tell them, give them a firm handshake and tell them something good. I feel something good is going to happen in the next 3 days. My name is O'Brien Kimani, and I'm joined by my colleague here.
Mimi jina langu ni Mashirima Kapombe. I am a news anchor for Citizen TV Kenya. Lakini kwa leo, mimi nitakuwa mfawidhi wenu. Mfawidhi kwa Kiswahili ni MC. Kwa hivyo mkisikia ninatumia hilo neno, leo mtatoka na neno moja ambalo mmejifunza, si ndio? Karibuni sana in this National Cancer Summit 2025 with the theme Uniting Our Voices and Taking Action.
My name is O'Brien Kimani. Hata mimi nitakuwa mfawili. Okay? So we are starting, and of course we are going to have our first panelist of the day in the next couple of minutes. I'm sorry we are running late. We are about 15 minutes behind schedule, but we'll try to catch up with time. We now want to start this session. Do we start with our national anthem or word of prayer? I'm told that we start with a word of prayer, and then we'll go to the national anthem. So please, let's be upstanding, and we'll welcome Father Charles to come and lead us in prayers. Thank you.
Jambo. I come from the Christian tradition, and in one of the Gospels, Jesus is asked, how come we were not able to drive out this spirit or this sickness? And he said, this type requires prayer and fasting. So it is good and inspiring that we start with prayer, because this is another type of disease that, yes, we will make effort, important policy formulations and actions, but as we start with prayer, because this is another type that needs prayer. Let us pray. God of Abraham, Isaac, and Jacob, we invoke your name this morning, realizing that we need you. We need your wisdom and intelligence in us and among us. As we come here to have conversation over the next 2 days, how we can drive out this spirit of cancer among us, drive it away, and create for us a healthy nation. We pray that our conversations for the next couple of days will be blessed and inspired. And we pray that everything that we shall have conversation around may be empowered by your spirit and may lead to action that is fruitful and lead to the well-being of our communities, especially those who are not well. And as we have conversation, we think of so many struggling with this illness, those in hospitals and in homes who have lost hope. And we pray that our gathering for the next couple of days will bring hope, will bring life to those who need it. And we ask you to bless us and bless all the undertakings and bless everything that we shall do. Amen.
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 We start with our national anthem. Let us please be upstanding for the national anthem. East African National Anthem.
Mungu twaomba uilinde Jumuiya Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde,
Asanteni sana, tunaweza kukaa.
Thank you very much.
And without much further ado, we would like to welcome to the stage Dr. Elias Meli, the CEO of the National Cancer Institute Kenya, to give his welcoming remarks. Karibu sana.
Let's give our hands to Dr. Meli.
Ladies and gentlemen, good morning. Can you wave at me? Good morning everyone, good morning. You are all welcome. Good to see you, good to see everybody seated, looking pretty and handsome. Our dear esteemed guests who have honored us by being here very early in the morning, participating in this second National Cancer Summit. We are very, very, very grateful to have you this morning and looking forward to a very successful second National Cancer Summit. Ladies and gentlemen, while many of our other participants and our esteemed guests will be joining us in due course, we really acknowledge you being here this morning. The Ministry of Health and the National Cancer Institute of Kenya, with all the stakeholders in this space, have jointly organized this second National Cancer Summit for one very simple reason. Let us have a conversation together, because we are facing a real challenge, which is not only health, but also a serious problem with socio-economic implication. I have one singular duty at this point in time to welcome all of you. We would like you to exploit all the opportunities that are going to present itself through our very esteemed, very experienced, distinguished speakers who have been lined up for these 3 days beginning yesterday. I am happy to recognize the chairperson of the Board of Trustees of the National Cancer Institute of Kenya. I'll just ask Dr. Timothy Olwen to rise up and just wave at us. I know he'll have an opportunity to speak to us as the program runs later. I also know that we have our partners, friends, and colleagues who've traveled far across the oceans, hills, and mountains to honor us with this National Cancer Summit. Ladies and gentlemen, I know that all of us have been affected in one way or another. I know we are here because we've chosen to face this challenge head on. I know you are here because all of us would want to make a difference. All of us would want to contribute positively in this conversation. And all of us would want to be engaged and to be involved based on our different unique capacities that we have, that we've been given an opportunity to serve, either from public sector, from private sector, or the community. We are here because of our friends and colleagues, who some of them, I refer to them as thrivers or champions. Can I see any of our cancer survivors who are here in this meeting this morning? If you may rise, please. Can we clap for them? Thank you. You may be seated. They are the reason why we have hope. They are the reasons why we wake up every morning. They are the reason why we know that whatever we are doing is not in vain. It surely bears results. I know we fight with an intention to win all the times. We may lose sometimes. But ultimately, we shall win the battle. We shall win the war. And that is why we are here today. So ladies and gentlemen, feel welcome by the entire fraternity of the Ministry of Health, of the National Cancer Institute of Kenya, and the government of Kenya. You are welcome, and I will allow our MCs to continue with the program. Thank you very much. May God bless you as you enjoy the rest of the day and 2 days ahead of us. God bless.
Asante sana, Dr. Meli. Thank you so much. I think he deserves a better clap than that. Now, very quickly, I would like to call onto the stage the KSG choir. They line up here and entertain us as we also prepare for the next, the first session that we will have here. This session will be our first panel for this summit, and we'll be focusing on a deeply rooted conversation, which is the role of culture, religion, and community in the fight against cancer. Now, we know that in many parts of our country, cultural beliefs and religious values shape how people understand illness, how they seek care, and how they cope. But within these same traditions lies great strength of hope, of unity, and of moral responsibility. Now, this session invites faith leaders, health workers, and community advocates to reflect with us on how we can bridge traditional beliefs with modern medicine and together create spaces of compassion, understanding, and timely action. And as the choir gets ready, I would like to call upon the panelists of this session, which will be chaired by Phoebe Ongadi, who is the Executive Director, the Kenyan Network of Cancer Organizations. Please come to the stage. On this panel, we'll also have Catherine Mashira, who's a member, Board of Trustees, National Cancer Institute of Kenya. She's also a legal practitioner and cancer advocate. Please come to the stage. Our third panelist is Robert Marine, Executive Director, Champions of Hope Kenya. Robert Marine is the founder and executive director of Champions of Hope Kenya, a CBO dedicated to supporting cancer patients with compassion and dignity. We also have Father Charles Chilufya, who very ably prayed for us this morning. Please welcome to the stage. He's from the Kenya Conference of Catholic Bishops, that's KCCB. As they make it to the stage, finally, we'll have Elvina Majiwa, who is the Executive Director, Health Conscious Africa, Kenya. Sheikh Mubarak Ahmed Awes, the head imam at Masjid Al-Huda. He's also a renowned Dawa scholar, East and Central Africa. And finally, Eunice Mwende Mutiso, founder and director, Chasing Hope Africa. She's a patient advocate, metastatic breast cancer thriver, and storyteller. Karibuni sana. KSG, take it away.
Usachame Tunga mira, mira, mira Tunga mira, mira, mira Rararisa mira, mira, mira. Tunga mira, mira, mira. Usachame. Usachame. Tunga mira, mira, mira. Tunga mira, mira, mira. Wakenya wote tegeni masikio, tunalo jambo lazima tukumbushane. Uhuru wetu tunaosherehekea ulipatikana kwa juhudi za wazalendo wa kale. Yetu tujitahidi usiku na mchana, mashambani na hata viwandani. Ajenda zote lazima kuzitimiza, na uchumi wetu upate kuimarika zaidi. Yetu yetu daima na milele. Oh yeah, 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 oh yeah. Tushangilie Kenya, watu wote. Oh yelele, yelele.
Well done. Makofi kwa KSG Choir. We now hand it over to Phoebe Ongadi for our first session. Karibu.
Thank you very much, Ms. Kapombe. Ladies and gentlemen, as we said before, for the second time in history, the National Cancer Institute is convening the Cancer Fraternity one more time under a powerful and unifying theme dubbed Uniting Our Voices and Taking Action. One more time, let us give it to the National Cancer Institute, not only for convening this session, but for giving the civil society the attention and the platform that we deserve. One more time, give it up for National Cancer Society, and give it up for yourself for making it early on time. My name is Phoebe Ongadi, representing the Kenya Network of Cancer Organizations. What has changed from the previous Cancer Summit is that now cancer is still the #3 leading cause of death in our country. However, behind those statistics are people, are communities, are systems, are networks that are convened before us today. And I just want to appreciate our panelists who are going to help us devolve into a session called Culture, Religion, Community and Equity Hub. We have with us Pastor Charles Chilufya, Kenya Conference of Catholic Bishops. Can you kindly clap for him as he waits? Just wave, thank you very much. We have Robert Marine, Executive Director of Champions of Hope Kenya. Kindly wave for Robert. Thank you very much. We have Elbina Majua. Just keep clapping, it's also healthy. Tomorrow you're the one we'll clap for here. Please clap for Elbina Majua, the ED for Health Conscious Africa. Please help me appreciate Eunice Mwende, the current holder of the Scars to Stars Season 1 and a patient champion. Thank you very much for joining us. And thank you. We also have Catherine Washira, a member of Board of Trustees NCI Kenya and a renowned cancer advocate. And I think there's one more. Yeah, Father Charles Chilufya from the Kenya Conference of Catholic Bishops. Thank you. And I'd like to start with you, Father Charles. We know that recently this country has been grappling with very low levels of HPV vaccination uptake among the girls. And until recently, it is good for the meeting to know that the Catholic Church came up boldly to support the vaccine that was rolled out by the Ministry of Health. So please, on behalf of the Catholic Church and on behalf of the Church in general, let us appreciate Father Charles and the fraternity for coming out boldly to say that they accept the vaccine and that the vaccine can be rolled out for girls, because cervical cancer is still the #1 leading cause of cancer deaths in women. So we want to ask you, Father Charles, what are the cultural, faith-based or community-led what are some of the most effective ways that faith-based organizations can help to support awareness? Some of the effective ways that the faith-based organizations can help to support awareness, having in mind that 70% of the cancer diagnoses in the country, they are actually diagnosed in late stage. Let us give it for Professor Anyang' Nyong'o, #1 advocate in Kenya, together with Mama Kisumu. Kindly please clap for them as they take their seats. Thank you so much. We appreciate you and we welcome you. So I will go back to the bishop, the Catholic bishop. What are the most effective ways that faith-based organization can support? And please, the media, help him address his microphone, especially on awareness and screening uptakes and also on stigma. What are some of the ways that the church can help us, considering that most of the cancer diagnosis in Kenya is happening at late stage, and usually once the diagnosis happens, we run to the church, we run to the bishop, we run to you. So what are some of the things that you can do? As we are saying, we are uniting our voices today and taking action.
Thank you very much. A very good morning to you once again. Yeah. That question really points to, there are various levels to look at here. We need to take action, yes, but we also need, from what you're saying there, to take care of perceptions, how people see things, yeah? How people look at certain things. And that's a mind thing. It's something that is in the worldview or in a person's way of looking at something. And you know, the mind can breed in a person positive things as well as negative things. If the thinking and the way of looking at something is negative or is blurred or is influenced by beliefs and customs that breed fear, that breed lack of trust, that person or people like that are not likely going to move in a positive direction. They say if you want to move people, move their hearts. So if people continue to believe that when they have cancer, they are cursed, or they are bewitched, or they are being punished by God, you know, that is a very big block in their lives. Then they will give up. They will tend to not do anything about what they are supposed to do. So one of the things that faith leaders and faith communities can do is to help the transformation of minds and the way they look at these things, yeah? Through various things, the preaching, the sermons, community organizations, to shape the minds, to really shape the minds that there's an issue here that we can confront. It is not divine retribution. It is not a curse, yeah? It is just a problem in our midst that with our faith and our moral voice and our calling, like Jesus for us who come from the Christian perspective, we are called to handle and to look at. Yeah. And in that case then, other than the shifting of the mindset, okay, what is important and what faith leaders and faith communities have leverage for is community organization. So that when we are faced with scourges like this, like for example, cancer, that we mobilize communities to say there's an issue here that we can look at together. So that mobilization of community, that bringing together of community to look at these issues will bring support to those who suffer individually so that they feel supported by communities, and also communities moving to want to address the issue. The last point related to all the points I've mentioned that is important is related to things like cancer and others is a question of stigma, yeah, especially when it comes to something like cervical cancer, yeah. So now, faith communities, faith leaders have leverage to change that, you know, to root out stigma, yeah, especially to raise hearts that are compassionate and have feeling for those who are suffering from cancer to avoid stigma. Thank you.
Thank you very much. And just on that, just continue with that, Robert, on the issue of stigma and the issue of perception and mindset. You have boldly spoken about the childhood. You're a childhood cancer survivor. You have boldly spoken about how the scars, the trauma, the perceptions, the stigma that you went through as a child, how it affected you. And just to share that Robert recently said he was able to overcome all that in his 40s, late 40s. That tells you how the magnitude of the fact if the psychosocial issues are not handled. So from your perception, Robert, just building on what Bishop has said, what are the gaps and strengths, and how can we bridge the gap, especially of psychosocial care in childhood cancer, to ensure that we are bringing up healthy individuals who are able to stand up for themselves in future, building up from what the Bishop said.
Thank you, Phoebe. Based on my childhood experience, I'm actually in my early 50s, Phoebe. So based on my childhood experience, I was diagnosed with non-Hodgkin's lymphoma, which is a blood cancer, in 1986, and it was during those days where childhood cancer was barely recognized. It was very, very traumatic for me, especially due to the fact that I had been admitted in the adult male ward. There wasn't a pediatric oncology ward at that time, and you can only imagine what I was seeing through the night, in the day, bodies being moved out, men crying in pain. Although eventually I was transferred to the general ward, I still remember that experience. One of the most difficult things that time was lack of emotional support. Something that really affected me, and especially when I went back to school. I was in standard 6 when I was diagnosed with the disease. And after I joined back to school, nobody used to understand what I was going through. I had loss of memory, loss of concentration due to the chemotherapy drugs. I did not understand personally what I was going through. My parents also did not understand, and neither did the teachers. But what happened at school is one thing that I'll never forget. It's the pain, the punishments, the beatings I received from the teachers. My self-esteem and confidence was stripped off when I was in primary school. Teachers thought I was pretending, I was just being playful or arrogant. It's something that made me lose my self-esteem, which I regained about 4 years ago. So for over 30 years, I lived an empty life, a life where I did not have an identity. So lack of emotional support during that time was quite heavy on me. It landed very heavily on me. Thank you.
Yeah, thank you very much for sharing. And indeed, it calls for action in childhood cancers that the psychosocial care is not an ask. It is mandatory to ensure that the awareness trickles down not only in the fraternity of healthcare, but also among the teachers and the caregivers. Just to take us back to the mosque a bit, even as Robert has shared that passionately, and I'd like to shake Marak, religious leaders are trusted. And when you check the Muslim community, you have very organized ways of teaching religion and organized ways of passing religion. So how can this interfaith coalition partner with the public health institutions that are already embedded in cancer to elevate and remove stigma, especially on issues? Because the civil society, we come in to bridge policy and implementation. What we see lagging behind, we come in to bridge that. And right now, we are lagging behind in early screening, lagging behind in prevention, lagging behind in early diagnosis. So Sheikh, how can that be embedded into the religious teachings and the gatherings that you're currently having?
Asante sana na niwatakia asubuhi njema nyote, na naomba nizungumze kwa lugha ya taifa. Bila shaka tunatambua kuwa Mungu ndiye aliyetuumba na huu mwili ametupa ni amana na ametuamrisha kuhifadhi na haufai kusababisha ya maradhi yoyote. Tunapokuja katika kuumbwa kwetu tupo namna mbili. Moja katika wale waliokuwa karibu na mtume wetu Muhammad sallallahu alaihi wasallam alikuwa anasema watu ni sampuli mbili, ima ni ndugu yako katika imani ama ni ndugu yako katika ubinadamu. Ukishajua kila mwanadamu ni ndugu yako katika binadamu, bila shaka unawajibika kushirikiana naye katika kuokoa maisha yake, na hasa kwa kuwa katika Qur'ani Mungu anatuambia yoyote ambaye kwamba ataua nafsi moja ni kama ameua nafsi zote ama watu wote, na yule ambaye kwamba atahuisha nafsi moja ni kama amehuisha nafsi zote. Kwa hivyo ikiwa hiyo ndo fadhila ama ubora wa kuweza kumsaidia mwanadamu na kumhuisha, na ukiokoa nafsi moja ni kama kuokoa zote, na sote ni ndugu katika binadamu, bila shaka kuna ushirikiano mkubwa ambao kwamba tunaweza kushirikiana kama viongozi wa dini kwa hakika kuhakikisha tumewatoa watu katika hali ya hofu kutokamana na maradhi kama haya. Na tunajua sote kuwa imani ina ushawishi mkubwa kuliko chochote, na mtu anaweza kumsikiliza kiongozi wake wa dini kuliko kumsikiliza hata daktari. Imani ina ushawishi mkubwa, lakini hii imani ndio imetuambia Mungu ameumba maradhi, ameumba ugonjwa, lakini ameumba na dawa vile vile, na ikatutaka vile vile tujitibu. Kwa hivyo tunaweza kushirikiana bila shaka kutokamana na facilities ambazo kwamba tunazo katika taasisi zetu za kidini, kuhakikisha vipi tutawajuza waumini kuwa hili lipo. Tutoke katika fikra ya kuwa hakuna kitu chaitwa kansa, na huu ni ushirikiano kati ya madaktari na mashirika ya kuuza dawa kwa ajili ya kufanya biashara. Vipi ataweza kujibidisha katika kujiuguza, bali kufuatilia kujua tatizo kabla ya kufikia hali ya hatari. Asante.
Asante sana. Kama bado umeshikilia hicho microphone, katika zile gatherings ama mikutano ya Kiislamu, unapata kwamba ni rahisi kuongelelea masuala ya saratani sana sana, kwa sababu tunaangalia kwamba watu vile umesema, we trust the religion, we trust the leaders. Are you free to talk about stigma kwa hizo mikutano, cervical cancer, breast cancer, prostate cancer, or is it a challenge? How is it in those gatherings? And do you see us also embedding, having maybe a National Cancer Institute, Ministry of Health, or the civil society coming in to help us alleviate especially the stigma that is still derailing us behind as far as cancer diagnosis is concerned?
Bila shaka tunazungumza nao kwa daraja zote. Yani wakati wa holidays tunakuwa na programs za youth ambao kwamba wamefungwa mashule, tunawaletea madaktari ambao kwamba wanawaeleza maradhi yaliyoko na namna gani watajikinga. Lakini vile vile tunakuwa na vyombo vya habari, kwa mfano tuna station ya TV, tuna vipindi ambavyo kwamba vinahusiana na swala la afya. Vile vile tunazungumzia kwa mapana swala la kansa na maradhi yote kwa ujumla. Kwa hivyo ni swala tunalishughulikia kwa wingi kwa sababu inatujalisha sana afya ya mwanadamu.
Asante sana. Vile ulivyosema umeketi karibu na Eunice Mwende ambaye nilisema ni the current holder of Scars to Stars season 1. Tafadhali mpigeni makofi tena bila wivu. She walked down the aisle as a young girl diagnosed with breast cancer. She became pregnant and she was able to deliver to the awe of even her oncologist. Eunice Mwende, as a young person, you know, diagnosed by cancer, what were some of these unique challenges that you came across in diagnosis, you know, socially, mentally, psychologically? What are the unique challenges that you'd like this gathering today on the second National Cancer Summit for the leaders, the practitioners, the policy makers who are seated here? What are the challenges that you came across that you'd like to be highlighted, especially in your diagnosis journey?
Thank you very much for your question. So as you've heard, I was diagnosed at a very young age, at 23 years old, with stage 0 breast cancer. And later on, this was in 2016, 3 years later, I got a recurrence and it was stage 4 breast cancer in 2019. So I've been living with stage 4 breast cancer since then. One of the challenges, I'll speak on both ends because I've lived as a patient or survivor who has been diagnosed with early stage cancer and also late stage cancer. So initially, and I think Father and Robert Marini have mentioned some of the challenges, the stigma which came with it. In our family, I'm the youngest in our family, and we don't have any known cases of any type of cancer within the family. So having a cancer diagnosis as 23 years old was a very, shocking experience for me and my family members. We even had to go for a second, third opinion to just make sure that it was the right diagnosis. So there was stigma around it because, there were questions. Why is it that me being the youngest, I'm the one who got it? Is it that I'm not eating right? Am I not exercising? Is it a curse, as the father has said? So these are some of the things I went through. There's the misconception of what causes cancer, and at that age, I did not want anybody to find out that I had this disease, especially after I had a single mastectomy, which is removal of the whole breast. So it was quite an intense time. I did go through body image challenges. My self-esteem was very low. At that time, I didn't have any insurance, including NHIF, and I had just started university. So as a family, we had to choose, do I continue with my university or divert the funds to go seek treatment? So at the same time, as I was battling this physical battle of the illness and the emotional part, the financial part as it, I was also looking at my career. I had to put that on pause since I had to stop studying. I also had to battle the social barriers which came with the diagnosis. I had to go seek treatment, meaning I could no longer socialize with my peers as I used to. So there was a lot of challenges which came with it and which caused a lot of loneliness and isolation. So the first 3 years of the cancer journey, I was really isolated and I didn't know where to seek support. At the moment, we have quite a number of support groups out here, but then I didn't know, so I had to walk this journey without any support per se. Because as I like saying it, sometimes you don't get it until you get it. So there are some challenges I might speak with a cancer survivor who will actually get it, And when I'm speaking to a family member, they won't quite get it as much as they would want to put themselves in my shoes. So there was the lack of knowledge as well. I did quite a few mistakes without knowing, the procedures of which screenings, which surgeries to do first, since I was very green at this. There was now the financial challenge which I've mentioned, and also the fear of a recurrence, the fear of having a shorter life, since by then I knew if you've been diagnosed by breast cancer, it's equal to death, or any type of cancer that is. So there was a lot of lack of knowledge.
Thank you very much for highlighting the lack of knowledge. And I'd come to you, Elvina, as a young person and as a young cancer advocate. How can the youth be involved in this policy making so that we close that gap? Because Eunice has said very well, for her, she found that there was a lot of gray area around her diagnosis and there was a knowledge gap. So how can the youth and the young people be involved, being a young person also into cancer prevention?
Yeah. Thank you so much, Phoebe. I'd like to start by appreciating the National Cancer Institute for giving young people a platform. It's not often that we're invited to tables and we are given a platform to speak. So as a tobacco control and health promotion champion, I believe the most urgent action that we should take is mobilizing. So mobilizing faith-based institutions, and I'm happy that I'm sandwiched between Sheikh and Father. So mobilizing faith-based institutions, civil society, patient champion to reject the tobacco industry. So tobacco smoking is one of the leading causes of cancer. And it's important for us to reject their influence in policy. So Kenya is a party to the World Health Organization Framework Convention on Tobacco Control. And this treaty has a section 5.3, which calls on government and institutions to reject the tobacco industry influence on policy. And by this I mean rejecting corporate social responsibility, or what they call corporate social investment, because this is a very big hindrance and to cancer. So that's one of the things that we should do. Totally reject the tobacco industry influence. Apart from that, it's important for us to incorporate tobacco control and cancer prevention messages in schools. So from the formative years, I know the Muslims do it a lot. From the formative years, young people are taught about the faith. So adults want to see Christian faith doing it. So incorporating those messages, so that young people from the get-go can understand why are we doing tobacco control, prevention and how it works. Those are just a few things we can do urgently.
Thank you so much, Elvina, for the work that you're doing, for the work we recognize the voices of the young people. Catherine, you've had all of them. We have the champions, we have the voices, we have the voices. Because you wear two hats, you wear a hat of NCI, you also wear the hat of civil society. So how can NCI bring all on board? So that our voices are heard, not only hearing, but into policy implementation.
Thank you, Phoebe. I think the best way to answer that question is by first giving. Let me just contrast something, and I want us all in the room to imagine this. It took most of us maybe between 30 minutes to 1 hour. There are those who came from outside Nairobi, slept in a hotel, so it still took them between 30 minutes to 1 hour to get here. When we go out there to do outreaches, there are people who walk literally. There are people who walk literally. Are we in agreement? Are there those in the room who agree with me? That literally people walk for a day to access services, for instance. So the best way, and what I'd say is we need to embed cultural and national cancer planning. How do we do this? Through community engagement. How do we do this? Through community engagement. This helps us and address the underlying address the underlying social determinants. You look at poverty in health. You look at limited education. You look at limited education. If we have a one-size-fits-all, in the cancer policy, then we may not be able to address some of the disparities, especially in the very vast areas like Kajiado, very vast areas where people, the example I gave, a woman walks a whole day to access that same woman has a 10-year-old child, same woman has a 10-year-old HPV vaccine, who needs the HPV vaccine, only to find the vaccine is not available. Only to find the vaccine is not available. What happens next? What happens? So it is really critical. So it is really for the national cancer planning, for the national cancer planning to involve community voices, patient community voices.
Thank you very much. A round of applause to our panelists. A round of applause to our panelists. Just for our parting shot, one more time, just for our parting shot, as we conclude, I start with you said that it is important for us to embed all the voices. As you sit there, you are having girls and boys behind you. You are having girls and boys for a moment. Speak for them for a moment. I want you to speak to them for a moment. Speak for them for a moment. Those young boys and girls policymakers and policy shapers to take home from this session. Policymakers and policy shapers to take home from this session. As we do our parting shot, very briefly, and then I'll come to Sheikh. You be preparing yours. Very briefly, and then I'll come to Sheikh. You be preparing yours.
Thank you for your
voice as well. As we conclude.
Thank you for your question. Before the parting, to just highlight is what I would also want to just highlight more than about 70% of the new cases are late stage, about 70% of the new cases are late stage, to just leave it out here, and I'd like to just tell you that you should not let us fall in the gaps. Just tell you that you should not as a stage 4 patient, we have not, as a stage 4 patient, it is very hard to access treatment because the private covers will not allow that. When I go to welfare in the hospital, they do not accept my application because I am in later stage of cancer. The cancer organization which support cancer treatment, the cancer organization which support cancer treatment do not accept again to support me because I have late stage cancer. And so I'm only the money in my pocket and the friends and family, the money in my pocket. So I would urge that we have health system that so I would urge that we have health system because it's not just me but we are so many in mind, because it's not just me but we are so many of us out here. So why not include us in this policy? So why not include us fight for our lives? In 2019, so that I was given 1 year for our lives. In 2019 and now, I have an 8-month-old baby. Between then and now, I have an 8-month-old baby. And I want to see her graduate. Please include us. So that now, for my parting, I am sitting here as living proof and trust. I am sitting here as living proof and trust proof that so many of us who are living proof that.
Thank you very much. Thank you, Mwende. Can you please appreciate her? Please, one more time. Mwende, can you please appreciate her? And I hope you have one more time. Please appreciate your journey. And I hope you have had it. Please include us. Thank you very much. Discrimination, heart, your parting shot. Thank you very much. In half a minute, your parting shot.
Kwetu tuna kitu kinaitwa wakfu. Upande wa mali ya usaidizi kwetu tuna kitu kinaitwa wakfu. Katika sampuli za mali ya usaidizi kinaitwa hidawa. Katika sampuli za mgonjwa tuna kitu kinaitwa hidawa. Watu wanafanya kama drama mbele yake. Kwa maana wanakuja watu kisha ni kama drama mbele yake kwa ajili ya kumpatia kitu fulani, kisha nikaweza kupona kutoka haya maradhi. Hii ni moja katika kupona kutoka haya na muunga mkono vile vile. Hii ni moja katika mchango wa afya na muunga mkono vile vile ni wizara ya afya katika mchango kwa sababu matibabu ni ghali ya kansa na wengi wanakufa si kwa sababu matibabu ni ghali ya kansa na wengi wanakufa si kwa sababu wa kujitibu.
Thank you. Asante sana. Makofi tafadhali to the Muslim community, and they are saying from now on zero stigma to the Muslim community, and they are saying saying from now on, zero stigma. Asante. Very briefly,
please
1 second.
Embrace us.
Yes, very briefly.
Please my parting shot would be, please embrace us. The policy process. Please involve us in partnership. The policy process. Please involve us in partnership. Help us reject the tobacco industry, which is aggressively help us reject the tobacco industry, emerging products, aggressively targeting young people. Have heard of with emerging products. They've heard of nicotine people have heard of, and these are some of the products of nicotine that the tobacco industry, and these are some of the products that the tobacco industry, and they're using glamorized ways of marketing these products. So help us glamorize such products, marketing these products. Reject the industry. So help us reject, push such products. Help us reject the industry.
Thank you very much. Include us, help us reject. Thank you, Father Charles, your parting shots. Thank you very much. Include us, help us reject. Thank you, Father Charles, your parting shots.
Issue of participation. Just to build upon the issue of we as faith leaders, Muslim, Christian, we as faith leaders, we have Muslim, we feel that call to respond to this. So we are on board, and it is important that we respond to this. So we are communion. And it is important that we keep just a parting word, communion. Faith leaders of all sorts, religious leaders, a parting word, important capital. Faith leaders, they have such leverage. Religious leaders are the things that capital dealing with. They have such leverage. I think it's good, like we are here dealing with. Not only for mediation with communities, good, like we are here to dialogue. Not only for mediation with communities, but also to dialogue. This voice also. When we are creating policy, to rebuild trust that has been broken, because it is important.
Thank you. It is possible to rebuild the trust that has been broken. Thank you, Robert. Thank you. It is possible to rebuild the trust that has been broken. Thank you, Robert. Yani summarize kabisa.
Please kindly allow me to say this so that it gets off my chest. 2 years ago, 39 years after a Form 4 boy who is currently fighting for his life right now in hospital. 2 years ago, was in a boarding Form 4 boy who is currently fighting for his life right now in hospital. Headmaster that was in a boarding, they'll take care of him. The parents were trying to insist for his headmaster, but the headmaster said no. Boarding, they'll take care of him. Cancer patients die at night, but the headmaster said, the case I'm handling right now, cancer patients, that boy right now is in emotional distress. The case I'm handling right now, so that boy right now is in emotional distress. This story is not about the headmaster. So it's about, it's not about, we have a voice in master. Childhood cancer survivorship. It's about, has not been, we have a voice as a childhood cancer survivorship. I would appeal to the NCI, Ministry of Health.
Yes.
We always hear every other time there are headmasters. I would appeal to the NCI, Ministry of Health.
Yes.
We always hear every other time there are headmasters. Space. Meetings in Mombasa, NCI, head teachers and all the relevant bodies. If you we could go and sensitize those teachers, those head teachers, so that they bring that knowledge down. We could go and sensitize those teachers.
Thank you very much. The knowledge needs to go to the teachers. Can you please clap for Robert one more time? Please. Thank you very much.
I see the MC on stage.
Yes. Can you please clap for Robert one more time? Please.
I see the MC on stage.
Yes.
So with community, less than a minute, with other stakeholders, meaningful engagement. Number 2, the patient voice must be in every conversation. With other stakeholders. Number 3, the patient's voice must be in every conversation. Number 3, cancer plans.
Thank you very much, ladies and gentlemen. One more time, if we say uniting our voices. Thank you very much, ladies and gentlemen. One more time, if we say uniting our voices. You say for the first time uniting our voices. We have been given the platform. This for the civil society, and for the first time National Cancer Institute, we have been given the platform. And of course, you will get to hear more. One more time, appreciate for us the National Cancer Institute, and of course, you will get to hear more because we are the first line of defense, and we are a voice. We are closer to the community, closer to the patients, closer to the systems, and we are a voice that cannot be ignored. Thank you very much.
We can do better than this. Let's clap. Let's give them a better clap.
Thank you so very much.
I mean, we can do better than this. Let's clap.
I can guarantee you
that.
Thank you so very much, including the chair.
We're going to hear moving testimonies, and of course, groundbreaking policies on how to address issues testimonies, and of course, groundbreaking policies on how to address issues around cancer. Go ahead, and so this is a platform for us to talk more about cancer. Please go ahead, you're encouraged. And of course, our slogan for the next 2 days is of Cancer Summit, and then your response should be uniting our voices and taking action. Let me see, and then your response should be Cancer Summit, our voices and taking action. Oh, you can do better than this. Cancer Summit. Oh, you can do better than this. And uniting our voices and taking action.
You say Cancer Summit.
And uniting our voices and taking action.
Cancer Summit.
All right.
And
Uniting our voices and taking action.
To welcome the next panelists on stage. Ladies and gentlemen, allow me now to welcome the next around
charting the next frontier.
We're going to
Policy
take us through a conversation
for
advancing cancer control.
charting the next frontier.
Policy
I want to invite
on stage
for
Dr.
Timothy
Advancing
Olwe.
Cancer Control.
He's the chair, board of trustees. I want to invite on stage
the
Dr.
National
Timothy
Cancer
Olwe
Institute
of
He's
Kenya.
the
Let's
chair,
put our
board
hands
of
together
trustees,
for Dr. Olweni. He's an experienced healthcare leadership and management professional with academic qualifications. He's an experienced healthcare leadership and management professional
and
with academic qualifications,
career
medical
spanning over
business
25
as well
years
as
in
the
the
public,
public,
private, and non-profit
and a cancer sectors
and career spanning over 25 years in the public, private, and non-profit. I also want to welcome Dr. Moturin Chomi. I also want to welcome Dr. Farmer International Area Head for Africa. Are you here with us? Is the Farmer International Area Head for Africa? Are you here with us? Let's put our hands together. He's the head of Africa at Roche, bringing over 30 years of global healthcare leadership. He's the head of Africa at Roche, bringing over 30 years of global healthcare leadership experience. Next, we have Marianne Otieno on stage. She's the Africa Public Affairs and Market Access Manager at Beckton Dixon. She's the Africa Public Affairs and Market Access Manager at Beckton. Let's put our hands together. She is the Africa Public Affairs and Market Access Manager at BD with over 15 years of experience. She is the Africa Public Affairs and Market Access Manager at BD with over 15 years of experience advancing health systems across sub-Saharan Africa. We also have Dr. Alan Pambla, Executive Vice President, Africa, Head of Sub-Region Dr. Alan Pamba, Executive Vice President, Africa, Head of Let's put our hands together for Sub-Region Pamba, Roche. He is the Executive Vice President, let's put our hands together Head of Sub-Region Pamba at Roche Diagnostics. He is the Executive Vice President, Africa, and Head of Sub-Region Africa at Roche Diagnostics. Leadership team and plays a central role. He is a member of the Roche Diagnostics Strategic Investment leadership team and plays a central role in driving. Then we have Dr. Gladwell Kiariu. Thank you very much. He's the President, Kenya Society of Hematology. Then we have Dr. Gladwell. Let's put our hands together. He's the President, Kenya Society of She's also a senior lecturer at the University of Nairobi with over hands together. 2 decades, 20 years. She's also a senior lecturer at the University of Nairobi with over research and education, please. 20 years of leadership in clinical oncology, research and education, please. Dr. Ali, take your position. And we also have Dr. Grigory Ganda. He's a county minister for health. We also have Dr. Grigory Ganda. Dr. Ari. He's a county minister. Let's put our hands together for Dr. Ari. He has led transformation initiatives, including the Maro Social Health Insurance Scheme. He has led transformation initiatives, including the Maro Social Health Insurance Scheme, leadership, which has influenced national policy and improved access to care reduction. And his leadership, Kisumu County achieved a 30% reduction. Thank you very much, mortality through integrated service. And finally, you have Dr. Tim Theuri. For your time. He's a Chief Executive Officer. And finally, Kenya have Dr. Tim Theuri. Dr. Tim Theuri is a strategic health leader and advocate for strengthening Kenya's health. Dr. Tim Theuri is a strategic health leader and advocate for strengthening Kenya's health system. Dr. Theuri, are you here with us twice this morning? I think he's getting late, but Dr. Theuri will join us later. So you are very well assured that we are in good hands, and so you are very well assured that we are in good hands through this conversation. The person who is going to take us through this conversation, Dr. Timothy Olweni. The conversation I told you is charting the next frontier policy priorities for advancing care control. The conversation I told you is charting the next frontier policy priorities for advancing care control in Kenya. Dr. Ari, please take the stage.
Good morning, ladies and gentlemen. I want to take this opportunity to welcome you all to this summit this morning. I want to take this opportunity to welcome you all to this summit, Professor Nyang' Nyong'o, and we owe as National Cancer Institute, we owe him a lot of gratitude, Professor Nyang' Nyong'o, and he was instrumental in as National Cancer Institute, we owe him a lot of formulation and birth of the National Cancer Institute while he was Minister for Health. So we owe you a lot of formulation and birth of the National Cancer Institute while he was Minister for Health. So we owe you a lot of gratitude, Prof.
Sorry, Chair, for stepping on your shoes. Allow me to also invite on stage Dr. Joanne Paula.
the head of National Cancer Control Program, Ministry of Health. Please, Dr. Paula, thank you very much, and I'm sorry for forgetting to. Joanne Paula is a seasoned medical doctor and a global health expert with over 20 years of experience in clinical care and system strengthening and healthcare leadership in Kenya. Thank you very much, Doctor. And we have Pauline Irongo. Where are you? She's the Director of Policy and Public Affairs at Pfizer, Sub-Saharan Africa. Please, let's put our hands together to Pauline. She's a globally recognized health policy and public affairs expert with a distinguished career spanning the biopharm sector and civil society. She currently serves as the Director of Policy and Public Affairs at Pfizer, Sub-Saharan Africa. Please, let's put our hands together for this seasoned team. Dr. Ari, please, it's your season.
Thank you very much. So I find it very appropriate that our session comes in after the one that came in earlier. The reason I say that is because we always have to be people-centric. We have to remember that what we are all engaged in is all about people and their lives. And therefore, it has to be about the patients and their family and their experience, and those examples we had here earlier, and the quality of life that they lead, and how they interact with our healthcare system along that patient journey. We have to make sure that our patients can access healthcare in line with the principles of universal health coverage, but also in line with, again, ethical principles, which can be cascaded even to policy. So even as we go through policy today, it has to be that that policy supports healthcare delivery at the individual healthcare level. So we have together a very good panel of specialists here. I think they've already been introduced. And I'd like to start with the questions. You know, healthcare is a devolved function, especially in our current constitutional dispensation. And the majority of care actually is delivered in the counties. And I'd like to start with Dr. Ganda. The question I have for you is, how is county policy aligned with the national policies, especially with respect to cancer and its management? And if there are any policy gaps, are there any changes you would recommend? And if there are any policy gaps, what would those gaps be in your perspective?
Thank you very much, Dr. Lueny, and I'll answer that question and move on and talk about what we're doing in Kisumu so that we save time. But, you know, the national government gives policies for this country. But we've always said that both national government and county governments are actually policy-making organs. And that means then that there must be a lot of interactions between the two, and I'm happy that you've recognized that. So the policy frameworks made by the national government is what everybody in the counties applies. And what we do in the counties is see how do you apply it. For example, some counties would prefer facility-based mechanisms. Others would prefer community-based mechanisms. You know, in the northeastern areas where facilities are not easy to come by, then their strategy would be different. So counties modify those strategies based on where they are. If you look at our policies, I think our policies were made in consultation with counties. The cancer policies that have come out actually have a lot of input from the counties. So I'd not say there's much for us to be able to change, but to learn from it and to review. But going back, policy has to be translated into action. And the biggest action we need to be able to do is what I call movement from illness to wellness. Our policies are very nice on paper when it comes to prevention and early detection. But on the ground, we talk more about treatment of diseases. If you look at the last 2 weeks, what's in the newspapers right now is billions of shillings sent to cancer centers to treat people who are sick. But you rarely hear anything about how much has been spent to screen and detect people early and prevent illnesses. I think I might leave that for now.
Thank you, but a follow-up question to that would be, in terms of partnerships, we can never have the kind of resources that we all require. So we have to leverage all the resources at our disposal, and that involves having very strategic partnerships with various partners and collaboration. So what kind of partnerships specifically in Kisumu County have you engaged in, and what have been the outcome in terms of those engagements?
Again, that's a very nice question. It is true. Healthcare is call it almost a bottomless pit. It can consume. And so many times you have to have strategic partnerships for you to be able to achieve your desires, because the amount of money that you're given is not enough. In Kisumu, we have leveraged a lot on these partnerships to prevent, to detect cancer early, and to treat cancers. Starting from prevention, one of the things that we've done is that we took advocacy very, very seriously. And one of the things that is happening, not only in Kisumu, but in the Lake Region Economic Bloc, is that the First Ladies Association has been very instrumental in trying to bring up the numbers and creating, and that has seen, if you look at the top 10 counties in terms of screening and treatment, then you will realize that they actually come from the LRIB region, and much of it is because of the advocacy that is being done by the First Ladies. But if you look at the First Ladies' advocacy, you realize there's an element of the National Cancer Control Program, because after they realized that this is a workforce, then they said that why don't we make a training curriculum that allows them to be able to know how to do the advocacy. And so you can see how partnerships between national, county governments have been helping in the advocacy. In terms of HPV screening, we have moved up in terms of HPV screening. We have two partners, particularly in Kisumu, who have really helped us, UNICEF and the Africa Cancer Foundation. And what we did is we realized that there are so many small pockets of people who are doing work, and we decided, why don't we all come together and screen these women? And so, and give them HPV vaccination. And so we had a very elaborate program using social media platforms, using young people, using schools, using the Ministry of Education to be able to bring back up those HPV vaccinations. I know we are not really doing the 90% that we would wish to be, but we've really moved up. We've almost tripled the amount of number of people who have been vaccinated in the county. Coming back to cervical cancer screening, which is a very important part, Kisumu has a population of around 150,000 women who need to be screened. We are screening around 30,000 every year, which means if we screen every person just once in the next 5 years, we should have been able to screen all the 250,000, but that's not the reality. Many of the people have HIV, so they're screened every time and many times, and so those numbers don't add up. So if you look at it, we have special programs which go community, and I want to point out Cure Cervical Cancer and some of the research organizations which we are working with. Through that, we've been able to screen almost 22,000. If you add what the research people are doing, that makes 27,000. That's around 30,000 women in Kisumu screened, house by house, moving sub-county by sub-county. And as I move towards the end, of course, before I talk about that, there's a very innovative program in breast screening. You realize that most of our women, we did a lot in terms of making sure that we have mammographs almost in the whole country, but nobody does them. There are very few. The one in Jaramogi does probably 5 women in a month. And so through Africa Cancer Foundation, we have a very innovative program, and we're doing fundraising for it to do mobile mammography, where we put a mammogram in a truck and go to the communities and be able to do mammography for these women, and we hope those will increase the numbers. Now, in terms of treatment, we have an MOU with the national government, which was signed when Kagwe was still the minister, to be able to set up the comprehensive cancer center. And in this center, then we must have the buildings done by the county government and the equipment done by the national government. That was then. I know Jaramogi now is being transitioned. But adding on to all these things, there is an advanced pathology lab that has been set up by the national government for histopathology to be able to help us to do pathology. And then we have the CHAMPS program, which has now brought it up to be able to do immunohistochemistry, which means the laboratory now in Kisumu is advanced to do pathology and screening. When it comes to the bunker and the cancer center, we moved away from trying to build it in pieces, and we are doing a turnkey project. Again, this is because of friendships with people like Electa Foundation, who were able to help us identify a number of people who can be able to do this, and we hope we should be able to deliver this in the next 1 year. So there are many other partnerships that I can talk about, but I've just highlighted a few that are making an impact already in the county. Thank you very much.
Thank you very much, for Dr. Ganda, for those insights as to what efforts you're making in Kisumu County. Thank you. Now, my next question is going to be to Dr. Maturin. You know, pharmaceutical companies, because of the aspect that we require pharmaceutical agents, of course, in management of cancer. I mean, one of the mainstays of cancer management. Access to these drugs, especially for cost and especially in low to middle income countries like ours, is restricted. So what kind of collaboration have you gone into, would you plan to go into with governments to be able to enhance access to these life-saving drugs?
Thank you very much. I would like to start maybe by thanking NCI for the opportunity to be here today, share our experience, and also learn from my peer here or the other session like the one we had earlier. I think the role of pharmaceutical company or diagnostic...
I'm not too sure they can all hear you.
Yes. To the role of pharmaceutical company to assure greater access to medicine, I think for us and for all the peers around this table, it starts by actually redefining our role as well, right? Because, and that's the step we at Roche, for example, have taken, right? To recognize that we have more that we can bring than supplying medicine, than responding to tenders. Is to recognize that we can bring a lot more with our experience, our capability, our resource to strengthen the system so that issues such as prevention, screening are dealt with. Because treating a patient with cancer late is not the outcome we should be going for. But catching that patient early enough allows that treatment gives the maximum chance to that patient to survive. And that's the context in which we at Roche Pharma or Diagnostic, as my colleague Alan will mention earlier, collaborate alongside government to bring solutions that ensure that our medicine and diagnostic solutions are available where it is needed. For example, in Kenya, we have signed 2 memorandum of understanding with the government of Kenya, the first one in 2022 and the second one early this year, where we ensure that our medicine for a specific type of cancer is available to all Kenyans, wherever they are, at that affordable price, which is covered by the Social Health Insurance Agency. Yeah. Thank you.
Thank you. And as a follow-up question, what long-term policy and partnership priorities are you working on so that we not only have these solutions, but they're sustainable and also scalable?
I would like to come back to the session we had earlier, right? When you see questions like stigma, questions like trust, questions like how people think about it, I think it requires going where the patients are. Right? It requires going at county level, it requires going at community level, it requires actually being part of the primary healthcare system, right? Because that's where the interventions should start from our experience. We are particularly proud that in Kenya, since 2019, we have been working with the counties to be where the population is, where the patients are, so that they can be caught earlier enough. As soon as we have that in place, and those patients are caught earlier enough, then they can receive the care that they require. Now, the evolution we see here and going forward, and the type of partnership we are working on now, including with NCI, is to make sure how do we get those information on the patient pathway? How do we get those information required to make decisions, required to understand how effective our intervention on the patient pathway? Hence, digitalization become one of the key, partnering around digitalization to have this understanding, to have this data become key. In Kenya right now, we are working with NCI and Savannah Global Health to be able to produce those data, those information on time, yeah, and hopefully being integrated in the national digital health strategy.
Thank you. Dr. Pamba, in the area of diagnostics, Again, are there any policy shifts or any policy changes that you would recommend so that we can be able to unlock access to diagnostics, and especially accurate diagnosis for patients is important, early and accurate diagnosis?
Thank you, Dr. Lwen, for that really important question. I'm going to try and raise my voice to wake everybody up. I woke up this morning at 2:30 a.m. to be here I was in Mombasa, and I thought I was sleepy, but my goodness, the room feels very sleepy. So let's bring some energy into this really important conversation. And to address that really important question you just asked, there are two key policy changes that we would like to see happening, not just in Kenya, but across Africa. I have to start by commending Kenya because on both fronts, we are already progressing quite a lot. The first one is anchoring diagnostics in policy. When I trained as a doctor, diagnostics was a nice to have. Get results from the lab. Many times they never correlated with the patient in front of me. 5, 6, 7 times, I stopped looking at them and I treated the patient. And there was still some sort of in the hospital. Now, we need a future where we have quality diagnostics. We had civil society saying that don't let patients get to stage 4 before we know they have cancer. And this impacts all of us, including us sitting here in the panel. So first policy is really anchoring diagnostics in policy. Kenya is lauded for launching the EDL 2023, the Essential Diagnostics List, right on the back of the World Health Assembly, recognizing the importance of diagnostics and encouraging countries to write their EDLs. So Kenya is way on track in terms of elevating the importance of diagnostics in achieving universal health coverage. The second policy is anchoring financing of diagnostics on the EDL in policy. So we have national health insurance schemes across Africa, different countries. We have Shisha here. We would like to see that the EDL is not just a list of tests that need to be done, but it's backed up by financing. That's what brings it alive. Those are the two key policies. As Roche, just to finish off on that question, we set up on a big ambition in the continent to increase the number of quality diagnostic tests we bring to the continent tenfold. We call it the 10X strategy. And we are very determined to work in partnership with governments, both here and across Africa, to realize that vision. Africa will not achieve universal health coverage without a strong diagnostics backbone. Cancer will not be beaten in Kenya or Africa without a strong diagnostic backbone to detect early and give people a chance. Thank you.
Thank you very much. And how about the aspect about the data and local evidence? How much, what role should that play in terms of shaping policy decisions around diagnostic integration into cancer care, and especially in low-resource countries like ours?
Just repeat the question again, please.
I'm saying the data and local evidence, what role should it play in shaping decisions around integrating diagnostics into cancer programs for treatment, and especially in low-resource settings?
No, data is very important. I think when a country moves to making decisions based on data, then you begin to get policies that reflect what is needed at this point in time in terms of the goals that the country has. And again, as a company, we're very invested in working with different stakeholder groups to drive data systems, integrated data systems that allow for that. I recently visited Rwanda, a very good example, and had an opportunity to see what they call their data war room. They have an integrated health system that brings the national statistics, national data, into one integrated platform. And you can, in real time, see how many cases you are diagnosing of malaria, of if there is an epidemic, Ebola, and where it's happening. And you can intervene very, very quickly. Now, it's taken a lot of effort and time and vision to build that, but it will pay off big time, because when you get into that data war room, you can see they have a grip on their health system. They just need to finance it and they can make the right decisions. Similarly, when I visited Dr. Gander in Kisumu, I was very impressed with the system they have for screening in the communities. They have, I'm really impressed by how they've mapped out these patients, where they are, when they are tested, the results coming in and the interventions that are needed. So anchoring our decisions on data, investing in data systems, is a very cost-efficient way of moving towards UHC.
Thank you very much. So, Marianne, I'd like to know from you what policy, again, changes you think, or any shifts that you might propose in terms of increasing or incentivizing investment in the oncology sector in Kenya.
Okay. First and foremost, I just want to thank NCI for the opportunity for BD to be able to be presented at this conference. And thank you, Dr. Lweni, for your question. I have two key points. I think there's need to prioritize public-private partnerships in diagnostics and early detection. In the previous panel, when they spoke about how 70% of the cases in Kenya that are diagnosed from cancer are at stage 3 or 4. And there's need for private sector to be able to support the ministries of health to be able to bridge that gap through through PPPs. And Dr. Ganda, I like the example that he said that there are many partners working in the same space, and he brought the partners together. So it's important that even as we sit here as private sector and other partners in the room, it's important for us to be able to pool resources since we have one common goal. So if we have strong frameworks for PPPs within the country, it makes it easier for private sector to be able to invest in those areas. Then the second point is on clear reimbursement pathways. And Kenya, I think, is leading with the introduction of the SHA, the Social Health Insurance Fund, that has put, there's a package for oncology, but there's also, they've gone a step further to be able to include screening as well in the public health fund, which is also very important for private sector, since when there's a clear pathway for reimbursement, it's easier for us to be able to put resources towards innovation. And lastly, it's around workforce development. So as private sector, we're very committed in being able to train healthcare workers, but there's need to be able to integrate this into the learning institutions, since there's a lot of investments and there's a lot of innovation that is currently happening in the diagnostics environment that needs to be translated down to the learning institutions as well, apart from the healthcare workers who are already in practice.
Thank you very much. Thank you. Dr. Kiarie, as the Kenya Society for Hematology and Oncology, you have, of course, play a leading role in terms of especially for policy formulation. And my question is about standardization of the treatment protocols. You do agree they are not necessarily standardized to the level that we would wish. And so what role would you play in terms of standardizing those protocols and guidelines, but also in terms of strengthening the workforce capacity so that we have got people out there, the workers who are empowered to be able to take care of our patients the way they should?
Thank you very much for that question. And first and foremost, Dr. Lweni, let me thank the organizers of the conference, because all minds need to be put together to be able to improve our outcomes in cancer treatment. Now, I'll begin by saying that professional bodies like ESHO must actually sort of get away from their traditional responsibilities of probably just doing research, coming out with protocols in their little centers, and become more innovative in becoming more influential and very tactical in policy making, especially in those questions you've asked me about, setting guidelines and so on. We need standard guidelines in sort of this devolved sort of healthcare platform. This ecosystem must treat all patients equitably. But that means that we need to translate all the research, all the data collection that we are doing into sort of innovating our guidelines to suit the Kenyan and African patient. And probably Pharma has spoken, the platform of, innovation in doing, in laboratory work as well, need all to be encompassed so that we can be able to standardize that and translate it to all our patients who are in Kwale, in Kisumu. Kisumu may be doing very well, and we thank the governor for that, but we need to uplift all the other centers to be able to do the same.
And where a professional body, for example, can help is in cancer mapping, because you'll see the cancer disease is different in regional centers, and therefore the allocation of some of these financial and capacity and so on need to be in line with some of these data collected. I'd hoped I'd hear from Pharma, from Dr. Pamba, about the integration of digital platforms and also artificial intelligence, which has become a very big thing, even in the practice of oncology. Teleconsults, because we're not going to be able to have equal pathology in Kwale, in Northeastern, and probably the benefit of devolution is that we're going to have state-of-art cancer centers in these regions. Are we going to make Northeastern the leader in treatment of esophageal cancer, make Kisumu the state-and-art center of treatment of cervical cancer? Are we going to make Mombasa the state-of-art center, for example, in treatment of gastric malignancies? And this can only be advised by cancer mapping, by this research, by participating of these professional bodies in policy making and advocacy, so that we have equitable distribution to be able to uplift the guidelines and adoption of the guidelines that you speak about. And also, you asked a very good question about partnerships with both international and regional bodies to be able to build capacity, send our people for training, and also enforce the adoption of these guidelines. And this goes across the board. Do we have quality workers in centers? Do we have quality drugs? Do we have adoption of policy? Do we have proper use of drugs? Do we have proper distribution of some of these drugs? We used to have what we used to call the KEMSA kit, for example. Are they equipping it with the proper common drugs that are going to be useful in these cancer centers? I also alluded to in one of our meetings about a recent journal article in the Lancet about the quality of drugs that Kenyans are using. And I challenge Pharma to partner with government and also to partner with our professional bodies so that we can set up standard labs to be able to be sure that our patients are getting the correct thing. The Lancet alluded to the fact that in 4 African countries, Kenya being one of them, the active pharmaceutical ingredient is only 17 to 20%. And a quarter of these drugs are actually usually out of use and they've expired. So are we also checking that to ensure that our outcomes are improved by having this quality care? So Kesho is very committed to improving accreditation and this capacity building and training, and be able to ensure that even the regional leadership that we have is equipped to continue doing all these. Public engagements, the list is very long, Dr. Oluenyi, and I think I'll stop at that in saying that Kesho is resolute in ensuring that all these bring good patient outcomes. Not only late disease, but also, are we having bad outcomes because our quality of care of these people who've presented late is not good enough? Thank you.
Thank you very much, Dr. Kiaria. My next question is going to be for Pauline. In your perspective, what strategic collaborations can we have between government and the private sector in order to enhance access and the quality and improve outcomes in line with UHC principles?
Thank you so much, Dr. Oluenyi, for that question. When I speak about partnerships, at the back of it, I want to think about health equity. And when we talk about health equity, if you read our documents, whether it's at global level guidelines that Kenya is a signatory to, or even our own local policies, like the national strategy, you will find equity as a core value. But how do we work towards equity? First of all, it's a really challenging thing to translate equity into action. And I've had a lot of people speak about partnerships. And I also had patients speak about the challenges that are linked to equity that they experience when they really underlined it, whether it's isolation, it's resources, it's being left out by the healthcare financing system, that it's only one institution that can accept a patient in late stage. So as we think about that, how do we work and play together whether it's private sector, government, civil society, and communities, to ensure that we can change the reality of our people. And therefore, public-private partnerships become really important and critical in the response to cancer. Government can't do it alone, neither can private sector. We bring different strengths. The government is really well positioned to define policy, to regulate, to think about how do we structure healthcare in our country. But private sector also comes with innovation. A lot of us sitting here from diagnostics, from pharmaceuticals, I represent pharmaceutical medicines and vaccines. What is it that we can do together with our governments to be able to bring help close to the people who need it, access to healthcare, so that we move it from being a privilege into a right, and we move it to something that people can really touch. It's one thing to write health equity, but how do we walk that journey? And I want to quickly just paint that really quickly. Recently, Pfizer launched a program. That initiative is called the Accord for a Healthier World. And I'm using it as an example of what can be done. I know there are so many other models. And that commitment is targeting 45 low-income countries and lower middle-income countries. And what we did is to enable access to every medicine or vaccine that we have on a not-for-profit basis for these countries. And not just current portfolio, but everything else that we will produce in the future, and that speaks to sustainability. We did that recognizing we've used other models in the past, but how do we become sustainable? Because the economics, the social determinants of health, they'll not change overnight. But patients, people, need services. And with that also, we need commitment from government. Donation is one thing, but we want financial commitment. Give me a second, and I'll wind it up. We want financial commitment, systems commitment by the government, so that as we bring in our models, our innovation, they can work. And therefore, with that sort of program, what we are looking at is long-term financial commitment by government, our own commitment to enable easier, more affordable access, and Dr. Kerry just spoke about the quality. We're a manufacturer, we're coming directly to these governments. We want to address the challenge of quality, because when you deal directly with manufacturers, some of the challenges that can come in between, to a certain extent, they are lessened. And as we walk through that journey, we also want an enabling environment, a strong regulatory environment, a strong policies environment that enables public-private partnerships to become a reality and a contributor to achieving UHC.
Thank you very much. And finally, Dr. Bor, could you just quickly highlight any key policy priorities that are currently guiding national efforts in cancer prevention and control from the ministry perspective?
Yes, thank you, Chair. And thank you for the invitation to be on this panel. Just to highlight the national priorities in terms of policy, I think some of the speakers here have mentioned the National Cancer Control Strategy, whose vision is a nation free from the preventable burden of cancer. So that just tells us that our main priority is in prevention, in line with the shift that the government is taking from curative to prevention and health promotion. As you know, most of our cancers, the top 5 cancers, are cancers that are preventable, either through primary prevention or secondary prevention. And I would say that our priority is, while ensuring equity in access and evidence-based intervention, we're focusing on primary and secondary prevention through strategies like the HPV vaccination and community awareness, tobacco control, and in terms of secondary prevention, screening for the high burden cancers that are actually screenable. We're looking at integration as a priority, integration of these cancer services in primary health care, which is a strategic priority for the ministry. I just want to mention, Dr. Lweni, that This year marks the end of the second year of implementation of the current National Cancer Control Strategy, which is our main framework guiding us as a nation on cancer control. And we did a review at the ministry and found that majority of the interventions that were targeted for the first and second year, actually they have been initiated, but few have been completed. Most of them are partially, they are on course, but they are partially done, which is a big challenge. We found overall that foundationally, we have made progress. We have a good foundation. Our risk is in implementation. And so let me just highlight 3 key strategic imperatives that we must all think about even as we are here. And these are the priorities. The first one is a sustainable financing framework. We need that. Secondly, we need to strengthen our health workforce and quality of care. And lastly, a unified data ecosystem. And if we get those right, then I think we'll be moving in the right direction. Thank you.
Thank you very much. Please join me in appreciating our eminent panelists. I know there are people with a vast experience, and they've just given us a snippet of what they would have liked to talk about, but I think it gives us a good basis for having discussions going forward. Thank you very much.
Oh, let's put our hands together for this team. What a beautiful, beautiful panel that we had this morning. And there's a team that is going to appreciate you as you walk out. And of course, they are going to be joined by the first panel that we had. So let's have Phoebe Onganda joining them, Catherine Washira, Robert Marine, Charles Chilufia, Elvin Majiwa, and finally, Sheikh Mbarak Ahmed and Eunice Mwende Mutiso. Please come over and get your gift pack as well. Ladies and gentlemen, we are about 5 minutes behind schedule. It's time now for tea break. Our chief guest is joining us shortly, so we need to have a quick tea break, and thereafter we should be back to that. We can continue with the official part of the for now we are taking a quick tea break, and then thereafter we are coming back at exactly 30 past. So we have about 10 minutes for tea, and then we'll continue with the program. Remember, this is the second National Cancer Summit, which is taking place here at the Edge. Please, ladies and gentlemen, walk out, have your cup of tea, cup of coffee, plus a bite, and you can also take a health break before we resume in the next 10 minutes. Thank you very much. The choir, meanwhile, be on standby. Once we are back, you're going to give us an item. Asante.
Now, the National Cancer Institute of Kenya, led by its chairman Timothy Olweni, is calling for stronger collaboration between national and county governments, researchers and the public to drive a more effective fight against cancer.
In terms of talking about the fragmentation that we have within our healthcare system in terms of how patients access care, it is important for us to dismantle those barriers in the cancer care ecosystem.
Cancer is the third highest cause of death in Kenya.
The Ministry of Health has identified 5 cancers as being responsible for over half of the cancers reported in the country annually.
1 in every 2 Kenyans diagnosed with any type of cancer succumbs to the disease in the same year of diagnosis. This means that less than 50% of cancer patients get fully treated. The Ministry of Health says the main cause for this is late diagnosis.
A third of cancers are actually caused by infections. And if we treat these infections very well, then we will prevent cancer. We cannot treat cancer comprehensively if we are struggling to treat malaria, diarrhea, diabetes, hypertension.
Now, the National Cancer Institute of Kenya, led by...
Welcome to the second National Cancer Summit here in Nairobi from 27th to 30th July 2025. The summit aims to advance cancer control by reviewing prevention and early detection in relation to UHC, emphasizing quality and accessibility of diagnostic services and improving access to effective treatment. It also seeks to promote collaboration, advocacy, and sustainable financing for equitable access and to strengthen multi-sectoral strategies to inform policies. This summit is more than just a meeting of minds. It's a testament to the unwavering spirit of humanity, our capacity for hope, and our collective determination to overcome even the greatest challenges. The journey ahead will be long and demanding, but with every step forward, we move closer to a future where cancer is no longer a death sentence, but a manageable disease or even a distant memory. We welcome you to Nairobi, a vibrant city and host to this year's summit. While you're here, we encourage you to experience the beauty of our city and explore the unique Nairobi National Park, a natural wonder just minutes from the urban center. Enjoy your stay.
Now, the National Cancer Institute of Kenya, led by its chairman, Timothy Olweni, is calling for stronger collaboration between national and county governments, researchers, and the public to drive a more effective fight against cancer.
In terms of talking about the fragmentation that we have within our healthcare system in terms of how patients access care, it is important for us to dismantle those barriers in the cancer care ecosystem.
Cancer is the third highest cause of death in Kenya.
The Ministry of Health has identified 5 cancers as being responsible for over half of the cancers reported in the country annually.
1 in every 2 Kenyans diagnosed with any type of cancer succumbs to the disease in the same year of diagnosis. This means that less than 50% of cancer patients get fully treated. The Ministry of Health says the main cause for this is late diagnosis.
A third of cancers are actually caused by infections. And if we treat these infections very well, then we will prevent cancer. We cannot treat cancer comprehensively if we are struggling to treat malaria, diarrhea, diabetes, hypertension. We definitely must make sure that our diagnostics are at the best at all levels.
Treatment is curative and manageable when cancer is caught early, and also the cost of treatment is not as high. For me, one thing I urge my people is let's go for screening when screening is called upon. Let's engage and have a conversation with all the stakeholders in the cancer space.
There is a lot of stigma in the society. We as the cancer survivors, we stand in the gap so that for those who are on with the treatment, when they see us, they really come out clearly to say that if Mercy has survived for the 20 years, I can also walk the journey.
National Cancer Institute of Kenya was established, and its mandate is cancer prevention and control. Cancer, we recognize that it can be treated with curable intention. Cancer can be prevented. Ministry of Health, by establishing National Cancer Institute and charged it with a mandate of, among many other functions, is prevention of cancer.
Tuko na chanjo kwa wasichana wetu wa miaka 9 mpaka miaka 15 kuzuia hawa kwa ugonjwa wa saratani. Ile HPV vaccine that is going to assist our girls in matters to do with cervical cancer. We have enough vaccines in Kenya to make sure that all our girls aged between the ages of 9 and 15 can be given those vaccines so that we can protect them from cervical cancer that is destroying and killing many girls and many women in the Republic of Kenya.
So ladies and gentlemen, it gives me great pleasure to launch our Cervical Cancer Awareness Month and the HPV screening.
Ladies and gentlemen, wapi makofi tafadhali. Wapi makofi. Oh yes indeed.
So we aspire and we intend through National Cancer Institute of Kenya to prevent cancer where possible. Where not, then we are called upon to advise on screening. We are screening people who potentially are not sick, and they could be having indolent disease, they could be having subclinical disease, that if we screen early, we may diagnose before it presents with symptoms. And if we do that, then definitely that means we can diagnose early and even treat with minimally invasive interventions, whether it is surgery, that then we can preserve organs with less morbidity or less toxicity in the event that we have to treat these patients with either chemotherapy or radiotherapy. National Cancer Institute of Kenya assists in technical advice in establishment of cancer diagnostic and treatment centers. We will come to your facility, whether at the county level or at the national level, and provide technical assistance to ensure that whatever center is being established, one, it is going to guarantee quality care. It is going to guarantee the right diagnosis and the right treatment. More often than not, we have lost the battle of treating cancer with curative intention if we don't get it right from diagnosis.
KUTRH is a highly specialized level 6 referral hospital, and our flagship project is oncology, cancer care.
I have mentioned again and again that we have so many mushrooming cancer centers across the country. And one of our roles is to provide standards and quality. We shall help you from a government perspective to make sure that when you go to a center, truly they have capacity across the continuum of care so that you do not get the wrong surgery for the wrong diagnosis. We have different modalities for diagnosing cancer. It could either be through laboratory diagnosis, through histopathology evaluation, or it could be imaging and radiology through CT scans and other modalities, including the most advanced one that we have within the country, PET CT scans, and many other that our country has enabled to be available in this country and even into the county governments to improve diagnosis of cancer. We are here from the Ministry of Health under the leadership of our Cabinet Secretary to increase the capacity for our county governments in provision of cancer care across the entire continuum of care. And we are happy that today we are here at Samburu County Referral Hospital for this very important activity where we have launched a cancer treatment center here. And it is not just about the launch, it is actually beginning with actual treatment. Today we have been able to treat 4 patients who have received treatment, and we've all witnessed, with prostate cancer and other different types of cancers on day 1.
We are here at the Lodwar County Referral Hospital to launch a clinic or a center for the treatment and diagnosis of cancer cases here in Turkana County.
Part of our initiatives towards reducing the burden of cancer in our country is to increase access to treatment and diagnosis and treatment of cancer for our patients. We are happy that the patients will not have to travel very far, they will not have to incur the cost, and they will get treatment right here close home, and by evening they should go back home. We are happy we are making commitment, while our first patients today have actually received treatment here. So we did not come with promises that we will come and set up a center, but we have come walking the talk, and this is because of the able leadership in the ministry and the institute to make sure when we visit, we shall leave a mark.
Kenyans can now access cancer treatment services at a much cheaper cost after Kenyatta University Teaching, Research and Referral Hospital received a cancer treatment machine. The machine will facilitate painless, non-invasive procedures on prostate, liver, lung, breast and brain cancers, among others.
This event is therefore a true milestone in our national healthcare journey, because we are here to launch a center which represents the convergence of high standards of treatment, state-of-the-art technology, affordability and effectiveness in cancer treatment. Kenyatta University Teaching, Research and Referral Hospital will deploy an advanced robotic radiation treatment machine known as the CyberKnife, which introduces revolutionary capabilities and enhanced efficacy in cancer treatment by locating, tracking, and accessing tumors that are ordinarily difficult to reach with precision. Again, I agree. Now we will move to CyberKnife precision. The technology is therefore able to administer more radiation with great precision, meaning that fewer sessions, maybe 4 to 5 only, instead of 20 to 30, are required, with each session lasting only between 5 and 15 minutes. This will significantly improve treatment outcomes and be able to deliver these services better, affordably, and much more effectively. Cumulatively, these advantages lead to shorter recovery period, minimal side effects, and better overall outcomes. The government therefore intends to sustain its investment and support for highly advanced diagnostic and treatment equipment to actualize the highest standard of treatment and care for all people. The CyberKnife technology at this hospital is the second in our continent, the only other being in Egypt. This propels Kenya to the frontier of advanced medical technologies and catalyzes our strategy to quickly emerge as an advanced regional and international medical hub. Its location is in a public hospital sends a strong signal to all Kenyans that it is no longer necessary to travel far away for advanced treatment that are now available, accessible, and affordable in our public hospitals.
What we've done as government is that we have cascaded the issue of early testing to the county level. And that earlier testing from the county level will involve centers that we've developed. At the moment, we've developed around 4 cancer centers, regional centers.
We therefore encourage Kenyans to utilize our diagnostic and treatment services within the country. There isn't much need to travel abroad now for treatment as it has been before. We have the latest of equipment, including CyberKnife, including PET scan for diagnosis, including surgical treatments that are so minimally invasive and treats cancer, laparoscopic surgeries, which our fellow homegrown trained and also international trained healthcare workers are able to deliver right here back at home through our centers of excellence within our regions and the national hospitals that our country has established. We are also interested that in the care that we provide is quality across the entire continuum of care, and we wish to assure the public that whatever care you will get from prevention, National Cancer Institute of Kenya is interested to know what is the quality. So we are inspecting, certifying and designating cancer centers based on established guidelines that are internally and externally validated, that was contributed in its formulation and development by the users themselves and the stakeholders to guarantee quality of care at all times. In our country, the capacity has increased immensely over the last 10 years. And almost every county, through the MES program, almost every county now has increased capacity in diagnosis. We almost have a CT scan in every county. Lately, through our strategies to improve cancer care in our country, we've been doing every county cancer action plan. And we have noticed most counties have CT scans capacity, because that's the basis of diagnosis on radiology and imaging. We have a challenge though in pathology. Where we have very few doctors in that area and we have very limited equipment and infrastructure. But certainly there is a lot of improvement. We are charged with another huge responsibility of capacity building. This is either informally through training of including community health promoters.
Na cha muhimu pia zaidi, screening ya cancer. Screening ya cancer. Elezeni watu wajue kwamba cancer screening si ya mtu mgonjwa. Cancer screening ni ya mtu mwenye ako na afya yake yote. Sawa sawa. Kama wewe saa hizi hauna homa, hauna headache, hauna kichote mbaya, wewe ndio mtu ambaye unafaa uende kwa screening. Ule mwenye ako na signs, huyo hasa ni screening tena. Huyo mtu ambaye anaenda kwa diagnosis. Sasa si screening. Screening ni ya watu ambao wako na afya yote vizuri, aende angaliwe kama labda kuna dalili yote ya cancer. So mtu asiseme kwamba bado hajagonjeka, sasa kwa hivyo haendi kupimwa cancer, aende kata screening.
WHO, has called on us to close the care gap, and we're really working on that. And the National Cancer Institute of Kenya, which is the agency mandated by Ministry of Health to reduce the burden of cancer in our country, is very strategic at this point in time. And I mentioned earlier on that we have a plan that we are implementing to the latter, called National Cancer Control Strategy 2023-2027. By the time this is implemented, with the support that the theme of this year is calling on nations to invest more resources. And we are really asking, the government through National Assembly to allocate more resources during budget making process to cancer, because it is one disease that is really terrorizing all of us. It terrorizes our social life, our economic life, our spiritual life, our physical lives, and people do not work. It's an economic issue as much as it's a physical issue. I would also wish to bring confidence to the public that National Cancer Institute of Kenya is committed and it is dedicated to deliver on its mandate to the latter. Because 10 years down the line, since NCI was established, it is an opportunity that we demonstrate to the public what capacity we have. And so much has happened and so much is still desired of the National Cancer Institute. We are building confidence to ensure that we solve our local problem. And the only way is one other key pillar, mandate, function that NCI has, which is cancer research. We are an institute, and the public is asking us to solve our local problems. For a long time, we have relied on foreign data to treat our patients, to diagnose our patients, to prevent some of these conditions. But we do recognize that genetically we are totally different. Clinical trials which were used to develop drugs, develop devices, develop equipment might not have included our local participants in Kenya, in East Africa, that we may share a particular genetic pattern. And therefore, we may undertreat or overtreat our patients because metabolism of these drugs, or also the densities of our tissues, if it is diagnosis, is different based on our genetic makeup. And therefore, we are coming strong at this point in time, confirming to the public that we have the right infrastructure now to conduct local research. We have identified our local gaps and we are going to look for solutions through research, cutthroat research for that matter, across the entire continuum of care. We have the National Cancer Control Strategy. This is a sector strategy that has been handed over to National Cancer Institute of Kenya to implement in totality, collaborating with other national agencies and also with other partners in private sector and within government, including county governments. It is costed at 49 billion. These are the resources that we are asking for the next 5 years to implement this National Cancer Control Strategy. Our mandate is huge. We promise that we will deliver on our mandate. We have the right governance structures to ensure there is transparency and accountability on the resources that are invested in cancer through resource mobilization from the partners and grants from the national government. We have an oversight body and we have also the Office of Auditor General that then looks at our financials every year to ensure that resources are prudently used towards cancer prevention and control. I would then wish to give Kenyans confidence that with the mandate NCI is being given, we are not leaving any stone unturned until we make sure that we reduce the burden of cancer in this country by making sure that we prevent most of the cancers so that the incidences can go down, or in the event that cancer is diagnosed, it be early so that when we offer treatment, it will be with curative intentions. And at the same time, we will ensure that morbidity, complications that occurs while going through treatment becomes less. We would want to widen the gap between those who are diagnosed and those who unfortunately we lose due to complications of cancer. You have our word we are going to address this cancer issue. We have all the support within the country and without. And we work with all partners. We are calling everybody to be responsible. We are calling everyone to play their part and ensure that together we are mobilizing all resources, financial and non-financial, to ensure that we reduce the burden of cancer. Thank you very much. May God bless you. Until next time, once again, my name is Dr. Elias Meli. I am the Acting Chief Executive Officer, National Cancer Institute of Kenya. Thank you.
Welcome to the second National Cancer Summit here in Nairobi from 27th to 30th July 2025. The summit aims to advance cancer control by reviewing prevention and early detection in relation to UHC, emphasizing quality and accessibility of diagnostic services and improving access to effective treatment. It also seeks to promote collaboration, advocacy, and sustainable financing for equitable access and to strengthen multi-sectoral strategies to inform policies. This summit is more than just a meeting of minds. It's a testament to the unwavering spirit of humanity, our capacity for hope, and our collective determination to overcome even the greatest challenges. The journey ahead will be long and demanding, but with every step forward, we move closer to a future where cancer is no longer a death sentence, but a manageable disease or even a distant memory. We welcome you to Nairobi, a vibrant city and host to this year's summit. While you're here, we encourage you to experience the beauty of our city and explore the unique Nairobi National Park, a natural wonder just minutes from the urban center. Enjoy your stay. Welcome to the second National Cancer Summit here in Nairobi from 27th to 30th July 2025. The summit aims to advance cancer control by reviewing prevention and early detection in relation to UHC, emphasizing quality and accessibility of diagnostic services and improving access to effective treatment. It also seeks to promote collaboration, advocacy, and sustainable financing for equitable access and to strengthen multi-sectoral strategies to inform policies. This summit is more than just a meeting of minds. It's a testament to the unwavering spirit of humanity, our capacity for hope, and our collective determination to overcome even the greatest challenges. The journey ahead will be long and demanding, but with every step forward, we move closer to a future where cancer is no longer a death sentence, but a manageable disease or even a distant memory. We welcome you to Nairobi, a vibrant city and host to this year's summit. While you're here, we encourage you to experience the beauty of our city and explore the unique Nairobi National Park, a natural wonder just minutes from the urban center. Enjoy your stay.
Having this empower is also enabling us to have that dashboard program whereby it can give us the entire detail of our patient from their registration, the time they have been seen from the first.
Africa. Africa. Africa, Africa, oh liberté. Africa, Africa, oh liberté. Nakomituna, nenge oyo ya bolingo toko mananani. Africa, nakomituna, nenge oyo ya bolingo toko mananani. Africa.
Wonderful, 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 wonderful.
Lokasa oyo ya bolinga winongai imalobe ate pasi. Africa, Africa, oh liberté.
Beautiful work there by KSG Choir. We just want to remind you that our chief guest, followed by his protocol, is going around the booth, and in the next 6 minutes we should be starting. Please, Mashirima, what do you have to say?
Bila shaka O'Brien, unajua ukifika hapa mbele unaweza kuzungumza kwa lugha ya Kiswahili ama lugha ya Kiingereza kulingana na vile ambavyo unajiona uko sawa sawa. Na muda mfupi kutoka sasa tutakuwa tunaingia kwenye sehemu yetu ya ufunguzi rasmi ya kongamano hili la pili la National Cancer Summit, Uniting Our Voices and Taking Action. Nikisema Uniting Our Voices, tunasema Taking Action. Uniting Our Voices, Uniting Our Voices. And in a few moments from now, our chief guest, the Prime Cabinet Secretary, Dr. Honorable Musalia Mudavadi, will be in the room, pamoja na the CS Ministry of Health, Honorable Aden Duale, together with other guests from the ministry. And in a short time, I think as we wait for those 3 minutes or so, the KSG choir can continue. And then once they come in, then we can kick off the program. Karibuni.
Africa, oh liberté. Aye, Africa, aye, Africa, oh liberté. Aye, aye, Africa, aye, Africa, oh liberté. Nege oyo ya bolingo toko mananani, Africa, nakomituna. Nege oyo ya bolingo toko mananani. Africa. Lokasa oyo ya bolinga winonga ina ekama u ate ipasi. Aye, Africa, aye, Africa, oh liberté. Aye, Africa, aye, Africa, oh liberté. Nakomituna nege oyo ya bolingo toko mananani. Africa, nakomituna nege oyo ya bolingo toko mananani. Africa. Lokasa oyo ya bolingo ngaina ate pasi. Aye, Africa, aye, Africa, oh liberté. Africa, aye, Africa, oh liberté. Nakomituna nege oyo ya bolingo toko mananani. Africa, nakomituna nege oyo ya bolingo toko mananani. Africa, dudum, dudum,
Africa mobimba, la baga chichu.
Kokoliko, kokokakuku kalari ranga koko Kokoliko, kokokakuku kalari ranga koko Ye koko Ye koko Petro yarira uwera senaku. O Petro yarira uwera senaku. O Petro yarira uwera senaku. yako ulayalile kanire Yesu Kokoliko, koko kakuku kalaranga, koko
Now, the National Cancer Institute of Kenya, led by its chairman Timothy Olweni, is calling for stronger collaboration between national and county governments, researchers and the public to drive a more effective fight against cancer.
In terms of talking about the fragmentation that we have within our healthcare system, in terms of how patients access care, it is important for us to dismantle those barriers in the cancer care ecosystem.
Cancer is the third highest cause of death in Kenya.
The Ministry of Health has identified 5 cancers as being responsible for over half of the cancers reported in the country annually.
1 in every 2 Kenyans diagnosed with any type of cancer succumbs to the disease in the same year of diagnosis. This means that less than 50% of cancer patients get fully treated. The Ministry of Health says the main cause for this is late diagnosis.
A third of cancers are actually caused by infections. And if we treat these infections very well, then we will prevent cancer. We cannot treat cancer comprehensively if we are struggling to treat malaria, diarrhea, diabetes, hypertension. We definitely must make sure that our diagnostics are at the best at all levels.
Treatment is curative and manageable when cancer is caught early, and also the cost of treatment
yes, my name
is
is
not
Lucy
as
Jerry,
high.
and I'm a very big noise
For
in
me,
the cancer space.
one thing I urge my people is let's go for screening when screening is called upon. Let's engage and have a conversation with all the stakeholders in the cancer space.
There is a lot of stigma in the society. We as the cancer survivors, we stand in the gap so that for those who are
cancer survivors, cancer champions, thrivers. Hey, Dr. Nashat is one of us nowadays. Karibu. We are going to dance here. Marine and caregivers. Janice. Please come. I'm not coming for you. Please come. Nimekuja kusema asante.
Kuja kusema asante. Nimekuja kusema asante. Asante kwa wema wako na fadhili zako Baba. Nimekuja kusema asante. Mimi nimekuja kusema asante. Nimekuja kusema asante. Sema asante. Asante.
kushukuru, nafsi yangu ya kuhimidi Baba.
Nimekuja kusema asante
kwa fadhili zako na wema wako.
Nimekuja kusema
asante, asante,
asante, asante. Nimekuja kusema asante, asante, asante,
National Cancer Institute established, and its mandate is cancer prevention and control. Cancer, we recognize that it can be treated with curable intention.
Siwasiki, sema kwa sauti ya sasa.
This is a show of treatment is working, early detection saves life. And our doctors are up to task. Nobody has gone for treatment outside Kenya. Most of us here have got our treatment either in KNH, KU, TR8, Jaramogi, Oginga. So, big up people. Thank you so much. And Mama Kisumu is a witness to that. Our only plea, our only ask before we sit down, access to medicine. Our only plea.
Thank you.
And
Thank
another
you.
thing, please, the radiotherapy machine. The backlog at KU and at KNH.
Asante
we
sana.
want to have a bigger number next time. Thank you so much.
Asante sana. Let's give our hands together to the cancer champions choir.
And as we remain upstanding and transition into the high-level session, kindly let's have the national anthem and the East African anthem.
Mungu nguvu yetu, ilete baraka kwetu, haki iwe ngao na mlinzi, na tukae na udugu, amani na uhuru, na watu pate na ustawi. Mungu twaomba unilinde Jumuiya Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tulilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Asanteni sana. Please let's be seated. And we now want to call on stage Dr. Elias Meli, the CEO of the National Cancer Institute of Kenya, tumpigie makofi as we kick off the opening ceremony. Karibu.
Thank you very much. And as he comes to stage, the KSG choir, please do that one item, and third to welcome the CEO.
Umbomizi bora wa mama, hava vangu ndayanza. Oh, umbomizi bora wa mama, hava vangu ndayanza. Zibora, onyayo yumanza, hava vangu ndayanza. Umomi msalia karibi, angala ucheze kidogo. Salia, umomi msalia karima, hava. Umomi gavana karibi, hava vangu ndayanza. mwana wa mama. Gavana, gavana, karibu baba, baba bangu ndayanza. Ogomi duale wetu, ababangu ndayanza. Duale, ogomi duale wa mama. Ego ngabiswa, zibora ngabiswa, zibora ngabiswa. Ego ngabiswa, msala ngabiswa, ego ngabiswa, msala ngabiswa, ego ngabiswa, namabega ngabiswa, ego ngabiswa. Gongabisa, gavana wetu gongabisa, Eduale ho, ongera kwako baba, tunakuona unang'ara-ng'ara, ongera msalia, Mungu akuongoze, baba, ongera gavana wetu, ongera gavana wetu. Shwa, shwa. Thank you.
Thank you very much indeed. Let's put our hands together for the KSG choir as we put our hands together as well to welcome Dr. Meli, the acting CEO at National Cancer Institute of Kenya. Thank you very much. Welcome.
Our chief guest for the second National Cancer Summit, His Excellency Dr. Musalia Mudavadi, our Cabinet Secretary of Health, Honorable Haden Duale, our board chair of the National Cancer Institute of Kenya, Council of Governors represented by our able Governor Anyang' Nyong'o, our PS Medical Services, PSS present, distinguished guests, ladies and gentlemen, you are all welcome to the National Cancer Summit. We are glad that you honored to participate in this meeting. His Excellency PCS, the National Cancer Institute of Kenya, and all the stakeholders under the leadership of our Cabinet Secretary, Ministry of Health, have brought together all the stakeholders in the entire cancer ecosystem within the country and without, who have been supporting the initiatives in this cancer space, working towards one vision, to have a cancer-free Kenya. Currently, we are burdened by rising cases of cancer with over 44,000 new cases every year and more than 28,000 deaths every year. We're going straight into the program. We do recognize that our Prime Cabinet Secretary and our Cabinet Secretary of Health and all the distinguished guests who are here have a very busy schedule. Allow me at this point to ask us to listen to a 5 minutes short clip from one of our esteemed guests who could not make it because of unavoidable circumstances. And this is Dr. Julie Grallo, who is the Chief Medical Officer, American Society of Clinical Oncology, who has partnered with us in a lot of initiatives in the past. Media team, kindly.
Hello, I'm Dr. Julie Graylow, the Chief Medical Officer of the American Society of Clinical Oncology. I appreciate the invitation to speak at this important 2025 National Cancer Summit hosted by the NCI Kenya, and I'm so sorry that I can't be with you today. I understand your theme is uniting our voices and taking action, so I'd like to talk about how we might better unite our voices and take action together. We've been discussing this with the NCI Kenya for a while now. Over on the left, you'll see my visit to the offices of the NCI Kenya back at the end of 2024. And then the NCI Kenya staff, including Dr. Melli, joined us at our ASCO annual meeting in Chicago just this past June. I'll tell you a little bit about ASCO as an organization to set the background, since you might not all know about us. We are a professional society of doctors and clinicians treating patients with cancer. We have over 50,000 members in more than 170 countries, and our international membership is about 40%. We've made, in the last couple of years, ASCO membership free in low and lower middle income countries. This is our 5-year strategic plan. Our mission is conquering cancer through research, education, and promotion of the highest quality patient care. And our vision is a world where cancer is prevented or cured and every survivor is healthy. I think we're already united in our voice that this should be our shared mission and vision. Our 5-year goals are that over 5 years we're going to advance global access to cancer care and research, develop more sustainable work environments, and improve the delivery of information that drives better patient outcomes. And we'll do that in 3 pillars: access to care and research, profession, and knowledge. In order to better serve our international members, we formed regional councils with members from regions to better inform us of what ASCO programs, projects, and services might be tailored to fit the given regions. We formed our Sub-Saharan Africa Regional Council in 2022. And this shows the makeup at present of our regional council. Members rotate through. Your current Kenya Regional Council member is Dr. Sitna Mwanzi, and if you want to be connected, you can email regionalcouncil@asco.org and we'll connect you with your regional council members. I thought I'd spend the rest of this talk talking about ASCO's global efforts to improve cancer care, 4 major focus areas where we can talk about how we might partner with NCI Kenya and the country of Kenya more broadly for partnership and collaboration. And those include quality care, education and training, clinical research, and leadership development. Let's start with quality care. ASCO helps define what quality care is through our quality programs. And we have a new ASCO certified program in patient-centered cancer care that has 7 primary domains. And we've just this week updated with a few more domains that you can see over on the left. Those 7 key primary domains that revolve around patient-centered care are patient engagement, availability and access to care, evidence-based medicine, comprehensive team-based care, quality improvement that's continuous and monitored, goals of care and palliative and end-of-life care discussions, and anti-neoplastic therapy administration safety. You can look up these standards as well as the new topics that have just been updated at asco.org/standards. We have LMIC quality projects in partnership with ASCO ongoing in Uganda and Honduras, and we have an MOU with the World Health Organization on quality care and delivery of quality care as well.
Thank you very much. That is an introduction of the partnership that we've had with American Society of Clinical Oncologists, our Prime Cabinet Secretary, and our CS. A lot of work that we are doing within the country and without to strengthen the cancer initiatives in the best interest of preventing cancer in this country and also treating well those who unfortunately get diagnosed with cancer. Allow me, our Prime Cabinet Secretary and our CS, to acknowledge the Board of Trustees of the National Cancer Institute of Kenya as I invite the chair to take over the program from here. We have Board of Trustees and the staff from the National Cancer Institute of Kenya. We also have guests from the US Embassy. We have guests from World Health Organization. In the interest of time, we may not be able to have them address us this morning. Kindly, the chair of the Board of Trustees of the National Cancer Institute.
Yes, morning again, everyone. Welcome again to the Chief Guest, the Prime CS, the Cabinet Secretary for Health, and all the dignitaries. All protocols observed. At this point, I'd like to welcome the Group CEO of AMREF, Dr. Githinji Gitai, who also happens to be my predecessor in this position. He was a former chair of the National Cancer Institute, to give us a few remarks. Thank you.
Well, thank you very much, Chair NCI, my brother and friend for a long time, Dr. Olweni, Excellency, Prime Cabinet Secretary, CS Health, Adendole, PS of Health, Oluga, the Governor of Kisumu, who's been a great champion of this cause, and the First Lady as well, and Prime Cabinet Secretary. I remember when we hosted the first National Cancer Summit. That was February 2nd, 2023. The Governor of Kisumu and the First Lady were also present. That was the inaugural one. And they did make remarks from their personal experiences and also in terms of the governance and the leadership that Kisumu has been showing. Allow me to make very, very quick remarks because I know how tight this program is. First, in 2023, when I was the chair of the National Cancer Institute, we were asking ourselves, and I must thank the board that continues to support the Board of Trustees, the chair, and the CEO, Dr. Meli, for continuing this agenda. Thank you very, very much. We asked ourselves, as the National Cancer Institute, which is an agency of the national government under the Ministry of Health, what is our role? Because ideally we know that there are many convenings that happen at technical level. Researchers do meet. We know that clinicians do meet. We know that industry, that's represented here by our sponsors, and we thank you most sincerely for enabling this to continue, also have, convenings to discuss what they need to do. We know that palliative care, patient groups, all these people meet. But we said that our biggest role at the National Cancer Institute was to bring all these voices together so that we could actually inspire change and collaboration. So that's why we founded the National Cancer Institute, and we held the first one on 2nd to 4th of February 2023. That has now happened, and this is the second one, so it makes me very proud, PCS and CS, to have been invited back here, because it means that when I left in good stead. Otherwise, they would not have invited me to come back. So thank you very, very much. I'll leave just two very quick points. That if you look at the burden of cancer in this country, the CEO, Dr. Meli, has talked about the numbers. We know the numbers. I don't have to recite those. It is significant. And this is not only in Kenya, it's across the continent of Africa. The one thing we must ask ourselves is it affordable to actually provide good, equitable, accessible care to that burden? The Kenya government is doing a whole lot. And we must thank the government for the efforts that have been mentioned here by those who have had, this burden, have suffered this burden. But when you look at the fiscal space, the available money, and you look at our structure of health financing, we would need about $1 billion, Cabinet Secretary, in my view, and PCS, to actually take care of everyone who needs to be taken care of, the screening, the prevention, and the care and treatment needed at our current burden. I would estimate that at about $1 billion. That's about more than 100 billion shillings, which is close to a quarter of our health expenditure generally, which is unaffordable in a country whose GDP and population and the tax collection is as it is right now. We have to face the reality that the fiscal space is low. And also knowing that the donors, and I talked about this in the first summit, the donors do not support the non-communicable disease sector, largely because most of the donor aid that we know that's now declining is actually driven by what we call global health security. It is the disease you have, let me keep it away from my people. That's really what drives the global health security. Of course, we have partners who've stuck with us, and that's the private sector in this area, and we thank them. But we know that the development assistance in the multilateral structure is guided by global health security. So the cancer care of hypertension and diabetes is a national agenda. It's not going to be anyone else's agenda. We'll not have an international cancer fund that funds our cancer care. Now, when you look at that, and you look at the expenditure that's needed, I then conclude that the only way we can take care of this burden is actually to focus on the low-hanging fruits, which are in prevention, early screening, and ensuring we downstage our cancers. Prime Cabinet Secretary, 70 to 80% of our cancers come at stage 3 and 4. And therefore, the cost of care is what brings me to that 100 billion Kenya shillings. But if you are to actually reduce and downstage through several things, I'll just say a few and then I'll hand over back to the chair. One is that we need to ensure that we spend money on early screening through the Social Health Authority, early screening, and ensuring we have early diagnosis and early treatment. That will bring down our cost of care significantly. It's possible. Number two, and that should cut across all the cancers. Number two is to ensure that we decentralize care, and that's what we've been trying to do with the National Cancer Institute when I was there, and I'm sure it's still doing the same to ensure the counties are a critical part of basic cancer care. Number three is to ensure that we actually achieve 70 to 80% of HPV vaccination of young girls. If we don't do that, our burden of cervical cancer will continue to increase. I know the Kenya government has been doing a lot, but we need to target at least 80% of all girls before 14 years. And this needs community participation and school-based programs for us to achieve. The final thing, on many of the other cancers, and I know there are many experts here, so I'll not speak on their behalf, that cancers like breast cancer, colorectal and all these are also related to diets. I know that the WHO has put guidelines on control of industrial trans fats and hydrogenated oils. But Kenya has never really moved forward to implement the 2 grams for 100 grams of intake that would actually reduce the consumption of industrial trans fats to start making gains on these other cancers like breast cancer, prostate, and colorectal. There is enough brains here to assist us and Ministry of Health and the government to make sure that Kenya becomes one of the 3 states in Africa that will have implemented the WHO recommendation control of industrial trans fats. I want to end there and say that I really celebrate the presence of communities here, the communities that have been working with all of us on the advocacy for ending and reducing the burden of cancer. This is the reason the summit is here, to bring every single voice together. Thank you very much, and I thank you, and thank you, Excellencies. Thank you.
Thank you very much, Dr. Gitai, for sharing those insights both from a local and a global level. At this stage, I'd like to welcome the Principal Secretary in the State Department for Medical Services, Dr. Uma Oluga, to come and address the gathering. Thank you.
To the Prime Cabinet Secretary, His Excellency Musalia Mudavadi, Cabinet Secretary for Health, Honorable Aden Duale, colleague PSS present, the Chair of the National Cancer Institute, Governor of Kisumu, colleague doctors, partners, good morning. PCS and CS, mine is very short. It's just to recognize my colleague PSS who had come to this summit because we have employed a whole of government approach, particularly on issues of public awareness, education, and also interventions that relate to prevention and early detection. And with your indulgence, PCS and CS, you'd allow me just to call my 3 PSS colleagues just to have 1 minute each to address us, and then I will give only 3 minutes to Professor Shaukat, who is the Principal Secretary for Science, Innovation and Research, particularly because of his role in the International Atomic Energy Agency, where he is just left, and particularly in his role in the acquisition of 2 Linac machines that has enabled us to operationalize 2 cancer centers. So I will start with my colleague PS Liban, who is the PS for petroleum, just to make very quick remarks in a minute, and then PS Salome Biako.
Prime Cabinet Secretary, His Excellency, CS Dwale, colleagues, PSS, invited guests, good morning. My name is Mohammed Liban. I'm the PS for Petroleum in the Ministry of Energy and Petroleum. I'm honored to be here, to be invited by my colleagues, because I'm dealing with petroleum, the diesel, the petrol, and also the jetty. These are hazardous products. If not taken care of, it can cause a lot of damage. Because at the ministry level, we are working at upstream. That is where we are doing exploration and also production of oil and gas. Care has to be put in place to ensure that there is safety when we are using that. At the same time also, we are doing security of supply, because petroleum is an enabler to the economy. We need it, for manufacturing. We need it for transport. We need it for roads. We need it for energy. But safety and security has to be put in place to make sure that our country is safe. So having said this, because once we are doing, our daily programs, especially in exploration, we ensure that oil and gas is found, underneath. And it's a mixture of also elements, like lead, like also mercury, which is hazardous, to the health. So the State Department, we are monitoring, we have a State Department to ensure that whatever we are doing, we make sure that environment is safe to all Kenyans as moving forward. Having said this, cancer, when I'm talking about cancer, especially Ministry of Health, we have 3 levels of treatment: the primary, secondary, and tertiary. Primary prevention is where the disease has not occurred. And that is very critical, because the screening of cancer and other diseases will be very, very crucial. And I thank, the Ministry of Health, by bringing up, the community health promoters is very key, because that is the areas where we can actually detect and ensure that this disease will not progress to other. So, second level of prevention is where disease has occurred. That is, we are supposed to look at our infrastructure from level 2, 3 up to tertiary level, the affordability, the accessibility to Kenyan people. I think that is a big task for Ministry of Health. And then the third level of prevention is palliative care. All is not lost. Once the disease occurs, then we are supposed, to take care of our people who are actually taken care of. To conclude it, when we attained, our independence, the government was fighting with 3 conditions: poverty, ignorance, and disease. At that time, we were dealing, with preventable diseases, which is gone. Now we are caught up, with non-communicable diseases: diabetes, hypertension, and cancer. I think this summit will enlight, the Kenyans as well, to make sure that our people get good health. Thank you so much.
Thank you so much, PS Liban. PS Salome.
Your Excellency, the Prime Cabinet Secretary, Dr. Musalia Mudavadi, Dr. Musalia, the Cabinet Secretary, Health, Mr. Adan Duale, the Governor of Kisumu, Your Excellency, together with Her Excellency, my colleague PSs, PS Shaukat and PS Liban, all invited guests, good morning. My name is Dr. Salome Biako. I am the PS Correctional Services, and I'm very gratified for this invitation by Dr. Uma Oluga, the PS Medical Services, primarily because I'm charged with the care of over 60,000 inmates in Kenya across 135 prisons. And one of the biggest problems we are grappling with is cancer, particularly prostate cancer and to a very small extent, breast cancer. Why do I say to a small extent? The reason is because 95% of all our inmates are men. And the bills that we have accrued in that space are astronomical. And I'm very happy that you have this summit. And I would urge all the delegates and participants in this meeting that when you're deliberating on the issues of solving, particularly prevention, diagnosis, and palliative care of cancer patients, kindly consider to come into the space of correctional services. We have been working with PS Oluga, Oumba Oluga Medical Services in registering all our inmates under SHA. And I would hope that one of the resolutions you can make is to have regular screening of all our inmates, because that population is really aggravated by cancer. Thank you very much, and I wish you all the best in your deliberations in this summit. Thank you.
Thank you so much, Professor Shaukat. I see you have a speech, but you only have 3 minutes maximum.
Thank you very much, PS Oluga. Prime Cabinet Secretary and Cabinet Secretary Foreign and Diaspora Affairs, our Cabinet Secretary Health, Honorable Adan Duale, my colleague PS Medical Services, His Excellency the Governor of Kisumu, and Her Excellency the First Lady, my colleagues Principal Secretary present, distinguished guests, ladies and gentlemen. Let me also take this opportunity to thank my colleague for inviting me to come and make some brief remarks. I'll make it short, Oluga. Just our chief guest, this summit is more than just an event. This is a very powerful platform that brings diverse voices and also to have a unite mission so that we can be able to address. My brother, when he spoke about numbers here, we are looking at 42,000 new cases and almost 28,000 deaths. These are not just numbers. There are families and people behind these numbers. And Your Excellency, if you look at the bigger picture, according to the Globocan 2020, there are about 1.1 million cases in Africa and almost 400,000 cases. That means there is a need for us to have this call so that we can address this surge. I'm really honored to stand here and take the pride, Your Excellency, being one of those founder members of the National Cancer Institute under His Excellency when he was the Minister of Medical Services at the time. And my journey took me to the International Atomic Energy Agency, of which we were able to train many Kenyans and also be able to facilitate the procurement of the LINAC in the Moi Teaching Referral Hospital, and Cabinet Secretary, as you're aware, also the 2 LINACs, one in Mombasa and another one in Nakuru. This is under the rays of hope. Excellency, I need to continue mentioning this. You are in Vienna yourself. You had a dialogue with the DG of the IAEA. We have great opportunity that we need to continue to partner with the IAEA. we are looking at the uniting our voices and taking actions. I would like quickly to focus on a specific area on the diagnosis and treatment of cancer. And my focus will be mainly on the radiotherapy, because documents and studies have indicated at one point or another, over 50% of the cancer cases will require radiotherapy. So as much as we continue with the palliative care, preventive care, and also looking at the chemotherapy, there will need for us to have this radiotherapy as well. So for me really is to continue with the research for evidence-based, and I'm glad that we are working very closely with the Cancer Institute and of course KEMRI and the ministry to generate more data, innovative for affordable, accessible solution. I'm pleased to inform you, Your Excellency, that we are working closely to have digital screening tools, and as you've seen outside, the use of the AI so that we can be able to interpret the data from the radiology and the rest. But the elephant in the room is on capacity building. We have to continue training our people, and I'm pleased to let you know, Your Excellency, that my work at the IEA still continues while I'm here to help the country. We are looking at Kenyatta University Teaching Referral Hospital Cabinet Secretary, and I have made recommendations that it becomes the centers of excellence so that we can be able to train Kenyans and Africans. And also looking at the strategic collaboration, public-private partnership is very critical. One thing that, Excellency, I would like to mention here, according to standards, we're supposed to have 1 machine per million population. Kenya at the moment is standing at about 19 machines. So we have a deficit of about 36 machines. If you do a rough estimate, that will cost us about 90 billion Kenya shillings just to procure the linear accelerator. I know Cabinet Secretary is on that. As I come to conclude, I want to continue urging the increased investment in research, and under National Research Fund, which is domiciled in my State Department, I will continue advocating for that. Secondly, we also have a draft plan with the National Cancer Institute to finalize the roadmap of the National Cancer Agenda. And second to last is to look at the data. It is very important that we generate our own data so that we can have all this precision treatment. My closing call of action is just to let everybody know that science is our compass, research is our engine, innovation is our bridge to equity and to hope. Let's unite our voices. Let us take action. Let us build Kenya where cancer is no longer a death sentence, but a battle where we're ready to fight and win together. Once again, I thank you, and I wish you all a very fruitful deliberations.
Thank you so much, Your Excellency and CS. I had to be kind to Professor Shaukat because Waziri has directed me that we find a mechanism to ensure all our regional cancer centers, we manage them, the equipment, and I am talking to him nicely so that we can get some support from the International Atomic Energy Agency. So you will indulge me. Your Excellency, we from the State Department of Medical Services are very keen on 2 areas. As we discuss the general country policy around cancer, we are keen on making sure that hospitals perform the functions well in terms of clinical workflows so that cancer patients are not tossed from one side to another. There's a very clear pathway how they get into the facility, how they get their care, and how they get out. And secondly, sir, is we are also ensuring that we match the resources with the policy so that we get efficiency in terms of resource deployment. With those very many remarks, I would like to invite His Excellency, the Governor for Kisumu, Professor Peter Anyang' Nyong'o, to address us.
Your Excellency, the Prime Cabinet Secretary, my dear friend, Musalia Mudavadi, the Minister for Health, my dear friend Duale, distinguished gentlemen and ladies here today, I really come here now to say very little, because a lot that I had to say have been said by my predecessors who were on this podium, Professor Shaukat in particular. But really, it is my great honor to join you today at this second National Cancer Summit, a gathering that speaks not only to our collective concern, but more importantly, to our shared commitment to changing the course of cancer care in Kenya. Cancer, as many of you may know, is now the third leading cause of death in our country, following infectious and cardiovascular diseases. We are facing a rising tide. Over 58,000 new cases annually, projected to increase to 95,000 by the year 2040. The time for dialogue is now, but more crucially, the time for action is now. Today I want to speak to one central issue: how we move from policy to practice, from paper to patient, from intent to impact. And I speak both as a governor and as someone who has walked this journey from national policy halls to county hospitals, from boardroom consultations to community health units. During my time as Minister for Medical Services, I initiated a process that eventually led to the establishment of the National Cancer Institute of Kenya, of which a lot has been said today. Today, I stand proud of what it has become, a national institution anchoring our cancer response. Equally, I celebrate the opening of public cancer treatment centers beyond Kenyatta National Hospital, beginning with Kenyatta University Teaching, Referral, and Research Hospital, and now extending to 5 additional regional centers. What is happening at Kenyatta University Teaching and Research Hospital is really magnanimous. Last year, the Minister of Health launched the National Cancer Control Strategy 2023 to 2024, a well-thought-out framework anchored on 5 pillars: prevention and early detection, diagnostics, treatment and palliative care, strategic information, and financing. I applaud this strategy. But we must now confront the harder question: are we implementing this strategy? Are we matching vision with capacity, ambition and accountability? And is our treasury prepared to finance this strategy to the end? Back home in Kisumu, we have internalized this strategy and contextualized it to fit our local reality. Cancer, particularly cervical and breast cancer, is an urgent public health threat in our region. And my First Lady and other First Ladies in the LREB region have been seized with the responsibility of early detection by examining young women for cervical cancer and breast cancer. Our statistics tell a stark story. Less than 15% of eligible women are screened. Let me repeat that. Less than 15% of eligible women are screened, and many are diagnosed too late. We therefore resolve to act and act boldly. Through partnerships with organizations such as KMET, Kiwa's Cervical Cancer, Africa Cancer Foundation, and PEPFAR, we're implementing a community-based screening program targeting every eligible woman in Kisumu within 3 years. We're also addressing prevention. Under the leadership of our county First Ladies as champions, we have increased HPV vaccination among girls aged 10 to 14 from 12% in 2022 to 38% in 2024. This has been achieved through community health workers, schools, nurses, and grassroots advocacy, supported by partners like the American Cancer Society and UNICEF. Our efforts are bearing fruit, with LREB counties posting the highest see and treat rates, a testament to what committed advocacy and partnership can deliver. The Constitution of Kenya 2010, ladies and gentlemen, gave counties the mandate to deliver health services, and that devolution has been a game changer. In Kisumu, for example, it allowed us to digitize community health, recruit gynecologists, oncologists, and now move toward the completion of a comprehensive cancer center, which will soon provide surgical and radiotherapy services under one roof. And as we move Jaramogi Oginga Odinga to the national level, I have pleaded with my friends over there to leave Victoria Hospital to us, because it is our center for cancer research, teaching, and cure, and our center for dealing with sickle cell anemia. And I'm sure that our minister who is here may enlighten you further what that goal is. But let us be honest. The power of devolution is not automatic. It must be supported by adequate financing, a clear division of roles, and coordinate implementation between national county levels. As such, the Minister of Health has been very good in recognizing this partnership, and I thank my colleague. Despite good policy frameworks, we still face implementation bottlenecks. One, many counties lack essential diagnostic infrastructure. Two, we face an acute shortage of oncology specialists. Three, financial protection remains elusive for many patients and proposals. And lastly, we cannot ignore social and cultural barriers. Fear, stigma, and misinformation continue to hinder early diagnosis and care seeking. Indeed, as I've been told by my friends at Jaramogi Oginga Odinga teaching at Ifo Hospital, people don't want to be told that they have cancer. If you say so, they think you are pronounced a deathbed. But that is not the case. I think more public education will make sure that cancer is treated like any other disease, preventable, curable, and indeed something that should be such a threat to humanity. We must address these issues head-on. Let us not be content with writing strategies. Let us instead commit to funding them, staffing them, equipping them, and measuring their impact. As I close, ladies and gentlemen, let me say that, to ensure that policy translates into impact, counties must operationalize the national strategies pillars, from prevention and screening to diagnostics, treatment and palliative care at every level of the health system. Two, stakeholder coordination must be institutionalized. National government, ministries, county departments, healthcare workers, NGOs, community health volunteers, and development partners must align on plans, funding, and messages. Three, community engagement and demand creation, as we have done in Kisumu, must be at the center, because the greatest interventions fail if people do not trust or understand them. Four, we must invest in surveillance, training, research infrastructure, including national reference laboratory and robust data systems. Five, and lastly, and critically, we must scale up financing mechanisms, including public-private partnerships, domestic resource mobilization, and risk pooling through insurance to cushion Kenyans from catastrophic health expenditure. Let this summit spark a renewed commitment, not just to talk cancer, but to treat it, to prevent it, to fund it, and to eradicate it where we can. As the governor of Kisumu, I pledge my full support to the national cancer agenda. Let us work together across counties, ministries, civil society, and development partners to ensure that every Kenyan, wherever they live, get the care they deserve. together, let us ensure that no one is left behind in the fight against cancer. I thank you.
Thank you so much, Prof. We take your words with a lot of value because of the journey that you have walked in supporting cancer. Waziri and PCS, I'd just like to recognize the chair of the Kenya National Chamber of Commerce because of the partnerships with the private sector. And then I take my seat. Dr. Ruto, yes, waving. As I take my seat, I now invite back the chair of the National Cancer Institute, which is hosting us, to invite you, and you can then invite our chief guest. Thank you, and we wish you blessed deliberations. Thank you.
Thank you very much, PS. I think it was extremely important that we have representatives from the other ministries within government. And the reason is, first of all, they have got a role to play in terms of the risk factors for cancer, the modifiable ones. We need to manage them. Secondly, it also impacts the social determinants of health, which is extremely important. And thirdly, you must appreciate that there's a direct relationship between poverty and ill health. Poverty is both a cause and a consequence of ill health. And if there's one intervention that will improve our health status significantly, it is alleviation of poverty. And that is why economic transformation is of necessity at the center of this administration's agenda, and it must be, if we're going to make an impact in terms of our cancer patients. The second thing I'd like to comment is that we cannot achieve universal health coverage, and especially for patients, for cancer patients, without bringing down the cost of healthcare in our country. That's a discussion I've had with every cabinet secretary I've interacted with, including our current one, and I've got a strong belief he's the one who will bring us together and have a debate in which we can be able to bring down the cost of healthcare. With those few remarks, I'd like to at this point now welcome our Cabinet Secretary for Health, Honorable Aden Duale, to come and address us. Thank you.
Your Excellency, the Prime Cabinet Secretary and CS for Foreign Affairs, the Governor of Kisumu, His Excellency Professor Nyang' Nyong', and the First Lady, PSS present, the Chair and board members of the National Cancer Institute, including the CEO, the following partners, civil society representative, healthcare professionals, cancer survivors and advocates, members of the Fourth Estate, fellow Kenyans, good afternoon. It is my honor to address you at this very important second National Cancer Summit, a critical gathering where we reaffirm our commitment to saving lives, reducing suffering, and building a future where no Kenyan dies from cancer. Cancer is not just a health crisis. It is a national emergency. Every day, more than 120 Kenyans are diagnosed. Every hour, families lose their loved ones. Each year, close to 29,000 lives are lost. These are not just numbers. They are people with names, families, and dreams. But today we come together, government, civil society, researchers, our county governments, partners and private sector, and the public, not simply to talk, but to act. And the theme, Uniting Voices, Taking Action, is a call for urgency and solidarity. Our National Cancer Control Strategy 2023-2027 provides us with a very clear roadmap covering prevention, diagnosis, treatment, palliative care, financing, and research. We are decentralizing cancer care as a country. Our regional cancer centers are now operational in Nairobi, Eldoret, Kiambu, Mombasa, Garissa, Nakuru, which is a major step towards equity in access. Through the National Equipment Service Project, we are strengthening our cancer care by equipping our national and county referral hospitals with essential screening and treatment equipment. Mammograms have already been installed in Kisumu and Kerugoya, while CT scans are operational in 15 county referral hospitals, with installation underway in another 15 additional counties. Data is our compass. Our National Cancer Surveillance Platform is enabling real-time data to drive smarter, targeted decision-making. On prevention, the ministry has successfully integrated the HPV vaccine into our routine immunization schedule, targeting adolescent girls aged between 9 and 14 years. This is a momentum step towards the elimination of cervical cancer. We are expanding our community-based screening for breast, cervical, prostate, among other cancers, through community health promoters and mobile outreach teams. Early detection saves lives. We are also strengthening our referral system to ensure timely follow-up and care. No Kenyan should suffer or die because of delayed treatment. Through the Taifa Care, we are building a health system which is more inclusive, equitable, and responsive. The Social Health Authority is very central to this transformation, with over 24.9 million Kenyans enrolled as of last night. Every day, between 40 to 50,000 Kenyans enroll on our platform. The Social Health Authority provides up to 550,000 per year through the Social Health Insurance Fund, an emergency, chronic, and critical illness fund for cancer diagnosis and treatment. Additional services covered include surgical procedures, inpatient care, outpatient care, and palliative care in line with the SHA benefits and tariffs. No Kenyan should be forced to choose between treatment and feeding their family. The government, under the leadership of President William Ruto, has made it very clear that the health of our citizens comes first. To date, SHA has received oncology claims amounting to 5.8 billion in the last 9 months, benefiting 49,315 patients who have accessed various oncology services, including the following: 15,300 patients received chemotherapy, 2,200 underwent radiotherapy, 2,609 accessed the PET scan, and 1,390 went through, under the SHA program, CT scan. And thousands more have benefited from other cancer diagnostics and intervention. We urge all Kenyans to register and contribute to the Social Health Insurance Fund. This is your protection. This is your family future. To further strengthen access to oncology care, the Ministry of Health, and I want to say it with a lot of pride, that we have signed an MOU with Roche, and I'm sure they're here, one of the biggest pharmaceutical company, to provide Herceptin 600 milligram SC and other products, therapies to eligible SHA beneficiaries. Please let's clap for Roche, a biological therapy that is used to treat breast cancer and gastric cancer, which make up 15 to 20% of all the cancer cases. It's a critical addition in the fight against cancer. This partnership we have with Roche has reduced the cost of treatment from 120,000 Kenya shillings to 40,000 per session, fully covered by SHA with no co-payment for our patients. These therapies will be available across all SHA-contracted healthcare facilities nationwide. They can be found both in the public, private, and faith-based. And this is to ensure equitable nationwide access. The ministry, under my leadership, encourages other pharmaceutical partners present here, and those who are listening to us, to join in expanding access to affordable, patient-oriented, and high-quality cancer care. However, ensuring access to therapies must go hand in hand with early detection. Over 70% of cancer cases are diagnosed late, mainly due to limited access, stigma, and misinformation. We must expand diagnostic and radiotherapy services in the most undeserved areas and promote early health seeking by normalizing cancer conversation. Geography must not determine survival. To our county governments, please prioritize cancer in your budgets. Ring-fence funding for screening, public education, and referral infrastructure. Decentralized action is very essential. To our healthcare professionals and researchers, lead with evidence, compassion, and innovation. Train the next generation, generate local data, improve the outcomes. To our partners and the private sector seated here, work with us, invest in localized, affordable cancer care solutions that are scalable and sustainable. To the media, civil society, survivors, and our citizens, use your voice, raise awareness, break stigma, support one another. Early detection saves life. Let this summit be remembered as a moment we shifted from plans to impact, from words to action. Let us unite our voices and deliver a future where cancer is no longer a death sentence, but a challenge we meet with courage, equity, and national resolve. With those remarks, it's now my honor and duty to welcome my boss and old friend, the Prime Cabinet Secretary, and the CS for Foreign Affairs and Diaspora Affairs to deliver his keynote address. Thank you, and God bless you all. God bless Kenya.
Thank you. You may be seated. The Honorable Adan Duale, Cabinet Secretary for the Ministry of Health,
my good friend, Professor Anyang' Nyong'o, Madam Dorothy, Principal Secretaries present, the Director for Health, the Chief Executive Officer and board members of the National Cancer Institute of Kenya, county health officials, development partners, healthcare professionals, cancer advocates and survivors, distinguished guests, ladies and gentlemen. It is a great honor to stand before you today at the opening of the second National Cancer Summit, a timely and vital gathering of minds, leaders, and change-makers dedicated to defeating one of the most formidable health threats of our time, cancer. Mr. Minister, on a lighter note, I did not take the Bombay ambulance to get here. Allow me to begin by congratulating the Ministry of Health, the National Cancer Institute of Kenya, and all partner institutions for convening this important summit under the inspiring theme, Uniting Our Voices, Taking Action. It is not only a call to solidarity, but a declaration that the time for fragmented efforts is over. The time to act collectively and decisively is now. Cancer is a growing national and global challenge. It continues to exert a profound toll on the lives of Kenyans and health systems. The burden of cancer is not just medical, it is economic, social, emotional, and psychological. For this reason, we must approach cancer not as a health issue alone, but as a national development priority that requires a multi-sectoral and multi-stakeholder approach. If we are to meaningfully address cancer, then all sectors, not just the health sector, must come on board. We must embrace a multi-sectoral national response to cancer. We must break down silos. The Ministry of Education must ensure that cancer awareness is integrated into our school curricula and life skills programs. The Ministry of Agriculture and Livestock Development, as well as the Ministry of Investments, Trade and Industry, must regulate carcinogenic products which promote health and nutrition and ensure food safety. The Ministry of Environment and Forestry must address environmental risk factors such as pollution and hazardous exposure. The Ministry of Information and Communications and the digital economy must support cancer registries, telemedicine, and digital patient care platforms. The National Treasury and Planning must prioritize and sustainably fund cancer prevention and treatment programs. The Ministry of Roads and Transport must ensure improved networks to make it easier for Kenyans to reach screening, diagnostic, and cancer treatment centers, and the list goes on. And crucially, county governments under devolved healthcare must localize, fund, and lead community-level interventions. In short, we must embrace a whole-of-government and a whole-of-society approach. We must bring all hands on deck, including the healthcare workforce, pharmaceutical companies, civil society, the private sector, academic institutions, faith leaders, media houses, communities, and above all, cancer survivors and caregivers. Ladies and gentlemen, as we respond to the internal challenges of cancer, Kenya is also looking outward with a bold vision of becoming a regional hub for cancer treatment, training, and innovation in Africa. This will position Kenya as a regional hub for cancer care. We already have critical building blocks in place, and I will repeat them because they have been alluded to. The operationalization of the regional cancer centers in Nakuru, Mombasa, Meru, Kisumu, and Garissa. The scaling up of radiotherapy, chemotherapy, nuclear medicine, and surgical oncology services. The emergence of highly skilled oncologists, radiologists, and oncology nurses trained locally and internationally. The advancement of cancer research registries and precision imaging technologies through public and private investments. We are not merely responding to disease. We are building the infrastructure systems and workforce that can anchor medical tourism, regional referrals, and clinical trials within Kenya. Our ambition is clear: to serve not just Kenyans, but also our Eastern and Central African neighbors who seek accessible, affordable, and high-quality cancer care. This ambition cannot be achieved in isolation. The government of Kenya, through my office, has prioritized health diplomacy as a cornerstone of our external relations. Through bilateral and multilateral partnerships, we are engaging meaningfully with international organizations and cancer control bodies, including the World Health Organization, the International Atomic Energy Agency, and Professor here spoke to it, the Union for International Cancer Control, and numerous UN agencies, regional blocs, and philanthropic institutions. These collaborations have resulted in strengthened diagnostic capabilities, technical support, equipment donations, knowledge exchange through capacity building, and access to global best practices. I take this opportunity to express our deep gratitude to our development partners and technical agencies who have worked with Kenya in this journey. The national government remains firmly committed to expanding these international collaborations in line with our national cancer control strategy and the aspirations of Kenya Vision 2030 and Agenda 2063. As a government, we recognize that cancer is a borderless crisis that requires borderless cooperation. That is why we have reaffirmed our role in international cancer diplomacy by participating in global cancer summits and World Health Assemblies, strengthening our voice in regional economic blocs to prioritize cancer under trade, health, and human capital development, hosting South-to-South collaborations for oncology, training, and knowledge exchange, and aligning our policies with UN and WHO global cancer targets, including the target to reduce premature mortality from non-communicable diseases by 1/3 by 2030. We are determined to position Kenya as a credible, responsible, and proactive partner in global cancer control. We shall collaborate with international organizations and other industry players in cancer care, in research, innovations, and in developing new health products and technologies. We are ready to learn, ready to lead, and ready to leverage on our networks to serve our people and the region better. As we expand infrastructure and partnerships, we must not lose sight of the people at the heart of this response. Cancer care must be patient-centered, culturally sensitive, and grounded in evidence. Evidence generated from research. Evidence-based targeted interventions lead to optimal utilization of resources. As Honorable Dwale said, Behind every statistic lies a story, a family shattered, a dream delayed, a life stolen too soon. Yet within these stories, we find resilience, hope, and the unbreakable spirit of survivors and caregivers. Today, we stand united, not just in sorrow, but in our resolve to turn the tide against cancer. We are not powerless. We are powerful when we join hands, when we unite our voices, and when we act with purpose. Every Kenyan has a role in this battle. Whether you shape policies, heal patients, educate minds, grow food, or inspire the next generation, your actions matter. Your voice matters. Let us leave this summit not with words alone, but with a commitment to bold, measurable steps towards a cancer-free Kenya. Let us honor those who have lost by ensuring their pain is not the legacy of our future. May we draw strength from our unity, courage from our convictions, and hope from our shared humanity. Together, we can and we will defeat cancer. It is now my honor to officially declare the second National Cancer Summit 2025 open. And just one extra minute, Mr. Minister Duale, let me just commend you and your team because you've brought a lot of new vigor to the health sector. Vigor and purpose. And we really want to encourage you to continue on that trajectory. I don't know if there's a lady Musembi within the hall. Dr. Musembi, is she around? Maybe, maybe not. But I think she's one of your senior oncologists somewhere. Where is she? I don't know. Ah, okay.
Professor Musimbi,
Musimbi, is it?
if she's in the audience, but in the event that she's not here, our PCS,
yeah.
I will make sure she comes to your office and the PCS office.
No, there's nothing wrong. I just actually wanted to acknowledge her because my first serious encounter with the aspect of cancer was through her initiatives. She was really involved working with the Pink Ribbon movement to bring a lot of awareness to matters around breast cancer. Professor Nyong'o, I don't know whether you were there then, but we even had a camp in Ole Tepis, in Kajiado, and she was the lead facilitator. And we actually pitched camp and spent the night with her and several other professionals in Kajiado. And I was really inspired by what she was doing and what they were doing. And those of you who are here as well. So I just want to recognize that I do remember a very powerful lady. And she remains very powerful. And to all of you who are doing an excellent job. Thank you. God bless you all. Asante sana.
Thank you very much, His Excellency, the Prime Cabinet Secretary, for your great words and, of course, for sharing with us. Please be seated. What the government is doing through policy and programs to help deal with cancer in the Republic of Kenya. Thank you very much. And now the meeting is officially opened. Without further ado, I want to invite the CEO of National Cancer Institute of Kenya to take us through the Empower program, and thereafter we are going into the award program. Thank you.
Thank you very much. Our Prime Cabinet Secretary, our CS distinguished guests, thank you for the commitment to invest in this cancer prevention and control. We're now moving to kindly PCS and CS indulge us with just a few more minutes to go through 3 very key items that are before us. One of them, appreciating the role of data, and data being the new oil. We have worked for a long time with our partners, Roche again, CS, and the first county ladies on a program called Empower that has been doing screening activities in the communities. And we are privileged that that team is going to hand over this great work to the National Cancer Institute of Kenya, to the Ministry of Health, to continue. To carry us through this session, allow me to invite the General Manager, Roche, East Africa, Ms. Jackie, and also our very able First Lady, Kisumu County, Her Excellency, Madam Dorothy Nyong'o. Kindly join me up front as we showcase this great work that we've been able to do over the last couple of years. We are embracing partnerships and collaborations from all the stakeholders. Her Excellency, Madam Dorothy Nyong'o, will speak first about this program, and we will proceed from there.
Good afternoon. All protocols observed. I've been ambushed. Anyway, I'm really happy to share the experience with Empower. This is a program that was started in 2019, a partnership between the County First Ladies Association, Roche, International Cancer Institute, Africa Cancer Foundation, Women for Cancer, and we decided that we needed to get screening services to be available to the grassroots women on a regular basis. So after a lot of consultation, we went around the counties and partnered with the county governments to set up what we called Empower Clinics. And by the time COVID hit, we established 19 Empower Clinics in spite of COVID. And the purpose of the clinics was to ensure that Monday to Friday, there was a facility available at the county hospitals, level 4 or 5, where women could go in to get a screening. And this has been really remarkable. It was a game changer. And it allowed women to walk in freely and get screening and then to be navigated through the system to get early diagnosis as well as early treatment. I think I will leave it there and get Jackie to share the rest of the story.
Your Excellencies, all protocol observed. Good afternoon, everybody. So just to conclude from where Dorothy has left, from the 20 clinics in 19 counties, we have screened over 200,000 women. We have over 3,000 patients receiving treatment in the centers. And in August 2024, we had a tripartite memorandum of understanding between Roche, Savannah, and the National Cancer Institute. And why we launched the second part was because of the learnings of the brick and mortar 20 clinics we had. And so we chose to go through the digital way to increase efficiency, which supports the UHC agenda in Kenya in terms of we want to talk about equity, efficiency, and patient centricity. So today we have 56 digital sites. We have tripled the numbers in 11 months and screened over 300,000 women. So we would like now to integrate and hand over the platform to the National Cancer Institute so that with the Ministry of Health can work together to make it a national program and platform to enhance the efficiency.
Thank you very much. Quickly now, we are moving to PCS and CS to award men and women who have sacrificed a lot in this cancer space. They've made a difference, picking from where our Prime Cabinet Secretary acknowledging Professor Musibi. So I would want to ask our MC team to carry us through the award sessions so that our PCS, our CS can honor these great men and women. More often we find our scientists, researchers acknowledged abroad, while back at home, we may not know that they are doing a lot of heavy lifting.
Thank you very much indeed for that presentation. And of course, standing on the established protocols, we now move to a very important, yes, please, let's put our hands together for that presentation on empowerment. And we're now moving to a very critical stage of this summit, and this is the award ceremony, and my colleague here, Mashirima Kapombe, will guide us. Thank you.
Asante sana. So we'll start with calling onto the stage our Prime Cabinet Secretary and CS for Foreign Affairs. Please come to the stage so that you can help us award our awardees this afternoon. Tumpigie makofi akija hapa mbele. You will award the CS as well, so please come first.
Yeah. the CS is also an awardee, so
yes.
It's your moment.
Asante sana. So we'd like to first call O'Brien.
We're going to call Professor Frederick Chite Asirwa. He's a founding director, International Cancer Institute. He is a medical oncologist and hematologist of several access to personalized cancer care and research initiatives, including blueprint programs. And he's also a founding member of the Shining Tower program, where he's a prof.
And as he walks to the stage, he has developed several training programs, including the SSA Oncology Preceptorship Training, Digital Pathology Program, Telemedicine Program, Oncology Training for Physician Assistants, Development of Oncology Nursing Training Program in Kenya, Medical Oncology Fellowship Program. We could go on and on.
Another awardee is the Award of Excellence in Cancer Care. We have Professor Nicholas Anthony Otieno Abenya. Please, let's put our hands together for the good old prof.
As he walks up to the stage, this is why he's being awarded today. He holds a master's degree in internal medicine from the University of Nairobi, and this award recognizes his profound direct impact on elevating clinical practice, shaping cancer care in the country, and building the specialist workforce essential for NCIK's mandate. Tumpigie makofi. And we'd like to call on stage Dr. Elias Meli to receive the award on behalf of Professor Frederick Chite Asirwa. Tumpigie makofi.
Let's clap, please. Let's continue clapping. Don't get tired. We're almost coming to the tail end of this process. Our next recipient is Benda Kithaka, founder and chief executive officer, Kilele Health Association, secretariat lead, African Cervical Health Alliance. Please, let's put our hands together for another round of appreciation.
And Benda is being recognized for her integrity warmth, and leadership in amplifying voices of the underserved and co-creating impactful tools for cancer control and management across Africa. Tumpigie makofi.
Thank you very much. Another award in the trailblazing woman in cancer care in Kenya and Africa. The recipient is Dr. Miriam Mutebi. Let's put our hands together, ladies and gentlemen, for Dr. Miriam Mutebi, and Mashirima is going to take us through her profile.
Now, Dr. Mutebi's work focuses on strengthening health systems, improving access to care, and advancing equity in oncology. She's a committed advocate, educator, and policy advisor. She works to build sustainable cancer programs and empower healthcare professionals across Africa. Makofi.
And the next award goes to a nurse. Her name is, first of all, before I go to the name, the award goes to, because of excellence in cancer care in hardship communities. What a nurse. And this is Madam Suleka Aidan. Let's put our hands together for Madam Suleka Aidan as we go through her profile, taken by Mashirima Kapombe.
I think she deserves a better clap than that because she comes all the way from Turkana County and she's an oncology nurse working in the county, and we're recognizing her for all the work that she did in the year 2024. Makofi kabisa.
And now, after the awards, we want also to recognize people who are driving the fight against cancer and management in this country, from policy to programs. I want to invite on stage the CS for Health, Cabinet Secretary for Health, Honorable Aidan Duale. Let's put our hands together. It is not a crime for you to ululate. You can just go ahead. Thank you very much, Waziri.
And as we award our CS for Health, I think we've spent so much time in this space where there's so many doctors that you want to call everyone a doctor. CS Aden Duale, asante sana. And as he stands there, I would like to call on stage the PSs first, so that they can be awarded, and then we can award our CS Aden Duale. So our PSs, starting with Dr. Ouma Oluga, followed by Salome Biko and Muhammad Liban, as well as Dr. Shokat.
Very good. Please come to the stage for your recognition.
Tuwapigie makofi. The leadership that they've shown throughout, tuwapigie makofi.
So where are the gifts for the PSs, principal secretaries, for the work, for the good work they are doing? Remember, they are very critical in policy implementation as well as formulation. And so they are on the front line. Please, just clap.
We would now like to appreciate and call onto the stage the Governor for Kisumu County, Professor Peter Anyang' Nyong'o. Please let's give him a round of applause as he comes to the stage.
And he will be accompanied by his wife, the First Lady, Dorothy Nyong'o. Please put our heads together for the Governor and then the camera people will guide us on how the photo will be taken. And this will be followed by the launch, the much-awaited launch of something very special, something that is going to revolutionize cancer management and fight against cancer in this country. So you don't want to miss out on that. And thereafter, we are going to have a photo opportunity before we can proceed for lunch. And then we'll give you an update on the afternoon program.
And finally, we would like to call onto the stage the chair of NCI Kenya, Dr. Olwenyi. Please come to the stage. Tupige makofi tafadhali. Dr. Olwenyi will be awarded by the PCS. And then the PCS will award the CS. Pole sana CS, tumekuweka sana. And finally, after keeping him waiting for so long, the CS Aden Duale will be awarded by PCS Mudavadi.
Yeah, and now before we move to the final award, let us also recognize the award of the Excellence in Leadership and Governance in Cancer Award. And this goes to the CEO of National Cancer Institute of Kenya. We were reserving this for him, and we are reserving the best to the doctor. This is Dr. Elias Meli. He's being rewarded for what, Mashirima?
His leadership, for sure, under the National Cancer Institute of Kenya. Asante sana for your leadership and making this possible together with the other officials in the ministry. Tumpigie makofi.
Makofi Jameni. And this award also is because of the great work that is being done by NCI Kenya, from the Board of Management to the Board of Directors and, of course, the staff at NCI Kenya.
And finally, PCS Mudavadi, please come to the front just a little bit. And the chair of the National Cancer Institute of Kenya will award him. There's a gift of appreciation for him.
And here comes the gift for the Prime Cabinet Secretary. Please let us put our hands together for His Excellence, the Cabinet Secretary, for the Prime Cabinet Secretary, Musalia Mudavadi. So time now for the photo op. Are we good? They're saying that you need to smile. You can put on, some beautiful smile. I can confirm that you look very good when you put on your smile. And thereafter, we are going to the launch of a very important milestone in this country, which will be guided by the Prime Cabinet Secretary.
So once the photo is taken, and as the photo is being taken, we'd like to call onto the stage Dr. Joanne Paula Bor.
Dr. Joanne, please come to the stage. Let's put our hands together for Joanne. Dr. Ari, thank you very much. She's going to guide us through the next stage as the awardees. Okay, one more. All right. Thank you very much. Please take your stage. Save for the Prime Cabinet Secretary, who is going to guide us on this. There is a special request by the Prime CS that the cancer champions to come to the stage for a photo opportunity as well, as we are taken through the program by Dr. Joyce.
Oh, they tell me I forgot something. Ooh, sorry, Basala. I forgot.
All the cancer champions in the room, please just come over here for that important Yeah, please just come here for your encouraging battle against cancer.
God bless you. I love you all. I'll see you. Oh, they tell me I forgot.
The launch of the National Cancer Radiotherapy protocols, and I am just here to give a brief background before we proceed to the booth. So the radiotherapy protocols, as we proceed, our chief guest, the radiotherapy protocols is a technical document that has been developed through a multi-stakeholder engagement with the aim of providing harmonized evidence-based framework for radiotherapy planning, delivery, and follow-up. As has been mentioned earlier, about 50% to 60% of cancer patients require radiotherapy. And as we have progressed over the years, from 2019, we had 1 national cancer center offering radiotherapy. Now we have 6 in the public sector and about 90 other centers in the country providing cancer care. So the aim of this protocol is to standardize care and also to guide the Social Health Authority, who will reference the protocol as the national standard for radiotherapy, ensuring accountability and consistency across all the treatment centers. This is the first document of its kind in the country, and I want to request that, with your kind permission, our Prime Cabinet Secretary and our CS, that I would invite representatives from the cancer centers offering radiotherapy so that they can join us as we proceed to the booth. I want to invite Dr. Zainab from KU, TRRH, Dr. Beatrice from MTRH, Gladys Mukosi from KNH, from the regional cancer centers, Dr. Omar from Garissa, and Dr. Siwilis from Nakuru, representing the private sector, Nairobi Hospital, Frederick Asige, and representing the cancer professionals, Dr. Gladwell Kiarie, the chair of the Kenya Society of Hematology and Oncology, and lastly, representing civil society patients, the executive director of KENCO, and very last but not least, representing partners, Clinton Health Access Initiative. Thank you.
Asante sana. So we are now getting into the...
Oh, sorry, MC, I have been asked also to invite Senator Mandago, the chair of the Health Committee at the Senate.
And there we have it, the launch of the radiotherapy protocols by our Prime Cabinet Secretary, Musalia Mudavadi. Tupige makofi. Tupige makofi kwa nguvu kidogo. Our chief guests are now receiving copies of the protocols. As our media team takes the photos. And there we have it. Asanteni sana. Prime Cabinet Secretary Musalia Mudavadi, our CS Aden Duale, Senator Jackson Mandago, our Chair for NCIK, Dr. Olwenyi, our CEO, Dr. Elias Meli, Governor for Kisumu, Professor Nyang' Nyong'o, as they get into the stage for another photo, one final photo with the protocols. Some can come down. Asanteni sana. And at this juncture, we will allow our guests to leave at their pleasure. The rest of us will go for lunch, but we'll just wait until our chief guests have left so that we can proceed.
Very well. Thank you very much indeed, Mashirima Kapombe, for taking us through that process. It is time for lunch, and I expect to hear and see some excitement. The VIPs are going for their lunch on the first floor. The first floor, that is where they're going to have their lunch. And you exit through the first door, and then you turn left. You take the lift, which is on your right, and then it will take you to the first floor. That is where you're going to have your lunch. That is the PSAs, the chair, the prime cabinet secretaries, et al. Then the other dignitaries, we are having our lunch on the second floor. On the second floor. We are coming back here at exactly 2 p.m. so that we can continue with our program. From me and Mashirima Kapombe, we take this opportunity to wish you a lovely lunch. Bon appetit.
The Constitution of Kenya provides for health as a right to every Kenyan. The national government through Ministry of Health The Constitution of Kenya provides for health as a right to every Kenyan. The national government through Ministry of Health has put in place its strategies to ensure that every Kenyan is able to access timely, quality and dignified care. In this case, cancer care, to be very specific. The National Cancer Institute of Kenya is implementing the National Cancer Control Strategy that has 5 pillars: prevention, diagnosis through pathology, imaging, treatment, coordination, healthcare financing, cancer, strategic information, surveillance, registration, and research. With over 200,000 cases being screened every year towards early diagnosis and detection, where the focus of universal health coverage is, the Empower program, which was developed under the leadership of the National Cancer Institute of Kenya and all the stakeholders, has provided real-time data to enable patients to access care timely without loss to follow-up and improved outcome.
The EMPOWER program, the way it's created, it's helping us to reduce turnaround times toward the follow-up and the treatment of this patient. As earlier, the way they have been doing, it's more manual registration, but nowadays when we're having this EMPOWER, it's also enabling us to have that dashboard program whereby it can give us the entire detail of our patient from their registration, the time they have been seen from the facility, the time they have been referred to the facility of investigation, and the facility that they are doing management.
Local evidence generation and data for decision making are critical to advance our policy milestones in the cancer prevention and control. And digitization is critical in the universal health agenda, and this milestone complements integration to the digital health superhighway.
The EMPOWER 2.0 program is going to focus on the successes of EMPOWER 1.0, which is the integration of breast and cervical cancer in the primary healthcare system. The focus will also be to understand the patient journey from an end-to-end perspective, starting from awareness, screening, diagnosis, and to treatment. And the third pillar is to incorporate the digital platform to understand and really be able to look at the cancer care treatment journey for all the patients.
Our work on EMPOWER is fully aligned with the Government of Kenya's broader digital health agenda, including integration with the Kenya National Health Information Exchange that we are helping to lead. By connecting platforms like EMPOWER to national registries and point-of-care systems, we're laying the foundation for a more patient-centered healthcare ecosystem. What began as a pilot in 20 facilities has now scaled to 76 sites, with 56 additional digital sites and 200,000 patients screened for breast, cervical, and prostate cancer.
This has been not possible without the support of all the collaborations that the National Cancer Institute of Kenya has built to support this digital health infrastructure. Our vision is to provide digital health infrastructure that empowers our counties and equips providers and enables patients to access cancer care with confidence and support. We invite all of you to build this important data infrastructure that is not only going to record the number of cases, but will also turn around the outcomes. You are welcome to walk this journey with us.
in Nairobi from 27th to 30th July 2025.
Cancer.
In terms of talking about the fragmentation that we have within our healthcare system in terms of how patients access care, it is important for us to dismantle those barriers in the cancer care ecosystem.
Cancer is the third highest cause of death in Kenya.
The Ministry of Health has identified 5 cancers as being responsible for over half of the cancers reported in the country annually.
1 in every 2 Kenyans diagnosed with any type of cancer succumbs to the disease in the same year of diagnosis. This means that less than 50% of cancer patients get fully treated. The Ministry of Health says the main cause for this is late diagnosis.
A third of cancers are actually caused by infections. And if we treat these infections very well, then we will prevent cancer. We cannot treat cancer comprehensively if we are struggling to treat malaria, diarrhea, diabetes, hypertension. We definitely must make sure that our diagnostics are at the best at all levels.
Treatment is curative and manageable when cancer is caught early, and also the cost of treatment is not as high. For me, one thing I urge my people is let's go for screening when screening is called upon. Let's engage and have a conversation with all the stakeholders in the cancer space.
There is a lot of stigma in the society. We as the cancer survivors, we stand in the gap so that for those who are on with the treatment, when they see us, they really come out clearly to say that if Mercy has survived for the 20 years, I can also walk the journey.
National Cancer Institute of Kenya was established, and its mandate is cancer prevention and control. Cancer, we recognize that it can be treated with curable intention. Cancer can be prevented. Ministry of Health, by establishing National Cancer Institute and charged it with a mandate of, among many other functions, is prevention of cancer.
Tuko na chanjo kwa wasichana wetu wa miaka 9 mpaka miaka 15 kuzuia hawa kwa ugonjwa wa saratani. Ile HPV vaccine that is going to assist our girls in matters to do with cervical cancer. We have enough vaccines in Kenya to make sure that all our girls aged between the ages of 9 and 15 can be given those vaccines so that we can protect them from cervical cancer that is destroying and killing many girls and many women in the Republic of Kenya.
So, ladies and gentlemen, it gives me great pleasure to launch our Cervical Cancer Awareness Month and the HPV screening.
Ladies and gentlemen, wapi makofi tafadhali. Wapi makofi. Oh yes indeed.
So we aspire and we intend through National Cancer Institute of Kenya to prevent cancer where possible. Where not, then we are called upon to advise on screening. We are screening people who potentially are not sick, and they could be having indolent disease, they could be having subclinical disease that if we screen early, we may diagnose before it presents with symptoms. And if we do that, then definitely that means we can diagnose early and even treat with minimally invasive interventions, whether it is surgery, that then we can preserve organs with less morbidity or less toxicity in the event that we have to treat these patients with either chemotherapy or radiotherapy. National Cancer Institute of Kenya assists in technical advice in establishment of cancer diagnostic and treatment centers. We will come to your facility, whether at the county level or at the national level, and provide technical assistance to ensure that whatever center is being established, one, it is going to guarantee quality care. It is going to guarantee the right diagnosis and the right treatment. More often than not, we have lost the battle of treating cancer with curative intention if we don't get it right from diagnosis.
KUTRH is a highly specialized level 6 referral hospital, and our flagship project is oncology, cancer care.
I have mentioned again and again that we have so many mushrooming cancer centers across the country. And one of our roles is to provide standards and quality. We shall help you from a government perspective to make sure that when you go to a center, truly they have capacity across the continuum of care so that you do not get the wrong surgery for the wrong diagnosis. We have different modalities for diagnosing cancer. It could either be through laboratory diagnosis, through histopathology evaluation, or it could be imaging and radiology through CT scans and other modalities, including the most advanced one that we have within the country, PET CT scans, and many other that our country has enabled to be available in this country and even into the county governments to improve diagnosis of cancer. We are here from the Ministry of Health under the leadership of our Cabinet Secretary to increase the capacity for our county governments in provision of cancer care across the entire continuum of care. And we are happy that today we are here at Samburu County Referral Hospital for this very important activity where we have launched a cancer treatment center here. And it is not just about the launch, it is actually beginning with actual treatment. Today we have been able to treat 4 patients who have received treatment, and we've all witnessed, with prostate cancer and other different types of cancers on day 1.
We are here at the Lodwar County Referral Hospital to launch a clinic or a center for the treatment and diagnosis of cancer cases here in Turkana County.
Part of our initiatives towards reducing the burden of cancer in our country is to increase access to treatment and diagnosis and treatment of cancer for our patients. We are happy that the patients will not have to travel very far, they will not have to incur the cost, and they will get treatment right here close home, and by evening they should go back home. We are happy we are making commitment while our first patients today have actually received treatment here. So we did not come with promises that we will come and set up a center, but we have come walking the talk, and this is because of the able leadership in the ministry and the institute to make sure when we visit, we shall leave a mark.
Kenyans can now access cancer treatment services at a much cheaper cost after Kenyatta University Teaching, Research and Referral Hospital received a cancer treatment machine. The machine will facilitate painless, non-invasive procedures on prostate, liver, lung, breast and brain cancers, among others.
This event is therefore a true milestone in our national healthcare journey, because we are here to launch a center which represents the convergence of high standards of treatment, state-of-the-art technology, affordability and effectiveness in cancer treatment. Kenyatta University Teaching, Research and Referral Hospital will deploy an advanced robotic radiation treatment machine known as the CyberKnife, which introduces revolutionary capabilities and enhanced efficacy in cancer treatment by locating, tracking, and accessing tumors that are ordinarily difficult to reach with precision. Again, I agree. Now we will move to CyberKnife precision. The technology is therefore able to administer more radiation with great precision, meaning that fewer sessions, maybe 4 to 5 only, instead of 20 to 30, are required, with each session lasting only between 5 and 15 minutes. This will significantly improve treatment outcomes and be able to deliver these services better, affordably, and much more effectively. Cumulatively, these advantages lead to shorter recovery period, minimal side effects, and better overall outcomes. The government therefore intends to sustain its investment and support for highly advanced diagnostic and treatment equipment to actualize the highest standard of treatment and care for all people. The CyberKnife technology at this hospital is the second in our continent, the only other being in Egypt. This propels Kenya to the frontier of advanced medical technologies and catalyzes our strategy to quickly emerge as an advanced regional and international medical hub. Its location is in a public hospital sends a strong signal to all Kenyans that it is no longer necessary to travel far away for advanced treatment that are now available, accessible, and affordable in our public hospitals.
What we've done as government is that we have cascaded the issue of early testing to the county level. And that earlier testing from the county level will involve centers that we've developed. At the moment, we've developed around 4 cancer centers, regional centers.
We therefore encourage Kenyans to utilize our diagnostic and treatment services within the country. There isn't much need to travel abroad now for treatment as it has been before. We have the latest of equipment, including CyberKnife, including PET scan for diagnosis, including surgical treatments that are so minimally invasive and treats cancer, laparoscopic surgeries, which our fellow homegrown trained and also international trained healthcare workers are able to deliver right here back at home through our centers of excellence within our regions and the national hospitals that our country has established. We are also interested that in the care that we provide is quality across the entire continuum of care, and we wish to assure the public that whatever care you will get from prevention, National Cancer Institute of Kenya is interested to know what is the quality. So we are inspecting, certifying and designating cancer centers based on established guidelines that are internally and externally validated, that was contributed in its formulation and development by the users themselves and the stakeholders to guarantee quality of care at all times. In our country, the capacity has increased immensely over the last 10 years. And almost every county, through the MESS program, almost every county now has increased capacity in diagnosis. We almost have a CT scan in every county. Lately, through our strategies to improve cancer care in our country, we've been doing every county cancer action plan. And we have noticed most counties have CT scans capacity, because that's the basis of diagnosis on radiology and imaging. We have a challenge though in pathology.
Okay.
Where we have very few doctors in that area and we have very limited equipment and infrastructure. But certainly there is a lot of improvement. We are charged with another huge responsibility of capacity building. This is either informally through training of including community health promoters.
Na cha muhimu pia zaidi, screening ya cancer. Screening ya cancer. Elezeni watu wajue kwamba cancer screening si ya mtu mgonjwa. Cancer screening ni ya mtu mwenye ako na afya yake yote. Sawa sawa. Kama wewe saa hizi hauna homa, hauna headache, hauna kichote mbaya, wewe ndio mtu ambaye unafaa uende kwa screening. Ule mwenye ako na signs, huyo hasa ni screening tena. Huyo mtu ambaye anaenda kwa diagnosis. Sasa si screening. Screening ni ya watu ambayo wako na afya yote vizuri, aende angaliwe kama labda kuna dalili yote ya cancer. So mtu asiseme kwamba bado hajagonjeka, sasa kwa hivyo haendi kupimwa cancer, aende kata screening.
WHO, has called on us to close the care gap, and we're really working on that. And the National Cancer Institute of Kenya, which is the agency mandated by Ministry of Health to reduce the burden of cancer in our country, is very strategic at this point in time. And I mentioned earlier on that we have a plan that we are implementing to the latter, called National Cancer Control Strategy 2023-2027. By the time this is implemented, with the support that the theme of this year is calling on nations to invest more resources. And we are really asking, the government through National Assembly to allocate more resources during budget making process to cancer, because it is one disease that is really terrorizing all of us. It terrorizes our social life, our economic life, our spiritual life, our physical lives, and people do not work. It's an economic issue as much as it's a physical issue. I would also wish to bring confidence to the public that National Cancer Institute of Kenya is committed and it is dedicated to deliver on its mandate to the latter. Because 10 years down the line, since NCI was established, it is an opportunity that we demonstrate to the public what capacity we have. And so much has happened and so much is still desired of the National Cancer Institute. We are building confidence to ensure that we solve our local problem. And the only way is one other key pillar, mandate, function that NCI has, which is cancer research. We are an institute, and the public is asking us to solve our local problems. For a long time, we have relied on foreign data to treat our patients, to diagnose our patients, to prevent some of these conditions. But we do recognize that genetically we are totally different. Clinical trials which were used to develop drugs, develop devices, develop equipment might not have included our local participants in Kenya, in East Africa, that we may share a particular genetic pattern. And therefore, we may undertreat or overtreat our patients because metabolism of these drugs, or also the densities of our tissues, if it is diagnosis, is different based on our genetic makeup. And therefore, we are coming strong at this point in time, confirming to the public that we have the right infrastructure now to conduct local research. We have identified our local gaps And we are going to look for solutions through research, cutthroat research for that matter, across the entire continuum of care. We have the National Cancer Control Strategy. This is a sector strategy that has been handed over to National Cancer Institute of Kenya to implement in totality, collaborating with other national agencies and also with other partners in private sector and within government, including county governments. It is costed at 49 billion. These are the resources that we are asking for the next 5 years to implement this national cancer control strategy. Our mandate is huge. We promise that we will deliver on our mandate. We have the right governance structures to ensure there is transparency and accountability on the resources that are invested in cancer through resource mobilization from the partners and grants from the national government. We have an oversight body, and we have also the Office of Auditor General that then looks at our financials every year to ensure that resources are prudently used towards cancer prevention and control. I would then wish to give Kenyans confidence that with the mandate NCI is being given, we are not leaving any stone unturned until we make sure that we reduce the burden of cancer in this country by making sure that we prevent most of the cancers so that the incidences can go down, or in the event that cancer is diagnosed, it be early so that when we offer treatment, it will be with curative intentions. And at the same time, we will ensure that morbidity, complications that occurs while going through treatment becomes less. We would want to widen the gap between those who are diagnosed and those who unfortunately we lose due to complications of cancer. You have our word. We are going to address this cancer issue. We have all the support within the country and without. And we work with all partners. We are calling everybody to be responsible. We are calling everyone to play their part and ensure that together we are mobilizing all resources, financial and non-financial, to ensure that we reduce the burden of cancer. Thank you very much. May God bless you. Until next time, once again, my name is Dr. Elias Meli. I am the Acting Chief Executive Officer, National Cancer Institute of Kenya. Thank you.
Now, the National Cancer Institute of Kenya, led by its chairman Timothy Olweni, is calling for stronger collaboration between national and county governments, researchers and the public to drive a more effective fight against cancer.
In terms of talking about the fragmentation that we have within our healthcare system in terms of how patients access care, it is important for us to dismantle those barriers in the cancer care ecosystem.
Cancer is the third highest cause of death in Kenya.
The Ministry of Health has identified 5 cancers as being responsible for over half of the cancers reported in the country annually.
1 in every 2 Kenyans diagnosed with any type of cancer succumbs to the disease in the same year of diagnosis. This means that less than 50% of cancer patients get fully treated. The Ministry of Health says the main cause for this is late diagnosis.
A third of cancers are actually caused by infections. And if we treat these infections very well, then we will prevent cancer. We cannot treat cancer comprehensively if we are struggling to treat malaria, diarrhea, diabetes, hypertension. We definitely must make sure that our diagnostics are at the best at all levels.
Treatment is curative and manageable when cancer is caught early, and also the cost of treatment is not as high. For me, one thing I urge my people is, let's go for screening when screening is called upon. Let's engage and have a conversation with all the stakeholders in the cancer space.
There is a lot of stigma in the society. We as the cancer survivors, we stand in the gap so that for those who are on with the treatment, when they see us, they really come out clearly to say that if Mercy has survived for the 20 years, I can also walk the journey.
National Cancer Institute of Kenya was established, and its mandate is cancer prevention and control. Cancer, we recognize that it can be treated with curable intention. Cancer can be prevented. Ministry of Health, by establishing National Cancer Institute and charged it with a mandate of, among many other functions, is prevention of cancer.
Tuko na chanjo kwa wasichana wetu wa miaka 9 mpaka miaka 15 kuzuia hawa kwa ugonjwa wa saratani. Ile HPV vaccine that is going to assist our girls in matters to do with cervical cancer. We have enough vaccines in Kenya to make sure that all our girls aged between the ages of 9 and 15 can be given those vaccines so that we can protect them from cervical cancer that is destroying and killing many girls and many women in the Republic of Kenya.
So, ladies and gentlemen, it gives me great pleasure to launch our Cervical Cancer Awareness Month and the HPV screening.
Ladies and gentlemen, wapi makofi tafadhali. Wapi makofi. Oh yes, indeed.
So we aspire and we intend through National Cancer Institute of Kenya to prevent cancer where possible. Where not, then we are called upon to advise on screening. We are screening people who potentially are not sick, and they could be having indolent disease, they could be having subclinical disease that if we screen early, we may diagnose before it presents with symptoms. And if we do that, then definitely that means we can diagnose early and even treat with minimally invasive interventions, whether it is surgery, that then we can preserve organs with less morbidity or less toxicity in the event that we have to treat these patients with either chemotherapy or radiotherapy. National Cancer Institute of Kenya assists in technical advice in establishment of cancer diagnostic and treatment centers. We will come to your facility, whether at the county level or at the national level, and provide technical assistance to ensure that whatever center is being established, one, it is going to guarantee quality care. It is going to guarantee the right diagnosis and the right treatment. More often than not, we have lost the battle of treating cancer with curative intention if we don't get it right from diagnosis.
KUTRH is a highly specialized level 6 referral hospital, and our flagship project is oncology, cancer care.
I have mentioned again and again that we have so many mushrooming cancer centers across the country. And one of our roles is to provide standards and quality. We shall help you from a government perspective to make sure that when you go to a center, truly they have capacity across the continuum of care so that you do not get the wrong surgery for the wrong diagnosis. We have different modalities for diagnosing cancer. It could either be through laboratory diagnosis, through histopathology evaluation, or it could be imaging and radiology through CT scans and other modalities, including the most advanced one that we have within the country, PET CT scans, and many other that our country has enabled to be available in this country and even into the county governments to improve diagnosis of cancer. We are here from the Ministry of Health under the leadership of our Cabinet Secretary to increase the capacity for our county governments in provision of cancer care across the entire continuum of care. And we are happy that today we are here at Samburu County Referral Hospital for this very important activity where we have launched a cancer treatment center here. And it is not just about the launch, it is actually beginning with actual treatment. Today we have been able to treat 4 patients who have received treatment, and we've all witnessed, with prostate cancer and other different types of cancers on day 1.
We are here at the Lodwar County Referral Hospital to launch a clinic or a center for the treatment and diagnosis of cancer cases here in Turkana County.
Part of our initiatives towards reducing the burden of cancer in our country is to increase access to treatment and diagnosis and treatment of cancer for our patients. We are happy that the patients will not have to travel very far, they will not have to incur the cost, and they will get treatment right here close home, and by evening they should go back home. We are happy we are making commitment while our first patients today have actually received treatment here. So we did not come with promises that we will come and set up a center, but we have come walking the talk, and this is because of the able leadership in the ministry and the institute to make sure when we visit, we shall leave a mark.
Kenyans can now access cancer treatment services at a much cheaper cost after Kenyatta University Teaching, Research and Referral Hospital received a cancer treatment machine. The machine will facilitate painless, non-invasive procedures on prostate, liver, lung, breast and brain cancers, among others.
This event is therefore a true milestone in our national healthcare journey because we are here to launch a center which represents the convergence of high standards of treatment, state-of-the-art technology, affordability, and effectiveness in cancer treatment. Kenyatta University Teaching, Research, and Referral Hospital will deploy an advanced robotic radiation treatment machine known as the CyberKnife, which introduces revolutionary capabilities and enhanced efficacy in cancer treatment by locating, tracking, and accessing tumors that are ordinarily difficult to reach with precision. Again, I agree. Now we will move to CyberKnife precision. The technology is therefore able to administer more radiation with great precision, meaning that fewer sessions, maybe 4 to 5 only, instead of 20 to 30, are required, with each session lasting only between 5 and 15 minutes. This will significantly improve treatment outcomes and be able to deliver these services better, affordably, and much more effectively. Cumulatively, these advantages lead to shorter recovery period, minimal side effects, and better overall outcomes. The government therefore intends to sustain its investment and support for highly advanced diagnostic and treatment equipment to actualize the highest standard of treatment and care for all people. The CyberKnife technology at this hospital is the second in our continent, the only other being in Egypt. This propels Kenya to the frontier of advanced medical technologies and catalyzes our strategy to quickly emerge as an advanced regional and international medical hub. Its location is in a public hospital sends a strong signal to all Kenyans that it is no longer necessary to travel far away for advanced treatment that are now available, accessible, and affordable in our public hospitals.
What we've done as government is that we have cascaded the issue of early testing to the county level. And that earlier testing from the county level will involve centers that we've developed. At the moment, we've developed around 4 cancer centers, regional centers.
We therefore encourage Kenyans to utilize our diagnostic and treatment services within the country. There isn't much need to travel abroad now for treatment as it has been before. We have the latest of equipment, including CyberKnife, including PET scan for diagnosis, including surgical treatments that are so minimally invasive and treats cancer, laparoscopic surgeries, which our fellow homegrown trained and also international trained healthcare workers are able to deliver right here back at home through our centers of excellence within our regions and the national hospitals that our country has established. We are also interested that in the care that we provide is quality across the entire continuum of care, and we wish to assure the public that whatever care you will get from prevention, National Cancer Institute of Kenya is interested to know what is the quality. So we are inspecting, certifying and designating cancer centers based on established guidelines that are internally and externally validated, that was contributed in its formulation and development by the users themselves and the stakeholders to guarantee quality of care at all times. In our country, the capacity has increased immensely over the last 10 years. And almost every county, through the MESS program, almost every county now has increased capacity in diagnosis. We almost have a CT scan in every county. Lately, through our strategies to improve cancer care in our country, we've been doing every county cancer action plan. And we have noticed most counties have CT scans capacity, because that's the basis of diagnosis on radiology and imaging. We have a challenge though in pathology.
Okay.
Where we have very few doctors in that area and we have very limited equipment and infrastructure. But certainly there is a lot of improvement. We are charged with another huge responsibility of capacity building. This is either informally through training of including community health promoters.
Na cha muhimu pia zaidi, screening ya cancer. Screening ya cancer. Elezeni watu wajue kwamba cancer screening si ya mtu mgonjwa. Cancer screening ni ya mtu mwenye ako na afya yake yote. Sawa sawa. Kama wewe saa hizi hauna homa, hauna headache, hauna kichote mbaya, wewe ndio mtu ambaye unafaa uende kwa screening. Ule mwenye ako na signs, huyo hasa ile screening tena. Huyo mtu ambaye anaenda kwa diagnosis. Sasa si screening. Screening ni ya watu ambayo wako na afya yote vizuri, aende angaliwe kama labda kuna dalili yote ya cancer. So mtu asiseme kwamba bado hajagonjeka, sasa kwa hivyo haendi kupimwa cancer, aende kata screening.
WHO, has called on us to close the care gap, and we're really working on that. And the National Cancer Institute of Kenya, which is the agency mandated by Ministry of Health to reduce the burden of cancer in our country, is very strategic at this point in time. And I mentioned earlier on that we have a plan that we are implementing to the latter, called National Cancer Control Strategy 2023-2027. By the time this is implemented, with the support that the theme of this year is calling on nations to invest more resources. And we are really asking, the government through National Assembly to allocate more resources during budget making process to cancer, because it is one disease that is really terrorizing all of us. It terrorizes our social life, our economic life, our spiritual life, our physical lives, and people do not work. It's an economic, issue as much as it's a physical issue. I would also wish to bring confidence to the public that National Cancer Institute of Kenya is committed and it is dedicated to deliver on its mandate to the latter. Because 10 years down the line, since NCI was established, it is an opportunity that we demonstrate to the public what capacity we have. And so much has happened and so much is still desired of the National Cancer Institute. We are building confidence to ensure that we solve our local problem. And the only way is one other key pillar, mandate, function that NCI has, which is cancer research. We are an institute, and the public is asking us to solve our local problems. For a long time, we have relied on foreign data to treat our patients, to diagnose our patients, to prevent some of these conditions. But we do recognize that genetically we are totally different. Clinical trials which were used to develop drugs, develop devices, develop equipment might not have included our local participants in Kenya, in East Africa, that we may share a particular genetic pattern. And therefore, we may undertreat or overtreat our patients because metabolism of these drugs, or also the densities of our tissues, if it is diagnosis, is different based on our genetic makeup. And therefore, we are coming strong at this point in time, confirming to the public that we have the right infrastructure now to conduct local research. We have identified our local gaps And we are going to look for solutions through research, cutthroat research for that matter, across the entire continuum of care. We have the National Cancer Control Strategy. This is a sector strategy that has been handed over to National Cancer Institute of Kenya to implement in totality, collaborating with other national agencies and also with other partners in private sector and within government, including county governments. It is costed at 49 billion. These are the resources that we are asking for the next 5 years to implement this national cancer control strategy. Our mandate is huge. We promise that we will deliver on our mandate. We have the right governance structures to ensure there is transparency and accountability on the resources that are invested in cancer through resource mobilization from the partners and grants from the national government. We have an oversight body, and we have also the Office of Auditor General that then looks at our financials every year to ensure that resources are prudently used towards cancer prevention and control. I would then wish to give Kenyans confidence that with the mandate NCI is being given, we are not leaving any stone unturned until we make sure that we reduce the burden of cancer in this country by making sure that we prevent most of the cancers so that the incidences can go down, or in the event that cancer is diagnosed, it be early so that when we offer treatment, it will be with curative intentions. And at the same time, we will ensure that morbidity, complications that occurs while going through treatment becomes less. We would want to widen the gap between those who are diagnosed and those who unfortunately we lose due to complications of cancer. You have our word. We are going to address this cancer issue. We have all the support within the country and without. And we work with all partners. We are calling everybody to be responsible. We are calling everyone to play their part and ensure that together we are mobilizing all resources, financial and non-financial, to ensure that we reduce the burden of cancer. Thank you very much. May God bless you. Until next time, once again, my name is Dr. Elias Meli. I am the Acting Chief Executive Officer, National Cancer Institute of Kenya. Thank you.
Right, thank you very much indeed, KSG. Please don't move. We're still waiting for more people to troop into the hall so that we can start our first session of this meeting. So we should be starting in the next few once we have a sizable crowd in the room. Otherwise, let's continue enjoying some beautiful music from KSG Choir. Thank you.
Moto wa roho, moto wa roho, moto utushukie. I declare that moto unaposhuka ushukie kila mmoja wetu na urejeshe tena, urejeshe tena. Kilicho si cha Mungu kichomeke usiku wa leo kwa jina la Yesu, kwa jina la Yesu, kwa jina la Yesu. Moto wa roho uchome. Unapotushukia, kama hujanena na lugha, moto wa roho ukiingia utanena na lugha. Sharaboze kayana na moze, sheketerere boze, shadararaboze rerema keteraboze. Holy Ghost, Holy Spirit, Holy Ghost.
Very well. Thank you, KSG Choir, for that beautiful song, Kenya Baba Yangu, Kenya Mama Yangu. As they finalize on the next item, I would request the next panel to come on stage, led by Dr. Tracy Irura, consultant clinical oncologist at the Kenyatta University Teaching, Referral and Research Hospital. Please come to the stage. Let's applaud Dr. Tracy Irura as she comes to the stage. Dr. Tracy is a clinical oncologist at KUTRH with a focus on breast, gastrointestinal, gynecologic, and brain cancers. She applies evidence-based care through a patient-centered lens and contributes actively to oncology education in Kenya and beyond. Also, to come on stage, we have Dr. Elias Meli, the Chief Executive Officer at the National Cancer Institute of Kenya, NCI Kenya. Let's put our hands together for Dr. Elias. Dr. Elias Meli is a seasoned medical and radiation oncologist with a robust portfolio in clinical care, research, health policy, and leadership across public-private sectors. He currently serves as the Chief Executive Officer at the National Cancer Institute of Kenya, where he spearheads a national effort to align cancer prevention and control with Kenya's universal health coverage, as well as Vision 2030. Help me also to welcome Dr. Gladwell Gadesha, Head, Division of Non-Communicable Diseases, Ministry of Health, Kenya. Dr. Gadesha, where are you? Please help me in welcoming Dr. Gadesha on stage. She is a seasoned medical epidemiologist and public health expert currently serving as the acting head of division of non-communicable disease, NCDs, at Kenya's Ministry of Health. With over a decade of experience in epidemiology, health system strengthening, and national policy implementation, she has been instrumental in shaping Kenya's multi-sectoral NCD and prevention as well as control strategies. We also have Mrs. or Miss Mary Ann Musangi, a board member of trustees, National Cancer Institute of Kenya. She is a philanthropist as well as an industrialist. Where is Dr. Mary or Miss Mary Ann Musangi? Are you in the room? Mary Ann Musangi. All right, as we wait for her to get into the room, we also have Dr. Miriam Mutebi, President, AORTIC, Consultant Breast Surgeon Oncologist, Assistant Professor, Aga Khan University, Board Directors at UICC. Where is Miriam Mutebi? Doctor, please welcome on stage. She's the President of the African Organization for Research and Training in Cancer and a leading breast surgical oncologist at Aga Khan University Hospital, a clinical epidemiologist and health systems researcher. She pioneers access-focused cancer innovations across Africa with a particular emphasis on women's cancer. Thank you very much. And also help me in welcoming on stage Phoebe Ongadi, the Executive Director at the Kenya Network of Cancer Organizations. Let's put our hands together. I know we have a lot of energy. We've just taken a very wholesome lunch, so we still have that energy. Dr. Phoebe Ogandi is a dynamic public health advocate and the Executive Director of the Kenya Network of Cancer Organizations, KENCO, a national umbrella body comprising over 70 civil society organizations engaged in cancer prevention, treatment, and survivorship, with over 15 years of experience in health systems, strengthening policy, advocacy, and community engagement. And finally, we have Dr. Evelyn Alela, Board Secretary, Kenya Network of Cancer Organizations. Please help me in welcoming Dr. Evelyn Alela. She's a pharmacist, breast cancer survivor, and medical director at Laurea, East Africa. She serves as board secretary for both the Kenya Network of Cancer Organizations and triple-negative breast cancer, Kenya survivors. A passionate advocate, Evelyn drives cancer's awareness through community outreach, social media, patients education, and survivor support. So the panel this afternoon will be chaired by Dr. Tracy Irua, and the conversation will revolve around why unity of voice and action matters now. Why unity of voice and action matters now. This is a conversation that is going to be led by Dr. Tracy Irua. Daktari, karibu sana.
Thank you very much for the warm introduction. Very happy to be here. Hope you were well and you had we had a very fast and vibrant first session. So it's my honor and critical responsibility to open this session on the theme that could not be more urgent, which is why unity of voice and action matters now. In Kenya today, cancer is not just a health issue, it's a national development challenge. We are witnessing rising cancer cases, late diagnosis, financial devastation for our families, and overstretched health systems. Yet, amid these pressing challenges, we also see good momentum. The national cancer strategies improve access to diagnostics, new treatment centers, and a growing will across sectors to change this story. But momentum without coordination leads to duplication. Resources without alignment lead to waste, and voices without unity risk being drowned out by noise. This is why unity of voice and action matters now, because fragmented efforts cannot win against a disease as complex and devastating as cancer. We must speak with one voice, whether in policy advocacy, research priorities, patient navigation, or even financing. We must act with one plan, align government, counties, academia, private sector, and communities. The patients who are seen in Busia, the oncologist in Kisumu, the policymaker in Nairobi, and the community health workers in Kitui, they must all be pulling in the same direction. And that direction is towards equitable, accessible, high-quality cancer care to every Kenyan. So today's session is really about aligning our voices. I think in the morning we really spoke about, and our leaders were here to tell us the different government initiatives that we have. So for now, in this particular session, we want to know what our timeline looks like and what the action is actually. We can welcome our panelists as we start. So I'll start with you, Dr. Meli, obviously. And we just want to know, as NCI, what exactly are you doing to align the diverse stakeholders behind a unified cancer agenda? And what are your key barriers to trying to coordinate these stakeholders?
Well, thank you very much, Dr. Tracy, for this opportunity to sit in this session. It's been busy morning, and glad that we are having this session this afternoon amongst many sessions that are related across the entire summit. Specifically to your question, diagnostics plays a very key role, and to be very honest, if we do not have a well-coordinated capacity to address that accurate, correct diagnosis, then we would not be having a patient to treat, and with what outcomes. So the biggest barriers that we've noticed over time is, of course, related to resources largely, and additionally, even with the limited resources that are available in this space, optimization of these resources has been also another challenge. And that is why having this conversation here today, all of us as stakeholders, taking stock of what is, within all our institutions, whether public or private, whether faith-based, local or international, how do we then, first of all, account for what exists in the entire cancer ecosystem? And second to that is, how do we then optimize what exists? Because the reality is, we know from our policy implementation that we need to embrace precision oncology, and it begins with making the right diagnosis, whether it's pathology or imaging and radiology, but that diagnosis has to be made right for us to be able to look at what targets. Right now we are at an era of looking for specific targets. We consider them biomarkers. You want to look at it and say, hey, I'm no longer going to burn the forest to kill, a snake, but I want to figure out where the snake is. Address that one with a particular specific target. Whether systemic treatment or whether radiotherapy related or surgical treatments that we know are our pillar treatment modalities. I also want to acknowledge the fragmentation in the system as well as a challenge. That because of, our different interests, we find ourselves, duplicating and overlapping resources that we should actually be investing in this space. Again, I reiterate, it's the reason why all of us are here today, so that, for once we are able to speak one language, get better coordinated, and it's really why the National Cancer Institute of Kenya was created in the first place, to make sure that we are able to speak to one another, to make sure we are able to optimize resources that are available. I would, put it bare. When I got involved at the National Cancer Institute of Kenya, I actually, at an early, time, realized that we had 11 institutions within Nairobi County alone that was involved in HPV screening for cervical cancer, to be specific. And we were using different technologies to screen these patients within the same constituency of patients. And it's the same across the country. So we are uniting our voices through this summit to make sure even these barriers that we realize, we are better coordinated so that the limited resources that we are pulling together can be there for impact. Thank you.
Thank you very much, Dr. Meli. Very comprehensive answer. There are quite a number of things they are trying to do there. We go to Ministry of Health. So Dr. Gladwell, just give us a brief on what the Ministry of Health is trying to do to unify the fragmented cancer landscape.
Yeah, thank you so much, Dr. Tracy. And I think I would first like to say that really the key message of the Prime Cabinet Secretary really personified what we mean to be united in the cancer space, really breaking it down to what are the roles of each of the actors and players. So realizing the importance of having coordinated planning and policy implementation, the ministry developed the national NCD strategic plan that is ending towards 2026. And the very first pillar talks about multi-sectoral control and also partnership, in the realization that everything else that then follows will have to be done in a coordinated fashion so that we achieve the aspirations and the goals of the strategic plan. The driver towards this unity is an intersectoral body we call the NCD Interagency Coordinating Committee that is disease-based. So there's a place for Cancer Technical Working Group that looks at coordination both from within and without health. That was also really emphasized earlier on. When you look at sectors outside health, there is the role of other ministries play in the issue of risk factor prevention. And from what our survivors talked about earlier in the morning, Father Charles, Mwende, and also Robert, they said that beyond the health issues, there are also other social issues that needed to be dealt with. And that's why working and going beyond the Ministry of Health and working with people like the Ministry of Education hence become important. And then when we look at the health space itself, you look at the players within the continuum of care, from prevention all the way to survivorship and palliative care. And also importantly, look at the colleagues in the communicable side, because there is a lot of interactions between cancers and also some infectious agents, like the increased risk of cervical cancer among women living with HIV. And then most importantly is looking at the person with lived experience. The continuum of care they face really has to inform what we make as policies and also how we implement as policies. And to ensure that this unified body goes on well, it means that it has to be led also well from the front. And we step aside and say, it's not just a Ministry of Health affair, it has to be also with sectors outside the Ministry of Health. That's why there is co-leadership when it comes to both the technical working groups of cancer and also the ICCs, the Interagency Coordination Committee. So we say that there has to be a chair from Ministry of Health and also a co-chair that is away from the Ministry of Health. And what is also important is that that body really needs to be a dynamic one that is constantly evolving to bring in new players and to bring in new mandates. And also lastly, it's a body that is able to reevaluate itself against its set mandates, such that at the end of the day, how many active players do we say that we are engaging in the table? Is it just a few voices, or we are getting the entire spectrum in terms of disease representation, demographic representation, even geographical representation? So we try to achieve that through policy and formation of coordinating bodies that bring all players together. Thank you.
Thank you very much, Dr. Ari. I think we have a lot of hope from Ministry of Health. What they're trying to do is bring all our voices to the table and coordinate this. So we'll go to Dr. Miriam, who wears two hats. She is a clinician, she's a surgical oncologist, and on top of that, also she's the president of AOTEC. So my question to her is, as professions, the agenda that promotes unified clinical and training and research standards, how are we as professionals supposed to plug in?
Thanks, Tracy. And I think listening to the previous comments, maybe we need to take a step back and think of ourselves. We've done all these incredible efforts, but then we do need to think about the broader 30,000 feet view, because we're not, in the spirit of Ubuntu, we say I am because we are. So we might be doing well, but then if the rest of the continent or our neighbors and stuff are lagging behind, then that ultimately has impact on all of us. And so we look at how can we collectively raise the collective. For instance, there's no reason in this day and age why patients in sub-Saharan Africa are paying 3 to 4 times the cost of a cancer drug than, say, in an equivalent low and middle income country in anywhere else in the world. But that's really because we have sort of operated in silos. Even as we approach our education or procurement, we're looking at how does Kenya acquire, how does Tanzania, how does Nigeria. But so there's really an opportunity for us to think about how do we broaden that scope. Now, in terms of looking at the professionals, I think there's a need to really build and enhance our professional societies. The organization, the African Organization for Research and Training in Cancer, which is really the largest and the oldest cancer body that's really trying to change the face of Africa, has really been working with different partners like Kesho and the NCI to look at how do we broaden, one, how do we expand oncology services, but two, how do we homogenize? Because that's very important, and we all have tales where somebody's come up with some treatment misadventure where, so you want to be able to say that the mastectomy you've had in Kenya is exactly the same as it is. And so in order to do that, we do need to expand the skill set, and it means that all the healthcare workers, irrespective of where they are, have the same skill set. And so part of the work that we've done with Kesho and the National Cancer Institute is really looking around what we call professional differentiation, which is really asking the question, who is an oncologist? Who is a clinical oncologist? Who is a surgical oncologist? It's not just training in terms of years, but what are the entrustable professional activities? We start throwing around big terms like EPAs, but really what we're asking is, if I have trained this person, how comfortable am I to have them deal or treat my aunt, my mom, my sister? That's really what we're fundamentally asking. And how do we have that same skill set, irrespective of where you are on the continent or in the country, such that we all have, everybody has access to safe, timely care. In addition to that, we've talked about the socio-cultural barriers, and so we do need to think about context. I think what we've done as educators traditionally has been really importing curriculums, cut and paste, and signing off, but then without stopping to think about, yes, I want to, have HPV screening, have I bothered to explain what is the benefit? What is the patient or what is the person's understanding of that? What is the understanding of the disease process? Because if you look at some local languages, the response for cancer is, the translation for cancer is the thing that kills you. If that is the understanding, then why would you come for care? So it's really looking at how do we build a workforce that is culturally appropriate and is able to provide respectful care, are really some of the areas that we do need to think about. And then, of course, we say all else is data. We've had this throughout the course of the conversation about the importance of data. But the real issue is, and I'm going to go off on my African tangent. I think it's Achebe who said that, until the lion learns to write, right, the hunt will always glorify the hunter. And if we look at how we are doing in terms of the research output and production, we are only doing 8% cancer research, 8% of all African biomedical research, with, wait for it, 5% of the countries in North Africa actually producing 67% of all African research, which is clearly an opportunity for us to think about how can we work collectively to, one, generate good, solid data that ultimately translates into better patient outcomes. Yeah.
Thank you very much, Dr. Miriam. I think that is a very good way of putting it. So as professionals, we do have a big role in doing more research for our people, because our people are not like the others. So we'll go to Ms. Phoebe. I think we've all seen the patients here today. It was very, very nice to see patients, especially as a clinician. My question to you is, how is the civil society unifying grassroots voices into a powerful movement that can shape the national cancer priorities and the social accountability?
Thank you very much, Dr. Tracy, for that question. We start by emphasizing that the civil society is the link between policy and implementation. So then we start by also emphasizing that for the uniting grassroots voices to work, the civil society should be involved at the inception of the policies, not at the tail end. Why? Because we are the ones who are closest to the people. We hear the failures of some of these policies first. We will hear when the access fails, when the cover fails first. So we want to be involved all the way through. And one of the ways that also came up very good in the morning is that recognizing the lived experience as expertise. And I think KENCO is leading from the front. If you look at KENCO's board of governance, 60% of them have lived experience. And not just lived, but learned. Because we also have oncologists who are living with cancer. You can imagine the difference an oncologist living with cancer will bring to a table of decision-making concerning cancer patients. For example, right now, we are grappling with the shift from NHIF to Social Health Authority. The civil society hears it first because we are the closest to these people. We are saying that we are happy that now there was the increase of from the 400,000 Kenya shillings with the capitation to 550. But if you heard the CS speaking today, he said very well that he wouldn't like Kenyans to choose between having a meal on the table and having treatment. But qua ground, that is what is happening. Cancer patients all over are grappling to choose between putting a balanced diet on the table and having the much needed care. So we are saying, if only we got involved at the beginning of this policy, maybe we could have given different opinion to it. And even out of that, the out-of-pocket payments is too much. Cancer racing against time. It is a disease that is not waiting for budget allocations. It is not waiting for policies. It is not waiting for decisions. It is you act now and you act right. And acting now and acting right, please do it with the patient in mind. And we are seeing even, for example, looking at even NCI that has convened us today, they gave out a budget to the Ministry of Health. And part of the mandate of NCI is also to support the civil society. What do you do when that budget is only funded at 15%? So Dr. Meli seated there will not tell you, but even now he has not received the capitation that he needs to take the institution going. So that needs to be handled. The primary healthcare fund, we are grappling with 70% late diagnosis. Why? Because of the lack of screening and lack of early diagnosis. The primary healthcare fund on paper should have given us 61 billion Kenya shillings, but qua ground we are having 4.1 billion. Standard one child will not understand the difference between 61 and 4 billion. So until even the emergency chronic fund is another one. So we are saying that the lived experience and the civil society should not be involved at the tail of it. They're involved at the beginning and also during the policy. And when we do that, then we have what we call meaningful engagements. Meaningful engagements, and as KENCO, we are taking the meaningful engagements very seriously because we want to have a civil society roundtable. The civil society voices is critically important because we are the grassroots. And if you're not clapping for me, KENCO will clap for me. Thank you very much for clapping. The patient voices have to be included. The civil society have to be included. We are saying the government has done well, but there is still much to be done.
Well done, Phoebe. I mean, let's give her a round of applause. She speaks for our patients, and she speaks for the people she sees on every other day. They are grappling with SHA issues, and I think this really needs to be heard by the stakeholders. Well done. We go to our last panelist, Dr. Alela. She's also a patient champion. So my question to you is, as someone directly affected by cancer, how has the lack or the presence of unified action impacted your experience, and what change would you like to see the most?
Thank you, Dr. Tracy, and I'm honored to have this privilege to sit here representing the patient voice. I'll speak not about my experience, but a recent case that was brought to my attention by one of our patient advocates and navigator from Bungoma. This is a conversation we had on Saturday. So a patient came to her. This patient is from Bungoma. So she was in pain and eventually went to Eldoret for checkup. So she went and lots of tests were done, including a biopsy. This patient went back to Bungoma, went back home. So while she's waiting for her biopsy results, she's told that she needs to go for another biopsy. And she doesn't know why. And she's tried to get a SHA pre-authorization, and SHA said we cannot pay for 2 biopsies in 1 year. So this is a patient who is struggling financially. We are seeing the emotional burden that this has brought on her. So she doesn't know what to do. She is lost. The only person she has next to her is a survivor who is also limited in terms of what she can do. So this is one of the problems where we see when we are all not speaking the same voice, because SHA feels that 1 biopsy is enough for the patient platforms, because we are talking about patient centricity. We are here because of the patient. We need to have the patients at the table where decisions are being made about what needs to be done to them, for them, and about them. And secondly, we want to see resource sharing between different stakeholders. The government, the private sector, the patient groups, and civic societies. Let's all be generous with exchanging information and resources so we can all speak in the same voice. And thirdly, I think we are doing a very good effort. I want to see amplified awareness campaigns which lead to early detection and reduced stigma. Stigma is a big deal. Mwende spoke here about stigma. Marine spoke about stigma. I don't think there's any cancer patient who has not experienced one sort of stigma or the other. And the more we speak about it, the more we have conversations around cancer, we demystify it and we normalize conversations around cancer. And then we also, when it comes to data collection, I think we have a lot of data, we have a lot of statistics, but we need to have a patient behind these numbers, because statistics are good and they help us make very, very good decisions. But we need to put humanity behind this data. We need to put humanity and a face behind these numbers so that it can bring us to the reality of what is happening on the ground. And last but not least, unified messaging. We all need to speak with the same voice and have unified messaging. This is also going to help, especially to demystify a lot of misconceptions and myths that are really, really plaguing patients around the cancer spaces. Thank you.
Thank you very much. Please. So I'd like to close this session. I think it has been very, very insightful with our panelists. Some of the things that we really need to do is actually synchronize whatever is on the ground, when you cook kwa ground, and the policies that we have launched like today. As we close this vital session, I'm reminded of a simple truth. In the fight against cancer, we cannot be silent and we cannot be siloed. It's dangerous. If we were to build a Kenya where cancer diagnosis is not a death sentence, where geography or income does not determine survival, then unity must unity must begin. As we close this session, at the end of the conversation, this is not the end of the conversation. Let's keep on talking to spark a movement, one voice, one agenda, and many hands. I hope for the next NCI Conference #3 Summit that we will see many survivors in this room. We saw them, they were filling the podium. Next time we should see the whole room is full of survivors. Thank you very much.
Uniting our voices? Uniting our voices? Uniting our voices? You know, after lunch, sometimes people can get a bit drowsy, right? So let's try and keep alert. Let's remember what our theme is, uniting our voices and taking action. And this is not just a slogan, it's a call to action. So we are now moving into a different kind of session, which is a presentation by Dr. Harish Nagaraj. He's a dual certified consultant, radiologist, and nuclear medicine specialist, currently leading the Integrated Molecular Imaging Center at Kenyatta University Teaching, Referral, and Research Hospital. He holds a postgraduate qualifications in diagnostic radiology from the University of Nairobi, a fellowship in nuclear medicine, and PET-CT from the Bangalore Institute of Oncology, and a master's in oncologic imaging from the University of Pisa. Let's give him a warm round of applause as he walks up to the stage.
Good afternoon, everyone. Thank you for the nice introduction. Yeah. So today I'm here to talk about precision imaging in precision oncology. From morning we have been hearing to most of the stakeholders what they are talking about and where the importance lies in oncology. So my talk here would be mainly talking about the role of PET-CT, which has a great value with the current setting, which lies from diagnosis to treatment response. So the image you're seeing in this slide is where I come from, Integrated Molecular Imaging Center, which is in Kenyatta University Teaching, Referral, and Research Hospital. There is a story why I have posted this picture here. This center alone from 2022 has served more than 15,000 patients, and not just from Kenya or the neighboring countries, but also around 20 African countries. So that's a milestone in itself. So I have nothing to disclose. My outline of presentation is I want to just bring in key milestones in nuclear medicine, which is happening in Kenya from past like 5 to 6 years, and also talk briefly about cancer burden in Kenya, and then the indications of PET-CT in mainly in oncology. So nuclear medicine, if you look at it from the year 2019 and 2025, it has taken significant leap. And in the year 2019, we had just one cyclotron and one PET-CT scanner. Fast forward 6 years now, we have 3 cyclotrons and 7 PET-CT within the country. And this is a testimony for also a government which is actually really putting a lot of emphasis on oncology, and that's how the growth has been. And other significant achievements we have within the country is we do host first digital PET-CT, which is very useful in terms of low dose in dosage of radiopharmaceutical and also image acquisition. And we have a high energy cyclotron in KUTRRH, that is 16.5 MeV. And this alone actually can supply the whole East African belt, not just the country itself. So that's what the capacity is currently. Regarding tracers, when we started early in 2019, 2020, we just remained with the conventional FDG and FPSMA. I think most of the people know about these two tracers. But again, in this year currently, we have actually 3 more tracers in the country. That is gallium-68 based PSMA, FAPI, and Dotanok, which I'll be sharing soon. I'll be showing the images. And also the significant achievement in terms of not diagnostic alone. There's something called as Diagnostics. So we are starting to give treatment for castrate-resistant metastatic prostate carcinoma, and that's now lutetium-177. So even including our CEO, Dr. Nelly was mentioning that the new incidence versus the deaths, this is what actually scares most of the people, and that's why the need of accurate staging is so important in cancer. So that's the statistics. And then before even talking about PET-CT, it's not good to not acknowledge the people who have invented this. And that's the Sir Godfrey Hounsfield, who has invented CT. And these are the 3 gentlemen invented PET. And another key thing I want you to note here is PET-CT was approved by FDA in as early as 1999 October. So we had the first PET-CT in the country in 2019. So we are not that badly off compared to many other African countries. So Kenya is doing really good in terms of this. So just a brief for the people to know what PET scan is. So PET, as it stands, it's positron emission tomography scan. It's a scanning procedure which actually allows you to see what is happening physiologically in the body, apart from just the anatomic image which is captured on CT. So on the right, you're seeing that there is the PET-CT machine which is housed at KUTRRH. And what advantage does it give over the conventional imaging? The normal CTs which we do gives anatomical relation, like where the lesion is actually. But whether the lesion is viable or not, PET actually makes it to be seen. Then going to indications for performing PET-CT mainly in oncology. So there's various indication oncologists actually ask for. There are many patients sent to us to various reasons. And the key reasons mentioned here is to differentiate the benign from malignant anatomical lesions. Sometimes detect an occult primary in cases where the patient has a significant disease burden, has metastasis all over, but they don't know the primary lesion. So in that case, it's useful. And also now, if you look at the treatment response, the patient has been given chemotherapy and also been done radiotherapy. However, they don't know whether the treatment is working or not. Probably sometimes patients develop some toxicity based on chemo. So we might have to check and then advise about them. And also, one of our previous panelists was mentioning there was repeat biopsy, and then there is also significant burden on the government or even the SHA, for example. So PET-CT allows us to get a good diagnostic kill without multiple interventions unnecessarily. And also it guides radiation planning, and it differentiates post-therapy changes versus whether there's active residual disease or not. So when we are talking about benign versus malignant, this is one of the lesions. I wanted to show the case, whereby see on the right side, we see 8 millimeter lesion, roughly, which was seen on the CT, but now the doctor could not confirm whether it was malignant or not. Hence, the patient was sent for a PET. You can clearly see that in the top row, image C, you can see a avid lesion, very focal uptake in the upper lobe of right lung, which was confirmed to be malignant. So this adds a value in terms of PET-CT. And also this case which I was mentioning, this patient had, these all are, by the way, these all images are from Kenya, from our collections, and we had taken consent before publishing it. So this was one of the cases where we can see an avid uptake here, and that's in the liver. So the patient had done an ultrasound and biopsy came as metastatic adenocarcinoma. But the patient didn't have any kind of primary focus. And on our PET, we could see there is a faint or low-grade uptake in the left side of the breast. And the biopsy was done, and it was confirmed to be the primary. And also, our PET-CT has a surveillance role here. The image on the left, which shows some 2 nodules around in the chest area, whereby after the treatment, the lesion had disappeared completely. This is also one of the interesting which we had. The patient had done a staging, CT staging, and CT had shown M0 disease. However, the patient was complaining of some left hip pain. So the doctor was not very convinced whether this patient has really M0 disease or not. So he was sent to us. If you look at the bone window here, axial image, there is no significant difference. It's actually very symmetric. I don't see any osteoblastic or lytic lesion. However, when you look at the PET as well as the fused image, you can clearly see that there is avid uptake of the tracer there, confirming that it's a bone metastasis and it is M1 disease already. So the treatment completely changes. From radical intent now, the patient has to be thinking of systemic therapy. And also the advantage is other case, that was a lung carcinoma, and the doctor was suspecting if there was any other lesions outside the primary site. Here also we can see that the lesion was just restricted to the lungs itself. There was no other disease outside. The same topic, why we are repeating biopsy. If you look at this case here, the axial image here, all we can see is a presacral soft tissue density lesion here, and we don't know whether what's happening within the. This patient had underwent a biopsy, but it came as negative or it was necrotic. So if you clearly look at the arrow here, the PET-CT scan shows that that's a photopenic area, meaning to say the area is very light. Usually what is dark on the PET image is where the disease is. So the radiologist, the interventional radiologist actually went to the photopenic area where it is corresponding necrosis. The same can be depicted on the fused images. So in these cases, what happens is if we had, for example, if we had a PET scan earlier, the radiologist could have directly gone to the avid area, whereby now getting a viable sample for detecting the disease. And in terms of treatment response, you can see that that top row shows lymph node in the supraclavicular or infraclavicular region, whereby there's a focal avid uptake in the node, soft tissue density. We can clearly say that that lesion is no more seen in the scans after the chemotherapy. However, there was also a focal uptake in the scapular region on the left. So here also, PET-CT sometimes, as much as it shows the way, we should also not be confused to call everything disease. So that was just a benign or physiological uptake in the muscle noted. This is also another interesting case from, this is our own patient from OI. Patient had a rectal carcinoma. The patient was treated and we had given them completely metabolically non-active disease in the rectum. However, we had seen a focal uptake within the distal transverse and descending colon. The patient actually went home and they didn't actually do a colonoscopy. Fast forward 1 year, we can clearly see that the lesion had grown and then the patient had come. So sometimes, as much as the doctors here, they feel there might not be any, I mean, it could be a physiological uptake. You know, there is a reason sometimes we ask you to do a colonoscopy just to confirm whether there was disease. So this patient, luckily, they didn't have any other spread. So the treatment was quite easy, even for another surgery. So the role of PET-CT in also RT planning, here you can clearly see, if you look at the CT alone and treat the patient, you would have also countered the atelectatic area or the collapsed lung segment here. Whereas on the PET-CT, we can clearly see the lesion where, a good delineation, and then probably we can treat only the affected part instead of non-viable tissues. And I think this is my second last case. So here what I wanted to show is this patient had a prostate carcinoma and was sent for PSMA PET CT. However, when we did the PSMA scan, the uptake was not so great. So we thought, could it be like prostate cancer, or could it be something else? So we sent for a rebiopsy, just to note that the case was actually converted into neuroendocrine dedifferentiation. And since it was poorly differentiated neuroendocrine tumor, we did FDG scans, and you can clearly see how the uptake has changed. So the tracers are always, it's actually at the virtue of the imaging specialist to choose what exactly is better for what kind of histology. So it's always good to discuss among ourselves to see which tracer can benefit the patient in case. So with regards to new tracers in the country, currently we are doing FAPI and Dotanoc. So in whole of East and then Northern Africa, there's no other country doing Dotanoc. So this itself is a testimony for us that patients are actually, Kenya is becoming an inward medical tourism for Dotanoc scans, and we actually leading the way in terms of nuclear medicine. So these are the two scans I wanted to show. This is it's a well-differentiated rectal neuroendocrine carcinoma, which shows metastatic disease predominantly in the abdomen. And the other case is primary was in the liver, and it also shows metastasis spread well. And this is a completely new tracer, which we have in the country. And this is a metastatic CA breast left, which you can see. And this is a new tracer called FAPI. The advantage here is, if you look at our conventional or even the routine FDG scans, whereby we have high uptake in the brain. So here the brain is completely light, and then we can pick up the subtle brain metastasis very clearly. So this is also one of the traces here. And my last slide, what I want you guys to take home, the message here is PET CT usually changes both staging and therapeutic management for various cancer. In vivo quantification of tumor status and burden, it always has advantage of better identifying loco-regional and distant metastasis when you compare to the conventional anatomic imaging modalities such as CT or MR. In terms of when there is an upstaging of a case, it definitely decreases the number of futile and invasive interventions. And PET CT, by far I can say it's a gold standard for early identification of residual disease and recurrence. Thank you so much.
Thank you, Dr. Ari, for that insightful presentation. And just before we get into the next session on diagnostics, we would like to call onto the stage Hope. You know, in every conversation, you have to have hope, right? Especially in a cancer conversation, right? So let's give Hope an opportunity to give us hope with her poem. Karibu, Hope.
Good afternoon, everyone. My name is Hope Omboy Ochieng. I'm 14 years old from Shadrach Kimalel Junior School. I am a poet using poetry to send messages of hope, create awareness on reducing the burden of cancer, and for entertainment. I do plant trees of hope to keep my poetry and awareness alive as a physical symbol. And my presentation for today is about uniting our voices and taking action. Welcome. In the silent, quiet rooms, where our hearts beat so loud, with a silent storm beneath a hopeful cloud, cancer rebounds are becoming too many. And with 24/7 diagnosis of cancer, and the tireless warriors in white coats, busy treating patients, lives are being lost, destroyed, economies going down because of cancer. Cancer may have stricken, but it cannot define the strength in our souls. From the wards to home, from near to far, we call upon stakeholders and take action. To unite and take action for our voices, our rights. From the national government, county government, and all the way to
Can you say that again? We made it through.
Call upon stakeholders to unite in reducing the burden of cancer in and out of Kenya. And to you, yes you, whether young or old, black or white, married or not, let's join the fight. Let's join the fight in uniting our voices and taking action. For it's not about race, political, or religious background. Neither Kenyans nor the African continent. It's we, the world, against cancer. So come with me. It's time we unite, innovate, and build a healthy Kenya. Yes, a world-class authority in cancer prevention and control. And soon, we'll look back and say we made it through.
Can you say that again? We made it through. And we don't know how we did it. We made it through. And we can't tell but one thing. We know Jehovah. Give him glory.
Uniting our voices and taking action.
I made it through, and I don't know how I did it. I made it through, and I can't tell how I did it. But one thing, Jehovah took it over, and I...
Favorite, eh? She's going to guide us around that song. You are free to dance. Ululate. Let's do this song some level of justice. Thank you.
Can't tell, but one thing, we know Jehovah I don't know how I did it. I made it through, and I can't tell how I did it. But one thing I know, Jehovah took it over, and that is how I made it through. I made it through.
I made it through, and I don't know how I did it. I made it through.
Come on, sing.
And I can't tell how I did it.
But one thing
I know, Jehovah took it over, and that is how
louder.
I made it through.
Oh, I made it through.
I made it through, and I don't know how I did it. I made it through,
And I can't tell.
and I can't tell how I did it. But one thing I know, Jehovah took it over,
And that is how.
that is how I made
Shout it.
it through.
I made it through.
I made it through,
Woo!
and I don't know how I did it. I made it through,
And I could.
and I can't tell how I did it.
But one thing I know
One thing I know,
is Jehovah.
Jehovah took it over,
And
that is how I made it through.
I made it, I made it, I made it through.
I made it through,
Woo!
and I don't know how I did it. I made it through,
And I can't tell.
how I did it.
But one thing I know.
This is Jadida Wafula. We have Aurelian Gena. We have Aurelian Gena and Rebecca Geruto. They are guiding us in the sign language interpretation. Let's give them a hand of applause. Very good. Ladies and gentlemen, now we're getting into our third session of this afternoon. And the conversation that we are going to have between now and 3:40 is unlocking access, diagnostic at the heart of equitable cancer care in Kenya and beyond. The chair of this session is none other than Dr. Njoki Jeraine. Let's put our hands together for Njoki. Njoki Jeraine is a consultant clinical oncologist based at the Cancer Treatment Center, Kenyatta National Hospital, where she serves as a clinical co-lead for breast, lung, and carcinoma of unknown primary. She is a principal investigator at the United KNH clinical trial site and serves as advisor to the Ministry of Health, Kenya. Dr. Jeraine also holds the LMIC chair position at the Pediatric Radiation Oncology Society. Let's put our hands together for Dr. Jeraine. Hear me also to welcome Dr. Elias Meli, Chief Executive Officer at the National Cancer Institute of Kenya. As I said, he's a seasoned medical and radiation oncologist with a robust portfolio in clinical care research, health policy, and leadership across public, private, and academia sectors. Let's put our hands together for Dr. Meli. Also on stage, we're going to have Dr. Kibet Kibor Keitani, or Dr. Triple K. He's a Deputy Director, Laboratory and Pathology Services, Moi Teaching and Referral Hospital, MTRH. Dr. Kibet is an anatomic pathologist and Deputy Director at Moi Teaching and Referral Hospital, where he leads efforts to expand access to cancer diagnostic in Kenya's public sector. He holds a Bachelor of Medicine and Surgery from Moi University and a Master's of Medicine in Anatomic Pathology from Aga Khan University. Have you ever sat or gone through the portfolio of doctors and you realize that the rest of us are not educated, by the way? You know, I don't know whether these names are supposed to, like, suppress our feelings, because somebody, anatomic, big names. Okay, the same thing with engineers. I think we need to have a conversation how we are going to standardize some of these titles, because they make you feel like you never went to school, you feel like you just bypassed school, but that's who they are, and they do a great job. Somebody else to invite on the podium: medicines, access, diagnostic, vaccine security, and local pharmaceutical manufacturing. Karibu sana, Daktari. We also have Dr. Samson Kuhora. He's the head of planning, linkages, and benefits packages at the Social Health Authority, Kenya. Where is Dr. Kuhora? And there he is. Let's put our hands together. He is a leading voice in Kenya's health financing reforms and strategic purchasing transformation. As head of planning, linkages, and benefits packages at SHA, he drives the design, integration, and costing of benefit packages, including SHA's emerging oncology and model aligned with the universal health coverage and fiscal sustainability goals. Karibu sana, Daktari. We also have Dr. Taufik Oloruko Oba. Is in the room? Yes, please. He's a transformational diagnostic leader advancing equitable healthcare access across Africa. As country manager for Kenya and head of East Africa network at Roche Diagnostics, he drives regional strategy, cross-sector partnerships, and diagnostic systems innovation to strengthen national health systems. With over 2 decades of experience in pharmaceutical and diagnostic leadership, he has served in pivotal roles, including head of West Africa and interim lead for Anglophone West and East Africa. Let's put our hands together for Dr. Taufik. The chair of this conversation is none other than Dr. Jeraine. Karibu sana.
Thank you. A round of applause for our panelists. And you might be asking what the oncologist is sitting with. Very serious and forward-thinking men have that privilege of asking them hard questions. So I think the conversation around diagnostics is so core, because if we are going to provide quality care, we must make the right diagnosis. At the same time, who is paying for the diagnostics? The challenges we already know that exist in our country, from lack of infrastructure, issues with the referral system, issues with results, patients having 2 names and 2 similar names. How do we have that conversation around that? And we were thinking of that this is multifaceted, and maybe the solutions, which I'm sure will come from this panel, will be able to answer that. So our engagement is because of the variety of players that are in this space, and ensuring that diagnostics are actually integrated into an essential and a component part of the universal health coverage. So I'll start with our host, Dr. Melly. So, as chair of the NCI, or as CEO of the NCI, apologies. So how would you put Kenya's current policy direction in terms of improving access to cancer diagnostics?
Well, thank you, Dr. Njiraini, and our esteemed delegates this afternoon. The conversation continues. We are here, as we rightfully said, that we have to work together as a team towards one common challenge. And one of the challenges that we have across the entire continuum of care, looking at cancer care holistically, is diagnostics. That is the subject matter this afternoon. And as a country, we have very beautiful, policy documents that guides what we would like to do. The challenge definitely has been, resources to fully execute whatever commitment we've made through very beautiful, policies that we've developed through the ministry, that we've adopted from, regional programs, and even WHO-led international policy guidelines. And as we continue, to address this challenge, there are emerging concerns that have always, required a policy directive. And this continuously happens in our country. And having the all stakeholders approach in developing these policies, then it demonstrates that we are working together. We have several policies that have been developed by us of course, under the leadership of the ministry and being implemented through the agency. And it is what then guides. We talked earlier on about the National Cancer Control Strategy, which has the second pillar, being diagnostics with pathology, imaging, and laboratory medicine, where I think it's a cup of tea for my good friend Dr. Kibet, who is going to talk about that, and colleagues who work in radiology and imaging space, that we have a clear-cut policy on how we would like this to be addressed. When we talk about before we confirm, and it's also supported by our regulators, before we confirm a patient has been diagnosed with cancer, which is very important. More often than not, we have faced challenges of misdiagnosis, we've faced challenges of underdiagnosis or overdiagnosis, and this has really affected, especially our patients, our clients, who before they become patients, they are human, that we have to be cognizant of the psychological aspect of information that we communicate. So whenever we have a challenge that requires us to adhere or comply to a particular policy, then it affects our patients heavily. So I must acknowledge that there is so much that has happened from a policy perspective, and these policies then helps us to give guidance to avoid fragmentation, and to make sure that we are all focused on one direction, where we do not have different stakeholders investing differently, also using different technologies. And again, policies helps us to appreciate evidence, because they are developed, generated from evidence, which is from research that are conducted locally, regionally, and internationally. So I must acknowledge that over the last 1 decade, there is so much policy shaping in cancer space. While we struggle with comprehensive implementation in the diagnostic space, there is so much that has happened. Dr. Arish earlier on presented about precision nuclear medicine in diagnostics and theranostics. We can appreciate for sure that guided by the policies, we have a direction. Even as we get a plethora of diagnostics in the country, we have to protect the patient from guided by the policies, so that we assure patients quality diagnostics that will then guide quality treatment that will definitely guide in providing better outcomes. So I'm happy that we are having these discussions. There is room, though, to engage and to improve on what is going on. Thank you.
Thank you, Dr. Meli. And then Dr. Kibet, just to bring you into the conversation, I know you're doing excellent work in Eldoret and the whole region. And as a clinician, maybe you can share with us what progress has been made, guided by the same policies, to access both pathology and lab, diagnostics specifically for cancer, and what you see as the most pressing diagnostic gaps currently.
Thank you, Chair. I'm sure from what we've had since morning, there is a critical role that is played by the lab and pathology when it comes to cancer, especially early diagnosis and screening. And for a very long time, before cancer started trending, pathologists were literally known for other things, mostly the forensic works. Forensic autopsy work, but with cancer coming in, there's been an evolving role played by the pathologist. And actually there are quite a number of pathologists who don't even do forensic work at all. Their work is just on the diagnostics, tissue diagnosis and the blood diagnosis. So in terms of the progress towards access of these diagnoses, I will talk largely for the public sector, because that is where I've been involved for close to around 10 years now. Initially, our role as pathologists was just to say whether some tissue is cancer or not. And then it moved to needing to say the characteristics of the cancer, the grade, the stage, and the typing of this cancer morphologically using the microscope. But then because of progress in availability of different regimens, this need to, as Dr. Melly already said, to identify the snake in the forest so that you don't burn the whole forest. There's need to have markers, and there was need to do immunohistochemistry, and at the moment there are cancers that without immunohistochemistry the diagnosis is not complete. Things like breast cancer, those are metastases of unknown origin, that to just have a morphologic diagnosis is almost as good as not having a diagnosis. You need immunohistochemistry, and I think with the partnership of Roche, Ministry of Health, we began in MTRH doing immunohistochemistry, and I think now is around 7 years. We've been doing a wide panel of immunohistochemistry for all the cancers, lymphomas, breast cancers, sarcomas, and the rest. And we have, of course, the challenge I will share later on is on the financing and the reimbursement. And but then the world is progressing towards more personalized precision oncology, as the radiologist said. There's precision imaging, there's also precision diagnosis. We are moving towards molecular, and the world is moving very, very fast, so that if we don't work very hard in the diagnostics, we'll be left way behind. Recently, there's a lot of need and demand to have molecular testing to identify targets. And just like for immunohistochemistry, at the moment there are tumors that you almost always require molecular testing to be able to treat as an oncologist. Like, for example, lung cancer, colorectal cancer, even breast cancer, and even some ovarian, high-grade serous cancers. So with that, there's been a push towards setting up moleculars, and recently also with collaboration with the team from AstraZeneca, we started doing molecular testing, and we actually been a bit successful doing EGFR testing for lung cancer, but that is just one marker out of 11 that are targetable in lung cancer. So there's still a gap in that thing. So if look at that progress, the challenge, especially from the public sector, is the availability of this diagnosis. For essential routine diagnosis of histology, to say this is cancer or not, you will be surprised that it's around 21% of the counties have in-house histopathology services. 10 out of 47 counties. When you come to immunohistochemistry, I think there are now 3 counties with the news that I had this morning about Kisumu County starting immunohistochemistry. And then for molecular, it's almost 0 point something of the counties. So there's still a lot of need to invest in that region. There are counties that have pathologists, but they don't have equipment. Others have equipment, but they don't have pathologists. And I think there is a challenge there. Thanks.
Thank you for that, Dr. Kibet. And I think that now moves the conversation over to Dr. Kuhora, in charge of planning and linkages. And I think the thing is to think about, and what Dr. Kibet mentioned, it's about financing and reimbursements, and of course positioning SHA as our provider that we have mainly in the public sector. So could you just share with us how SHA is currently supporting reimbursements for cancer diagnostics and where the coverage gaps might be?
Okay, thank you for that, Dr. Just to explain how SHA is supporting this, I would want to support it with some figures. Unfortunately, it's in the afternoon, and most people don't like mathematics in the afternoon. But it's just to show that there is a service need, and we are basically responding to that service need. Now, the oncology benefit was rolled out in 2015-2016, with the main target being alleviating the pain that most patients were going through. Now, when it came to about 2020, 2021, there was a push towards getting value for health. How much more do we get in terms of health for every shilling being spent? And with this, there was a prioritization of 6 non-communicable diseases. And this was explained earlier by the group lead at AMREF, that most donor agencies actually don't consider NCDs as an investment for them. So we prioritized how we approached cancers, how we approached chronic obstructive pulmonary disease and asthma, how we approach diabetes, how we approach sickle cell anemia. It might not be country spread, but when it comes to average cost per patient, it's pretty high. And also how we approached the mental health because of the challenges that were there then. So the financing approach changed. And we had to look at the baselines, exactly where are we coming from, so that we know where we need to put in the money. Now let me give you the perspective of diagnostics. We looked at data from 2017 to 2022, 5 years, a cohort of more than 23,200 patients. And of that cohort, just about 33% had staging done. So basically, more than 60% of the cases that were being managed for cancers, where we were spending about 3 to 4 billion shillings a year, it was based on the presentation, not really a specific diagnosis, not really a specific staging that was done. And that is what necessitated how we approach the diagnostics. The other bit that we looked at is, of these ones which were staged, of the 33% which were staged, what was the staging? Most of these cases, to be specific, 81% were presenting in stage 3 and 4. So that meant that a significant barrier or a significant cost was being met because of when the patient was presenting. And therefore, there was a need to invest in early diagnosis, actually screening and early diagnosis. And even before you get to that, there is public information that needed to go out. How do we communicate to the public on their role when it comes to cancer management? How do we put in more resources when it comes to screening and early diagnosis? How do we make sure that the linkage is there? Because once you do the screening and you don't initiate early optimized treatment, then you're losing patients somewhere in between. Then once you initiate that early optimized treatment, how do you monitor these patients? And that is where the investment for diagnostics comes in. So when you compare 2022 versus now, one of the proposals that has been gazetted is that the country needs to invest in screening, and this screening is largely initiated. It's not a population-based initiative, largely because of the cost implications. We are having discussions with NCI on how that can be converted into a population-based screening over time. But what we are targeting in the initial phases of implementation is targeted screening. Then the next bit is the diagnostics and the staging. And this was rolled out in October last year. And some of the things which were not there before, including histology, are now covered. The others which were not there before are the tumor markers, which my colleague has mentioned. So those two were not initially there, but now they are covered. The other bit is on PET scans. The scope of cover for PET scans was significantly limited, largely because of the facilities which were offering that, and also because of the challenges that were there in terms of access. But with the expanded scope, as has been explained by the presenter earlier, we are actually seeing better outcomes when it comes to early diagnosis and supporting staging. And in the last 10 or so months from the time it started, the authority has spent about 466 million shillings in 15,000 cases that have presented, specifically in costs related to diagnosis. You've asked about coverage gaps. Are we having coverage gaps? The answer is yes. And one of the issues has been alluded to. There are challenges when it comes to infrastructure within the country. And just to put it into perspective is, even if we were to roll out population-based screening for breast cancer, for example, The capacity of the country to actually do the screening for the population that would need that screening is at about 42%. So we still have a gap in terms of the ability to offer that service. Now, from a health financing perspective, I will not call it a gap. I will call it an opportunity. So for the investors within the room, there is money for you to earn if you invest in the diagnostics. And I believe the use of public-private partnerships is one of the ways we can mitigate this gap that we are seeing. The other gap that we are likely to have on the initiation of the screening is that we need to have a reinforced referral framework. Dr. Meli has mentioned that, and one of the ways in which you can do this without it being a significant cost barrier to the patient is by sample networking. And I don't think this is something that will be starting from scratch, because we have seen it working for viral load in HIV. We have seen it working for Gene Expert in TB management programs. It's an issue of how we roll it out when it comes to cancer management. So that's the approach that I would use.
Thank you, and I like that. It's not challenges or gaps, it's opportunities, and I think that creates the Kenyan spirit where we need to make a plan for our patients. And just to bring on Dr. Menge, I know you head the Directorate of Health Products and Technologies. So I think that following Dr. Kuhora's thought, what's the national mandate of the DHPT, and what strategic direction are we taking in terms of improving diagnostics for cancer and other diseases?
Thank you very much, our chair, Njoki. And I think I'm answering the question on behalf of the Ministry of Health, because many people who are seated here feel that the Ministry of Health only meets in conferences and meetings to do various things. But yes, as the Directorate of Health Products and Technologies, we've been given various responsibilities by our mandate, especially in the area of trying to establish regulation and policy in how we perform various activities. As a country, we definitely have priority health needs for the population. And how then do we rationalize that the priority health needs are actually met by the activities that we engage ourselves in? We also know that we have challenges in how facilities access various products that they can be able to use in the various areas, and therefore we have a distinct role in supply chain management and providing technical assistance on how that can be done. What we realize as the ministry is that whereas there's been a lot of strength in the area of medicines and medical supplies, we have been relatively left behind in the area of diagnostics for various reasons. Because diagnostics has been a very, very wide area that possibly there has been no understanding. And from the year 2023, we really took a deliberate decision to start focusing on how can we be able to address the issue of improving access to diagnostics for various reasons. There are certain areas where you'll find that diagnostic capabilities exist way beyond the technical expertise that is within an institution. Yet there are other areas where you have technical expertise that is idle because they do not have the tools to be able to carry out the various diagnostics. And therefore, we set out on a course to be able to balance out what diagnostic capabilities should be made available, what technical expertise should be made available at every level of care, and how that then can we be able to match that with the supplies that are made available in that area. We also have a very important role in stakeholder engagement and collaboration, because there are very many players in the field of diagnostics. Are we able to bring them down to a round table and say that this is the focus of the country, and we wish and desire you to align to the needs of the country, not your personal priority, but can we be able to agree that these are the priority needs of the country, and therefore we are asking you to align. So that has remained our major mandate as a hospital, not as a hospital, but as an institution, but also ensuring that, especially in the emerging areas like cancer, we can be able to specifically address the areas of diagnosis that has been shared by my colleagues. Thank you.
Perfect. Thank you, Dr. Menge. Dr. Tofik, and I know you're here as a Roche Diagnostics GM. However, I will also ask you to wear another hat because there are quite a number of other players in the space. And just to talk about specifically what cancer diagnostics support or access in Kenya, both at technology level and capacity building perspectives, you've been part of, and what you envision as the programs or innovations that may be coming up from that.
Thank you, Dr. Terry. I think the task you've given me is a very good one, because I'll use the opportunity to also tie in what all my esteemed colleagues have mentioned. Essentially, uniting our voices so that we can then now take collective action. There is a nexus between the role that technologies and emerging technologies play in improving the impact on cancer care. Not just from the patient perspective, which is the primary focus, but from the financing aspect that Dr. Kohora has mentioned. Because we've all heard, we are seeing more and more patients in stage 3, stage 4. It takes a lot of finances to address, and the outcomes are always poorer. Surely it makes sense to invest in technologies that can help us to diagnose earlier, or even before that, to even screen. Now, as Roche, and not just as Roche, all the players in the diagnostic space, this is what drives our mission, to bring out innovative technologies that make it easier, quicker, more precise, and ultimately more cost-effective, in that order. But then, as has been mentioned also by Dr. Menge, the best technologies are useless if you don't have the people who have the capabilities to actually utilize this technology. So we have to meet each other somewhere in the middle. And this is the role that we take. And a good example is the recent MOU that we signed with the Ministry of Health, because this tries to capture all the moving parts in the ecosystem around cancer care. For example, we mentioned sample referral. Why is that important? This is critical because the technologies are not everywhere. They are needed everywhere, but it is not cost effective to have them everywhere. Therefore, you have to implement a hub and spoke mechanism where you invest in certain core centers, the technology required, and then invest in sample referral to pool samples there and get results back. Step 1. Step 2, do we have enough of you, oncologists? Do we have enough pathologists in Kenya? The answer is no. So how can we leverage on your expertise to reach as many people as possible? This is where innovations like digital pathology come into play. And this is also embedded in the services that we'll provide. And therefore, yes, as a training tool, yes, as a teleconsulting tool, but on top of that, as a research tool. Why? Because they're getting data. And that data is critical to make informed decisions, prognostic innovations, and so on and so forth. I could go on and on, but I think that in a nutshell, bit from policy to treatment to diagnostics to data and technology and financing, all our voices need to be united so we can all take an action. And I'll stop there. Thank you.
Perfect. Perfect. Dr. Meli, as the CEO for the National Cancer Institute, what do you foresee your role in reducing this fragmentation that we are talking about in the cancer diagnostic space and to improve the coordination? Because I think that's what is lacking. We are quite a number of players, and getting everybody on this orchestra to go on to the same tune, I think the mandate falls to the NCI. So how do you foresee your organization playing into that role?
Good question. It is the reason why we are on the table this afternoon. It is the reason why all of us are seated here. As much as we are on this end, we are in the same classroom. And many of the executors, both from private sector and public, are seated in the audience, having, being part of this discussion, that yes, it is time that, it becomes something of the past to work alone in silos. We have to be more coordinated. We have to avoid any duplication. If we are investing in the space of immunohistochemistry, if you are investing in the space of flow cytometry, if we are in screening, using whichever available technologies in our country that, have been approved to access the market, it should be complementary instead of competition, because that is the only way, we can improve early diagnostics through screening and proper diagnostics through imaging and pathology. So, ladies and gentlemen, we have to sit and talk, together, address one challenge. I know we may have our commercial interests, we may have our personal interests, but the reality is one common challenge that we have is cancer. One common interest that we have is a client. Whether we are preventing or we are treating that person who unfortunately has been diagnosed with cancer, it is never with anyone's choice. Unfortunately, it's like an accident that occurs in our genetic makeup, and any one of us is at risk. So we better work together as a team, sit on the table, discuss, optimize the resources that we have. I know that a lot of our esteemed partners who are here, BD is heavy in diagnostics. We have Roche, we have AstraZeneca, we have MSD, we have Pfizer. We have individual institutions that have invested heavily that are supporting this summit here. We acknowledge all of you, and we are calling to action that let's unite our voices and let's take action together. I'm very certain that if we take stock of these 10 years from today, there's going to be a huge difference, especially when we have now re-looked and thought through our healthcare financing, not only in diagnostics, but comprehensively across the entire continuum of care.
Thank you, Dr. Mali. I know we are short of time, so I would like in 30 seconds, if possible, Dr. Kibet, where do you see clinical leadership guiding this conversation on diagnostics?
Briefly, where I see clinical leadership is, number one, as I mentioned, pathologists and the lab are usually in the background. So behind the scenes, that most of the time our voice is not heard. So the critical role for the team in the clinical or even management is more of advocacy. If the lab cannot do a certain test, how can the clinical team and the clinical leadership team ask the right relevant questions so that resources can actually be prioritized for the purposes of having these tests done? Because most of the time, because when you are in the background and you speak, no one will literally listen to you.
Very true, very true. Dr. Kuhora, are we able to ring fence funding so that diagnostics can continue year in, year out? Because if you don't make the right diagnosis, as an oncologist, my hands are tied to either start the treatment. So are we able to do that?
Thank you. Are we able to do that? My answer is yes. And I'll give the reason why. I think about 5-6 years ago, it was difficult convincing somebody that putting a budget in healthcare is actually investing in the economy. But we have provided data, local data, we call it real world evidence, because this is actually data that has been generated from the Kenyan population, and we are running estimates using the Kenyan GDP, and we can run data over the next 10 years in terms of how much we are likely to save by investing in healthcare. So the discussion around investing is done. Now the discussion now is, are we investing to save, and how much are we saving by investing. And that's where diagnosis comes in. Are we able to ring-fence finances? I think that is a strong proposition, especially when it comes to sustainable financing. And with the outlook as it is, in terms of donor funding, in terms of the cost of healthcare as it is now, in terms of the proportion of the population that can afford healthcare, then domestic resource mobilization is a necessity. And one of the ways of doing that is by ring-fencing resources. How do we get the resources? I will give data that we have used in the last, it's actually projected from the last budget that was read. And we were estimating that if there was a focus on sin taxes are basically on alcohol and tobacco products. And then we look at betting licenses and betting winnings. We look at processed sugars. Then the country is actually able to raise about 26 billion shillings a year from that. So it is something that can be able to be done. Are there countries which have done this? Yes, they are. Are there other mechanisms that can be used? Yes. We have special purpose levies that can be done, and I think Ghana is one of the prototype countries in Africa where this kind of levies have been used specifically to finance healthcare. So they do about 2.5% of some levies on some goods and services, and this is specifically used for healthcare. Then the other bit, and what we have been using over time, are dedicated budgetary allocations. This has been the prototype all along. The only challenge has been what is the percentage. I think with the demonstration that investing in healthcare actually affects all the other sectors, then that should be a reason why we should be lobbying for additional resources, an additional percentage over and above what we've been getting as healthcare. And I think by having this DRM or domestic resource mobilization platform, it is possible to finance what we are looking for.
And I think this conversation, as you can see, we can keep talking about, because I think we're getting solutions to many of the problems that we have. And I'm sure with that RDM, Dr. Menge's EDL can be rolled out, implemented, and of course partnerships with other people like Roche and the other players that we have on the table. So let me thank the panelists. I think you have given us your wisdom, your years of experience have shown and come through. Dr. Melly for explaining to us where the role of the NCI is, and we look forward to seeing a bigger footprint in terms of the diagnostics. Dr. Kibet for bringing your clinical leadership, and I think that is important, that as clinicians we cannot be left as part of the conversation, because we are the ones who are on the end of seeing the patient and we see the impact. Dr. Menge for talking to us at policy level on what we need to do in terms of diagnostics and the direction which the government is taking, and I think that will shape the cancer space for the next year or so. Dr. Kuhora, I think we cannot do anything if somebody is not paying for something. So thank you for always being available, and of course sharing with us where we are looking at finding money. Nobody wants to be told they are being taxed more, but I know for us to pay for diagnostics, the money has to come from somewhere. Dr. Tofik, again, we cannot do this without the PPPs, and I think our key players, especially like at Roche, because you've changed the game space for majority of the cancer diagnostics. So a round of applause to our panelists for that. Thank you very much.
Asanteni sana. And as they make their way to their seats, please let's give them another round of applause. Thank you so much. As they receive their gift packs, asanteni sana. And for this session, the next session, which is our last for day one, I would like us all to stand. Kindly humor me. Please stand. In this room, there are doctors, there are champions, there are caregivers. And I ask us to stand because I don't think we appreciate what the health workforce does for cancer care. Do we appreciate the doctors enough? Do we appreciate the nurses enough? Do we appreciate the caregivers enough? So kindly, let's clap 1, 2, 3 for our healthcare workforce. 1, 2, 3, moja, mbili, tatu, funga, fungua. Please have a seat. And this is the Health Workforce for Cancer Care session. We'll be talking about gaps, growth, and opportunities. And on the stage here, we'll have Professor Frank Wafula. He's a leading authority in health systems and policy in Africa with over 15 years of experience spanning academia, multilateral institutions, and national advisory roles. Karibu sana, Professor Wafula. We'll also have Dr. Wilson Arwasa. He's a seasoned obstetrician, gynecologist, and strategic health systems leader, currently serving as health advisor to the President's Council of Economic Advisors. He has over 23 years of medical practice and 15 years in senior executive roles, including 8 years as CEO of Moi Teaching and Referral Hospital. He brings unmatched expertise in governance, organizational development, and health policy. Tuwapigie makofi wakifika hapa mbele. Our next panelist is Dr. Primus Ochieng. He's the program director, MSc, Radiation Oncology lecturer, Department of Diagnostics and Radiation Medicine from the University of Nairobi. He lectures in the Department of Diagnostic and Radiation Medicine and practices at Kenyatta National Hospital, specializing in advanced radiotherapy and interventional brachytherapy. Let's clap for him. Next is Miss Roslyn Anyango Okumo. She's the President, Oncology Nurses Society of Kenya. She's a seasoned oncology nurse specialist and educator with over 17 years of experience in cancer care, policy, and capacity building. Karibu sana. And finally, Dr. Francisca Ongecha, a consultant psychiatrist and the acting dean, School of Medicine at the Kenyatta University, where she also lectures in the Department of Psychiatry and Mental Health. Karibu sana. And as Dr. Francisca comes to the stage, I remember when O'Brien said, when you're introducing doctors, there are a lot of big words. But when you have experienced cancer, when you have been a caregiver, the words are not so big. They can be familiar, right? Karibuni sana. This session will be led by This session is going to be led by Professor Frank Wafula. Karibu.
Thank you very much. Those were very kind words. Good afternoon. Good afternoon. Wow. Tough crowd. Yeah, but I know it's always difficult later on in the day. So just be of good cheer. Thank you for introducing the panel. We do want to apologize on behalf of one of the panelists who could not travel for various reasons. Yeah, so in front of us we have a fairly elaborate skill set, and also I must add fairly balanced from a gender perspective panel, which is always good to see. And we're going to have a discussion, hopefully, with me only asking a few questions, because I think there's value in getting the people sitting in this room to field some questions as well. But you'll indulge me to just start by asking a few questions. And I'll start with Francisca, my namesake. Yeah, I think it might be helpful if you just start by setting us off, just letting us know what the cancer challenges really are for us as a country from a HRH perspective. What does the challenge actually look like? Because I think we've had through the day challenges across the different dimensions, and from where you sit as a trustee, what do you think are some of the things that we should be doing, or rather some of the things that you're doing towards attenuating this? Thank you.
Thank you very much, Professor Wafula, and good afternoon. Good afternoon, members. Yeah, you know, I have to be aware that I'm with you. I come from the profession of psychiatry, mental health connecting. So as the NCIK and our mandate as per the Act, Cancer Prevention and Control Act of 2012, we are given a huge mandate. And one of the core of our work is people. And this has been sung from morning, that we really need human resource. And therefore, human resource for health in cancer becomes a major component. And unlike many other professions that you may say you don't require too many personnel or different cadres, cancer space is one that requires several cadres of healthcare workers and or what we can call it personnel. For us to be able to manage any patient who has cancer, we require what we call a multidisciplinary team. And there's none of the cadres that is enough, given talk about just the new infections every year, 44,000. We leave the ones who are living with the disease. Then you are looking at our numbers, like around 69 oncologists. What are we talking about? And this is one of the major professionals in the team that now sits together with the others. When we look at the nurses, my friend here will be able to talk much, but how many oncology nurses do we have? What is it that takes us to India? The things that take us to India is actually the care, and requires a big number of nurses. Where I sit again in terms of mental health, human resource for health and cancer is really draining. This is actually a population. The workers, the healthcare workers in the cancer space go through a lot of trauma and pain, a lot of grief with their patients. And again, that would still reduce their potential to be able to be more productive permanently. So you can look at these numbers. So there's a lot of exhaustion. So when you look at the numbers, we have very few numbers. When you talk about under radio imaging, radio oncologists, I don't know whether we've even reached 20 by now. Yeah. So this is one space that where we sit as NCIK is very demanding, and it's talk about multi-sectoral approach to this, having partnerships, and we are glad. I don't know what Roche has that others don't, because it seems to be called everywhere, even when it comes to health personnel training. We've had partnerships with Roche that has really improved the numbers we see. They offer a fellowship program that runs here, that runs and is therefore able to give us quite again an increased number in personnel. We have partnerships with AstraZeneca, again, also to help us build. But then we'll talk about training later, and therefore I think I want to stop at this for this point, but just say that the burden is huge, the gap is big, and again, the training of oncologists, the resources that is required for training. You know, it's not those things that you'll just take a microphone and talk to 800 people and say, I've done a lecture, I'm a teacher. So I know the way some lectures can be given. For oncologists, you require that hands-on with somebody really supervisors. How many do we have who can be able to supervise and also be able to take care of the clients who need care? So we are still far, but as NCIK, we are ready to work, and we are working with partners, we are working with the national government, we are working with training institutions. And one of the things that we are already on course on is trying to get all the medical schools that are training, so that we start training healthcare workers in cancer prevention, treatment, and control. at a pre-service level so that we don't have to wait for super specialization. Why is this necessary? According to the Act, the healthcare service should actually be provided, cancer healthcare service should be provided at the primary healthcare so that we are able to deal with what we say are the main issues: prevention, early detection, and early treatment. If we wait for everybody when they are coming to the referral to review that curriculum to accommodate cancer as a training curriculum, not just that you come and train what you want. So with that, we will be able to ensure that we have all our healthcare workers coming to practice with knowledge on how to prevent and how to detect cancer early. I can tell you that during my training, cancer was not ours. It was for postgraduate training when I was being trained as a doctor. So cancer was not our issue. But today, cancer is our number 3 killer, and therefore we cannot wait for it to be a postgraduate thing, which is happening now. All oncologists are, you just hear a master's. Have you had anybody with a bachelor's in oncology, if anything? No. So we should be thinking of having them, not just having the bachelor, but having the bigger knowledge in undergraduate or in their pre-service training. Thank you.
Thank you very much, Francisca. Again, just to sum that up, you've talked about production challenges. I think you've mentioned labor dynamics as well, employment, and of course you also did talk about exit, which I'll come back to. We are losing some of our staff, which actually is contributing to the problem. Dr. Cheng, if we start at the bottom, at production, why is that still an issue now? All these years since we started training, where are they? I mean, are we not producing enough? What are your thoughts around that?
Thank you so much, Professor Afula, for asking me that very hard question. And what I'll say is that I'll just take you, I hope this will not take you into a deeper hypoglycemic coma, but I'll take you to the history of how cancers actually have evolved in Africa and why we actually haven't managed up to today to have adequate cancer specialists or allied health workers involved in the cancer treatment. Historically, cancer was a disease of the rich and Western world. And so the Africans, cancer was not their disease. Majority of the Africans were therefore the poor and the middle class, and their disease were the infectious disease, the TB, the malaria, and the HIV. And government fundings, NGO fundings, Ministry of Health fundings were all focused at fighting the infectious diseases. And then came HIV. When HIV came, we started seeing cancer coming in. And with HIV, we started seeing patients presenting with Kaposi sarcoma. And that was the first cancer which most Africans started seeing it as a cancer. Cancer, as has already been said, was a disease, and the center were hardly having patients to treat. HIV drew a lot of funding in Africa healthcare, a lot of restructuring, a lot of things were done because it was a real epidemic and it threatened the survival of humanity in Africa. And with that going on, when patients' cancers were controlled, they started seeing patients whose HIV had already been controlled were having things popping on their neck. They thought, oh, TB has come back. And when they looked for the TB, they found it wasn't TB, it was lymphoma. And so we started seeing lymphomas coming. Then followed, many of these patients were women. They already were in their post-menopause. They started bleeding. And they were put on hormones because people that time believed a woman bleeding was because of the hormonal imbalance. And they were put on hormones to control the bleeding. It didn't work. And when they were assessed by the gynecologist, they were found to have cancer cervix. And that was around 2000 thereabouts. At that time, that's when some of us left college. If that time you said you wanted to be an oncologist, people will look at you as if something was terribly wrong with you. The subspecial or the specialization, the postgraduate training at that time was you must be a surgeon, a neurosurgeon for that matter, or you must be a physician, a cardiologist, or an HIV expert for that matter. You have to be a psychiatrist and other specialty. Cancer at that time was a disease for those who die, and any doctor who wanted to take a training in cancer would be seen as a doctor who actually will not have any gratification for the patients because all their patients would die. The treatment was brutal. I would remember that cancer patients at that time were all treated in hospitals through their chemotherapy. And so from the physician or the young doctor's point of view, there was no need for one to specialize. It wouldn't give you any gratifications. Again, government wouldn't give you a grant to go and train. And there were no training centers in sub-Sahara or in the bigger Africa. Most training centers were either in the north or in the south, the rich countries, and the countries who are more the white countries. And therefore, oncologists were not being trained. There goes that if the trainer was to go for training, they would actually probably go abroad. They would get grants which were offered by other organizations, and the training would take very long. It would take 4 years plus. And because of all this, there were no oncologists being trained at that time. And at that time, HIV was being controlled. We were beginning to see more new cancers coming in, and it looked like what actually woke up cancer in Africa was after we controlled the HIV. And so the numbers started going up. And then came, cancer seems not only to be actually that time was getting a surge in Africa alone, but also getting a surge in the developed countries. And those training centers in those countries, in the north and in the south, as life was different from the cities where we came from to Nairobi. And so coming back home, one had to think twice. And those countries actually, the so-called developed countries or the North-South Africa, were also having a very high surge of cancers. And then what did they do? After you train, they try to induce you and encourage you to stay with them and tell you how coming back to Africa, which many people in the North and South see as Congo, is they would tell you it's not safe to go back to the forest. And so even the people who are trained decided to remain back. For example, in Kenya, between 2000 to 2020, we trained about 5 oncologists, and only 3 came back. 2 remained where they were trained. It was lucrative there. And so adding more problem, even the ones who were trained when they came back home, the training in those countries were at another level. When they came back home, they found whatever was available could not meet what they're trained in. And what then happened, one would not cope. And so some opted to go back where they came from or look for jobs elsewhere. All over the world, cancer was becoming a big problem as we are going through about 2010 there. And so the demand for oncologists was very high, and the people who were trained in Africa decided now to remain where they were trained or look for jobs elsewhere where they could be given better salaries. When people came back, those who came back, they became extremely busy. They couldn't sleep. They couldn't meet the needs of the patients because there were just too many patients and there were no oncologists. So all these have significantly contributed to actually Africa training oncologists, and they are not able to meet the demands. And therefore, as we come now in the 20th, from 2020 onward, we have now seen very huge surges in oncology. training became very difficult. Some of the countries thought that they could start training, but they realized training oncology is not training a surgeon. To train a surgeon or to train a physician, you need an hospital. To train an oncologist, you need a comprehensive cancer center. And a comprehensive cancer center for training is different from a comprehensive cancer center for treatment. Currently, some of us involved in the local training, we have a lot of challenges because most of our centers have like one machine, 2 planning systems, old treatment techniques, technologies driving oncology too fast, and the technology is very expensive. And so to meet or set up an oncology training or mount an oncology comprehensive training with an hospital was too expensive for most of our African countries. And so putting all this, we are still struggling to get enough oncologists. Thank you.
Yeah, thank you very much. That was actually quite interesting. You've said things that I never even thought about myself, so I'm sure the audience appreciates that. And I think to almost sum it up, again, you talked about a combination of challenges that stem from, of course, resource issues. There's path dependence restrictions in the training that restricted the potential to start offering this training. Maybe because as a country, sometimes we are tied to the Western model of education, where we want to copy what higher income countries do instead of trying to find a solution. And I think perhaps what Francisca talked about earlier is an innovation towards solving that problem. And then you talk about infrastructure challenges in training an oncologist and the requirement for a comprehensive cancer center. And then you talked about what I think a lot of people know. We had a lot of focus on communicable diseases, and cancer only started becoming of interest when we could draw the links with communicable diseases. So again, we're trapped there. But I think that an interesting thing that you talked about is also just the retention. I mean, if you're going to train people and they're going to stay there or they're going to go, then that remains a big problem. And I know the one thing, Rosalind, that we are really struggling with at the moment is retention, especially of nurses. And I know nurse specialists is a particularly thorny issue. Those of you who may not know, I know most of you do, Kenya has a bilateral labor agreement with a couple of other countries, one of them being the UK. And this is premised on an arranged expatriation of nurses, to start with. And this is based on the fact that WHO actually allows countries that are producing a certain volume of healthcare workers to get into bilateral labor agreements. So Kenya is classified under what is called an amber category. So there is red, amber, and green. Red means you don't have enough to export. Green means you have enough, you can export as many as you want. Philippines and India are probably green. Amber means you have a good number, but it's not enough for open export. It's only enough for government-to-government arrangements that allow expatriation. And so that seemed like a good idea on paper. But Rosalind, we've been losing quite a lot of nurses even outside the bilateral labor agreement. People are going on their own. And our understanding at the Kenya Health Human Resource Advisory Council is that this is actually a very big problem that we are probably understating. So I have two very quick questions for you. One of them is, are we doing something wrong here? Like, are they running away from us? Or are they running towards better practice opportunities and financing opportunities? Or is it a combination of us not treating them well and others just paying them better? How can we reverse this so that we maintain some of our specialists in the country?
Thank you for the good question, and good afternoon, everyone. So in terms of something wrong, are we doing something wrong? Maybe let me start by just talking about oncology nurses, since you have highlighted on it. We have nurses in cancer care, and therefore we have oncology and palliative care. Checking with the Nursing Council, oncology nurses registered by the council are 397, then the palliative care nurses are 125. that gives us a number of 500 trained in oncology and palliative care, where the whole care spectrum is expected to take place. So we still have a gap in terms of that. However, looking in nursing at large, to begin with answering that question, the number of nurses in the country is over 120,000. You realize that we are producing quite a number, and majority of them do not have jobs within. As it is, even the private hospitals are not ready to offer jobs. Some of us during our times, we qualified and they would ask you, so what was your grade overall? And you'd get a job with your result slip. So that does not necessarily happen. So I do not think it is wrong for nurses to go abroad, because even the country is not able to absorb them. However, coming to oncology nursing skills, I have looked at the past when we had some training that was a game changer in our safety issues like ChemoSafe. And some of the nurses we trained during those days that was a period of 2018 to 2020, and there was quite a lot of transformation in terms of chemotherapy and infusion administration amongst the pharmacists and the medical officers and the nurses. And then we've had more continue in the recent past. So if I look back, those great nurses, in just a matter of time now, we just meet on social media. They went. And even as they went, we didn't have more of that, because even those specific subspecialty training are not necessarily available because of funding issues. So in terms of specialty, it's not good to lose them. However, there are reasons why they go. And I know a few of them. Some of the reasons they say is they train so much, and some, for example, do their higher national diploma, some do their masters in oncology, and even beyond. When they come back to work, the leaders who are here, please listen, they are deployed wrongly. The nurse is done with her MSN oncology, and then she's just taken to labor ward. That's a policy issue that I'm hoping will be sorted, because it's being actioned at the DNS, and I'm hoping it will roll down. And then we also have nurses who are burnt out, and burnout is not only for nurses, but it's affecting many healthcare providers. And one of the reasons why there's the burnout is because with the energy and the excitement and you're back to work, then you realize the treatment processes, the delays. You get back and you realize that MRI machine broke down. Then you realize the radiotherapy machine also broke down. Then you realize the medication is also out of stock. And then you realize that the patients have now started crying to you because they can't afford to buy those drugs out of pocket. They can't afford to go to the private sector to get that MRI. They can't afford to do so much on their own. And so you lose some of them because the specific medication or the diagnostics were delayed. And then that happens over time. And then there is the burden of too much pain around somebody when you're losing a number of patients. Even the young children die, and they're not supposed to. So with all that stress, and maybe not a very clear way on how to navigate that pain among the caregivers, some just get burnt out with the care, and they'll just want to leave. And so when they're told that if you go abroad, you know that MRI will be done within 30 minutes. You know that, of course, depends with the country. You'll be told that those medications that are being prescribed and we are writing out of stock in our T-sheets, you will never hear that story. Who doesn't want that? So the burnout because of the systems, and then the burnout because of the workload. The workload is quite a lot. The patients are many because, as you hear, we have 44,000 cases, and then we have 500 oncology nurses, and the same applies to the radio-oncologists and the med-oncs and even the physicists. they are not adequate. So with all that, there's going to be a lot of workload, and that workload in itself would bring burnout. And so when somebody goes through a lot of burnout and they're told that there are mechanisms to handle such systemic issues, then they would definitely want to go. So how then do we need to handle such? We need to ensure that the basics that are available as policy makers, as leaders, are available so that the healthcare workers does not have to keep thinking of other things. However, as the healthcare worker, should you find that maybe you are a young doctor, a young nurse in a certain situation, and there's some contribution you are able to give, for example, you realize that people are just slow, and you get a chance, please be the advocate, ensure that things are happening correctly. You realize that maybe there was just a delay at the CT scan for no reason, and the patient is in the ward, and you happen to be the team leader, call the radiology department and say, we have this patient, we need this done now, so that you also feel you are contributing. Just don't sit and say, I can't do anything. So think of what you can do in your own and be able to do it in terms of the systemic. Then in terms of personal health, you know, when you're burnt out, sometimes getting to that environment really is traumatizing. So maybe the nurse at the infusion center with a lot of stresses, they want to get in and get out very quickly. But that cannot happen because the volumes are high. So the healthcare workers need to work on their well-being. On their well-being, if there's anything that excites you, beside coming to the hospital, beside the regular work, get into it. If you like going to the gym, like some of my good friends here, just get to the gym. And some of you who would want to try something new, like for me, one of the things that kept me going is I was in the clinical, but I would try to balance with trying something new. Like I would volunteer to the cancer program just to contribute into the development of the guidelines. So I would feel that, yes, we have a challenge here, but I've been able to contribute even at a higher scope. So if that makes you happy, go for it. If you think that the knowledge, so much is happening in cancer space, a lot of learning is required. Every day you get a new medication. Every day you get to hear lots in diagnostics. Go for it and educate yourself. And if you get a chance, join forums like this ones and learn, network, and you just realize that you go back and re-energize. So this requires somebody to get to know what excites them, what re-energizes them, and then they go for it. So if you're able to handle the burnout, then you'll probably not be in a hurry to run. However, the equipment need to be there. Then another thing that has made many people go out is the cost of living. Life has become so expensive. If you think of everything and it's just too expensive, then you think of your package and it's not good enough, who would not want to go out for a better package? I'm sure a majority of us would want to if that opportunity even came today. So the recognition of somebody's work. Somebody is doing a lot of work, at least internationally there is the per hour payment. Right in our system, you can even go up to 7 or 8 p.m. As an outpatient caregiver, and there's nothing that happens in terms of remuneration. So good remuneration is key to sustaining healthcare workers within the country, and our entry packages are good enough, and you'll be able to retain the staff. However, in terms of, again, the exit, it's not necessarily exit to abroad. Some are also just tired of being within, and therefore they change. They just want to leave that cancer space and go to do something totally different. Somebody wants to go and do certain businesses that are really off. So one of the things that would be important is good leadership within the clinical setup, so that you recognize that healthcare workers are going through stressful situations and ask them what would work. In hospitals, like for example, the level 6, you realize the hospital has a lot of options. There's the inpatient care, there's the adult inpatient, there's the pediatric, there's the infusion commonly called as chemotherapy. There's the radio palliative navigation. So we can be kind enough to try and find out where would this healthcare worker fit best.
Yeah.
Now the field's trained on the chemo. What else would work? So let's try and ensure that we give them a chance to try and explore and ensure that there's good working relationship, open communication amongst staff, and just good teamwork. Teamwork would help. Thank you so much.
Thank you very much, Rosalind. That was quite a lot of very useful information. Dr. Ruasa, welcome. I was expecting you, so I didn't present your apologies, and I'm glad that you're here. I will have you coming in, give you a bit of time to breathe, and maybe I'll have you say something as we wrap up. But maybe just to open up, to the audience, and particularly looking at solutions rather than challenges. Are there any innovations that we are missing when it comes to, strengthening the health workforce management, retention, production in Kenya? Not just the Cancer Institute, but the body I chair, which is a very new and young state corporation. We are trying to find solutions on how we can also optimize these healthcare workers and get the best out of them, even as we, hit the ground. So anyone with anything that is perhaps worth sharing in this type of forum, just feel free to raise your hand and someone will come to you. Okay, as they're thinking through these, and I'm told we're actually out of time, the clock ahead of us is a bit misleading. Dr. Ruasa, I am sure you've had time to catch your breath. I know you have a lot of experience also having led a fairly large hospital through these. As we head toward, now we are thinking about solutions rather than, more problems. Any suggestions you can in terms of how, managers, leaders in this room and the system can actually optimize the health workforce, retain them better, and provide cancer services better at that level?
Okay, thank you, Prof, and I really apologize for coming late, but it had to do with many factors, including the accessibility of the venue. But nonetheless, from what I gathered from Dr. Meli, the CEO and his team, and also from you, Prof, is that we have had very good discussions since the symposium was opened in the morning, I think by the Prime Cabinet Secretary and the Health CS. And mine is to join in, really, just to share some suggestions on how we can move forward in terms of this space of it's actually a triple burden, but more so we are looking at cancer now, without forgetting the communicable diseases, without forgetting other diseases like malaria and the rest, which still are a big challenge to this country. And looking at it from a health system perspective, Prof, is that cancer is now a major challenge. I saw the statistics that were shared by the CEO and the teams earlier in the day, which put, I think, cancer to be the third largest cause of morbidity in the country. And therefore, if you look at it in terms of resources also, you want to look at it in terms of human resources for health, the health workforce, is it commensurate? And the answer is no. And if you look at it, and it's not only cancer, you have to look at it from how much this country spends on health relative to the rest of the sectors. The total health expenditure, THE, which is about 550 billion in a year, going to various things. HRH takes about 40% of that as of today. And the numbers that we have is not enough, certainly, because if you look at it relative to the medical officer as the unit of measure, and you look at all the other cadres, we do not have enough health workforce for the needs of the population. And I was looking at the projections that by 2030, we should be having about almost 340,000 workers. There is going to be a shortage of almost 100 and something, almost 200,000. By 2035, we should be having a total of about 500,000 health workers, and we are going to have a shortage of almost 250 workers. So if we are to invest so that we can cover this shortfall, and the investment is not only by the government, in fact, the private sector should be enabled to invest. We need to invest, including for the health workers who are already there. We need to invest by 2035. We need to double the number of the workers. That means also doubling the number of oncologists, doubling the number of oncology nurses, doubling the number of RTTs and everybody in that space by 2035. So if today, from your data, Dr. Meli, I think you talk about almost 50-something oncologists in the whole country, we need to reach 100 plus in the next 10 years or less. And the investments financially to sustain the health workers who are in place plus the additional ones, which is going to double, we need about $5 million to be able to keep everybody in their roles. And that requires an investment relative to the GDP that is going to be at least 10%. And if you look at the data, and I'm sure this has been discussed from particularly the counties, what we have noticed is that the counties' investments or wage bill has shrunk, actually relatively since devolution. So the counties, I'm sure, are represented here. For me, my message is to the counties, you have a lot of work to do in investing in the human resources. Let's not cheat ourselves that we will make it alone as a national government. The private sector has done very well, except during the COVID pandemic and around that time. The private sector, actually, if you look at medical officers, they employ 60% of the medical officers. They employ same number of specialists as a percentage. The government employing the rest. Nurses are the ones that the government employs the most. 80% of the nurses who are in employment are in the public sector. So the private sector can do better, because I wonder, the most common cadre should be nurses. So I don't know how the private sector is managing with only 20% of the stock of nurses in the country being in the private sector. There is some work for the private sector there, but I want to laud the private sector because overall, if you look at the health labor market accounts, the private sector actually employment rate has risen by 7% overall in the last 10 years, while in the public sector it has only risen by 4%. So for me, I laud the private sector, and there is something good that is happening there that we can learn from the private sector. And the relative inertia in the public has to do with the counties. It's not the national government. So that is the challenge that I want to pose today.
Just one innovation and one solution to deal with these issues as we wrap up.
Definitely, if we are talking about numbers, we have to start from production, from the training. We must continue to train, and we should not fear. If you are doing infrastructure, you must also do training. Why we have Dr. Meli today, ladies and gentlemen, is that when we decided in MTRH to do the cancer center, we sent Dr. Meli to go and train. And many others we sent. And by the time the infrastructure was coming into being, they were also coming back. And they gave us ideas on how to manage the cancer services. And MTRH is a good example of how to invest without fearing. You have to be bold, because the numbers I'm talking about are not small numbers. But also, if you look at the 6 pathways that health leads to improved economic productivity of a country, we do not have a choice but to invest in that. And another thing is to work closely, a lot of partnerships, particularly locally. I used to tell MTRH there is no way we can talk of partnering with people from outside the country if we have not partnered with Mo University, if we have not partnered with KMTC, because the solutions are there. So if you train collectively, and I'm aware that the program has started in Moi of oncology, MED in oncology, In University of Nairobi, it has also started gynecology, oncology, more university the same. Those partnerships are the way to go because we do not have adequate resources all the time.
Okay, so you've actually given me 2 innovations. One of them is start investing, and don't just invest in infrastructure, invest in people, and we're given Dr. Meli as an example, who's now leading the Cancer Institute. I think that's a success story. And the other is we actually need to think about partnerships, and this includes public-private partnerships, but also figuring out how to optimize the human resources. Now, I really did want somebody to say something from the...
Prof, is that you cannot invest on human resource alone. You must invest on the entire spectrum.
The entire spectrum.
The infrastructure, the leadership. I heard somebody mentioning leadership as I was coming in, and I was really excited.
Yes.
The leadership, the essential
the
medicines.
Commodities and
if you look at the SDGs, at least 3 SDGs talk about NCDs, including vaccines for NCDs, medicines for NCDs, HR for NCDs, everything in between.
Okay, thank you for that. But the audience might be a bit tired. It's been a very long day, so I didn't get any inputs on that. I think that's fine. I think we're out of time, Washirima, if I understand anyway. So, allow me to, I would have actually, wanted us to distill on the solutions a bit more. But if you can just have 1 minute for each panelist to give me one innovation from their space, and then we wrap it up. So that is 5 minutes that we are taking. Then that would actually allow us to just close just one solution in less than a minute that you think could work. Nothing longer than that. Starting with Francisco.
Thank you. One solution. I'm a teacher, so I follow instructions. Have the counties ring-fence some little money for human resource for health and bind the workers to come back. Because as NCIK, as the national government, we are putting regional centers, but we want them to serve people. That's my one solution.
Thank you very much. Rosalind? I think, Orwasa, you did give us yours, unless another one has come in your mind. Okay, all right. Rosalind and then Orwasa.
Thank you. I would go back to early detection, and I would want us to empower nurses and primary healthcare providers to be in a position to do screen and treat, so that like cervical cancer, we manage them at that early stage, and then we'll reduce the overburdening of the healthcare system. Then I would want us to do task shifting. So let's work in the multidisciplinary groups and see which tasks can go to what cadres as we continue training. Thank you.
Thank you very much, Rosalind. Arwasa, in 30 seconds.
Thank you, Prof. We must, just for emphasis, we must invest real money. That is very, very important. That's number one and number one. But number 2, what I wanted to add also is the productivity. I don't know if you had discussed it, but even of the current workforce, if you look at the productivity analysis that we have done with WHO, it shows that the urban counties are not doing well. The staff are not available at work. That's what it means. Taking outpatient coverage of services as a unit, how many patients each nurse attends to, how many patients each doctor attends to. And therefore, we must relook at it so that overall, the productivity in Siaya is the best, but Nairobi is the worst. Yet Nairobi has the largest number of health workers. So it tells us a story that even the health workers that we have not reached the optimum. The leadership and governance has to do something about it. We have to push to the limits even as we invest more resources in this. Thank you.
Okay, thank you very much. Daktari?
I think as a trainer, what I will advocate for is curriculum innovation. Let all the healthcare workers be trained in oncology, so that currently you go to a hospital, if you have a cancer and the doctor sitting in front of you is not an oncologist, you are booked to see the oncologist.
There you have it. Let's actually ring-fence real money. Let's support the counties, provide the framework that allow them to ring-fence funds for training and encouraging staff to come back when they're done. Let's optimize all our human resources for health. Let's avoid the Western model where we over-specialize and restrict very specific people to specific tasks so that more people can support the process. And last but not least, let's show our commitment to this cause as Kenyans by ensuring that wherever we are, whatever we do, I know we have a lot of managers and leaders here, nothing beats good leadership and governance within our institutions. So join me in giving a hand to the team that is sitting here as we come to the end. Thank you very much.
Thank you so much. That session was led by Professor Frank Wafula. He says he was with his nickname, namesake. Jameni, kizungu imekuwa ngumu. Dr. Francisca Ongecha, asanteni sana. Dr. Wilson Naruasa, Presidential Advisor. Professor Kamarogo was not with us today. Roslyn Okumu and Dr. Primus Ochieng. Thank you for the history that you gave us. I was listening very keenly. Kindly let's take our seats. Asante. Tuwapigie makofi.
Thank you very much. Asante. And of course, as they take their seats, they are presented with the gift hamper. Ladies and gentlemen, it's now coming to 5 minutes to 5 o'clock. I must admit that you've been phenomenal. I've moderated many meetings, but I've never seen a situation whereby the meeting is still full when you're closing down, or when the curtains are being closed. This one is very, very special. I don't know whether it's because the conversations are very engaging. They touch on our health. The conversation speaks to us, but you people, you've been very, very, very attentive. And of course, up to this point, the hall is almost full. I think this is a pointer of things to come tomorrow and the day thereafter.
And I think it's more about passion. Everyone who's come on stage today is passionate about what they do when it comes to cancer care, ring fencing, the funding that we need. And I think that's a very encouraging place to be during the second National Cancer Summit, where we are saying we are uniting our voices and taking action. Let's say it again. We are uniting our voices
and taking action. And I also think there's also something with doctors, because, I mean, if you don't listen to doctors, who are you going to listen to? Okay? So we appreciate you. Thank you so very much indeed for being so kind and being around. Remember, tomorrow we're kicking off at exactly 9 in the a.m., all right? And we're going to have various conversations taking place at the same time. Tomorrow morning, we are going to give you a proper breakdown of which hall will be hosting which meeting. Today, it has been beautiful, joined by our distinguished guest, and of course, sharing beautiful, beautiful stories. We look forward to more of these. I am being informed that we are coming to the tail end of this conversation for today, and to access the tea, you have to use this door. All the other doors are going to be closed. So we are going to use this door, and then you turn to your right, and then to your right again to access the exhibition hall. From there, you can proceed to have your tea, to have your coffee, or even to have your latte.
And there's definitely one thing that the CEO, Dr. Elias Meli, has been worried about, that throughout the day we have not given the audience a moment to ask a question or contribute. Please be sure that tomorrow we will have breakout sessions in the afternoon, and come with all your questions, come with all your comments, come with all your contributions. We will have that tomorrow afternoon in the breakout sessions. I am also informed that all partners will be meeting with the CS shortly, in the next few minutes, on the first floor. So all partners kindly proceed to the first floor, where there will be a meeting with the CS.
Very good. I think at this point we don't want to add anything more. I want us to do nyayo clapping. Si tunaikumbuka ile afunga. Okay, so let's be upstanding. so that we can clap for each and every one of us who has made this day possible and successful, from our sign language interpreters to our technicians, to the hotel, to the organizers, to NCIK, everyone who made this meeting possible, to Mashirima Kapombe, and of course to me, O'Brien Kimani. So, do you want to lead us? I saw you are very good. Were you there, wakati wa Moi? Because you did it very well. Let's see how you do it.
Let's do it the same way we did it the first time, right? Ama hiyo imewabo. Ni kama wameboeka na hiyo. They've already done it before. Let's do another one. Ile ya maua. Da! Sawa sawa. Are you ready? Maua.
Last.
Ya pili maua. Ya tatu maua. Asanteni sana.
Thank you very much. Have yourself a beautiful evening. See you tomorrow.
Kwaherini.
Wazawo media, nipe muda, amini kwako lazima nitakuja, staki nije shingo pande, nataka nije mazima, na najua wendo umenipa ndo uzima na